Good morning, friends. Welcome to another exciting day of this bright, and I hope you've enjoyed the last 2 days just as much as we did. Uh, so today we have a long day again with very important topics, and I hope that you stay tuned and make maximum use of this day. Please put your questions on the chat box, and we will take them with the examiners and the speakers after their respective talks. Couple of housekeeping announcements. One is you need to fill your feedback form before you get the certificates. We have got 4 credit points from the MMC. Uh, we've just released the book Infectious Diseases in Critical Care yesterday on this BRITE platform, and uh, I'm pretty happy to announce that the publishers and the editors have actually got a very discounted cost for the book. So please pre-book your infectious disease book on this platform, and the book will be posted by the publisher directly to you, maybe in a month's time. You can also book the bright case based review book, which is again a very good book for the exam going students, and you can book this here on this platform, again at a very discounted rate. So please go ahead and do that. The other thing is, yesterday we missed the talk on ventilator associated pneumonia because of some technical reasons, but we will be having that today. So stay tuned for that. That talk will be done today. So you stay logged in for it. Again, as I said, we have a pretty eminent speaker with us to kickstart this day, and I have Dr. Ram Suban, who's a dear friend. He is a senior consultant at Apollo Gleneagles Hospital, Calcutta, and we've always been fond of listening to Dr. Suresh, and we all know that yeah, he's such a passionate teacher. So he will be speaking on a very important topic, that is subarachnoid hemorrhage and management. And I would like to invite Dr. Suresh Ramsuban um, to take over. Dr. Suresh, over to you.
Good morning, everybody. It's a pleasure to be here for this web-based conference this year, as we are all in the middle of epidemic. So this is the way it goes. All right, the topic that I've been asked to speak on is subarachnoid hemorrhage. Let me just put it into slideshow so that. Alrighty, here we go. And this is, as you know, on this conference, and this theme is based on a case-based approach, so that we build up the scenarios, and the next question automatically follows, and we expect people to be aware of how to think about it. So obviously, it would have been much better if we had been interacting and doing it together in a face-to-face situation, but we have to get the best out of the situation. So what I'm going to try is try to pose questions and then obviously answer them myself, and you can follow along with the story as it goes. So I've just taken this from the vignette that we wrote in the book. So this is a 78-year-old female, 74-year-old female who's hypertensive on irregular treatment. Has a severe headache, you can almost say a thunderclap headache, vomiting and loss of consciousness. Her heart rate is 46 per minute. She's in sinus rhythm. Blood pressure is 210 or slash 140 millimeter of mercury. Right side pupil is dilated and fixed, where the left side pupil is not reacting to light but normal in size. She's not responding to painful stimuli. And obviously, so when we present a case, we present a case vignette like this in either any of the exams or in life when you're facing a patient in the emergency. The question is, why is she unresponsive, and what is happening to her, and how are you going to manage it? So the question goes, how will you assess this patient? So obviously the lady is presented with headache, classical thunderclap, nausea, vomiting, loss of consciousness. So she's presenting with an impaired responsiveness at that person's particular point, and this is an acute life-threatening emergency that requires prompt intervention to preserve both life, and if you herniate more, you're going to die, and obviously brain function. The faster you recover whatever is the brain left, it will be better for her. So what we see in this patient in the vignette is that she is in a state of unarousable unresponsiveness, which is what we define as coma. So the first thing that we pick up when we see a patient like this, irrespective of what is the etiology of the coma, so this patient might have had a any catastrophe intracerebral. We are understanding that it's an intracerebral catastrophe by the physical examination and by pupils. Otherwise, if you were to not to be given that vignette, it would just be a coma, and that could be a medical coma and a surgery and an intracerebral coma. So that is the kind of distinction that we are looking at. So here we are looking at in this patient in the vignette, it's obvious that it's an intracerebral catastrophe that has led to the coma, but we still don't know what the intracerebral catastrophe is. He can have a brain tumor within him that has bled. He can have an ICH, he can have a subarachnoid hemorrhage. So at this point in time, so don't let's not jump into any management of the headache and so it has to be a subarachnoid. It need not be. So obviously, this is at this point in time when we say how do you want to assess this patient? We say we want to assess this patient who's in coma. And how do we assess how the patient is in coma? So to understand that, and what is obviously when you say that it's a neurological or intracerebral cause of a catastrophe that is responsible for it, we need to understand that the function of the alertness is basically maintained by the reticular activating system, which originates in the upper pons and the brains and the midbrain, and from there it projects to the thalamus, and from there to the bilateral cerebral hemisphere. So for a patient to be unresponsive, in an unarousable unresponsiveness, the lesion has to be somewhere in these four locations. That means it has to be in the upper midbrain or the upper pons and up midbrain, or it has to be in the diencephalon, or it has to be in bilateral cerebral hemisphere. So that is the fundamental thing, that a small ischemic stroke on one side of this thing will not cause this problem of coma. So when you have a coma, you have to have a lesion which can be explained, which has to be in these kind of areas. So, and that is where bilateral cerebral lesions, a diencephalic lesion, or a upper pons and a midbrain lesion has to be there. So when we are assessing this patient, as I said, the coma is medical or neurological disease, and obviously the list of diseases causing coma is extremely large. If somebody is in shock, he's going to be comatose. Blood pressure is 40, he's not going to be responsive. So we need to have obviously a brief history, a brief physical examination, a general examination, that is what's his blood pressure, what's his pulse rate like, and a pertinent neurological examination. So if you have a non-focal neurological examination, then it becomes a medical cause of coma, and then we can work it up as a medical cause. Well, if it's a neurological examination shows certain positive findings, then the priority is obviously to find out what is happening with the brain. All right. So neurological examination. Obviously, to talk about general brief history, we need to find out the time course and how did it happen, what was the patient, how long ago did it happen, what was the patient's premorbid status, and so on. And general examination is generally focused towards identifying the Cushing's triad, as we did in this patient. If the patient is hypertensive, bradycardic, you know that the patient probably has a raised in ICP as a cause of the coma. So this is what we need. When we talk about pertinent neurological examination, we're talking about three things: a level of consciousness, motor response, and brainstem response. Again, level of consciousness is important because otherwise people will say it's stupor, obtundation, drowsy, lethargy. There's so many terms that comes into play, and it kind of confuses the issue. And somebody says, oh, the patient was stuporous, and then somebody says coma, and the patient family says, oh, nobody told me that my patient is comatose. So there's a lot of issues with these terms. So that's why it's very important to describe patients' spontaneous behavior and response to stimulation as to assess his level. These two things is what you're trying to describe to assess his level of consciousness. To do that, so we commonly use the Glasgow Coma Scale, which I'm not going to go in detail. We are all aware of it, and it basically helps in assessing the depth of impaired consciousness. And wonderfully, it's stood the test of time, not only from trauma. It's been very useful in traumatic brain injury, subarachnoid hemorrhage, and meningitis. To say, though not useful in cannot be extrapolated to others, but somehow we have managed to use this as a good means of communication between providers as to the what is the scale of depth of impaired consciousness. So to say what is the response to stimuli and what is their spontaneous behavior. Obviously, there's one the better scores available like the 4 score, which is a full outline of unresponsiveness. It is an alternative score to assess consciousness. It's better than GCS because it can be used in ventilated patients, and it includes the respiratory pattern and brainstem reflexes separately, and probably gives us a better idea as to what's happening. Unfortunately, it hasn't passed the test of time. And the as I said, if your old is gold, if your GCS works well, people haven't changed, and that's why this is not really caught on. Though for an intubated ventilated patient, this is probably makes more sense to do it things with a full outline of unresponsiveness score. Right. So, in a more the second part of the neurological examination after assessing the level of consciousness is whether the patient is in coma and how deep the coma is. We look for focal defects, and most importantly, we look for posturing. So, if somebody is doing this or decerebrate or decorticate posturing, they are important indicators of raised ICP. So, the focused physical examination from a critical care perspective is a quick, you give a painful stimuli and see whether they're not responsive, and then are they posturing or not. And this part of the when we're assessing the GCS itself, we know they're posturing or not. The last is the brainstem response. You want to see the pupils, and in this case vignette we have shown that there's an unequal pupil. Obviously, we should be documenting whether the patient is, if both pupils are dilated, we would be like to see the doll's eye, corneal, gag, cough reflex to just complete the brainstem response. Are they breathing above the vent, and so on and so forth. All right, so continuing with the case, it's obvious that GCS of what we could notice was E1M1V1. That means she was not responsive at all, and she's the deepest possible coma, and pupils are asymmetrical, and vital sign demonstrate Cushing's triad. So now when we assess this patient's assessment takes a turn. It is not only coma that we are worried about right now here, that the patient is unarousable, unresponsiveness, but there are also signs of catastrophic things happening inside the brain, which has led to the coma, but has also led to a consequence of the intracerebral catastrophe, and that is raised intracerebral pressure and herniation syndromes. So that is the assessment that we should pick up when the vignette like this is presented. Yes, the patient is comatose because he's unarousable, his GCS is 3, and that's a deep coma, but also in addition to the coma, the patient has got a raised intracranial pressure. And more importantly, not only is there evidence of raised intracranial pressure, but there are signs of brain tissue displacement and herniation syndrome, which we can find out from unequal pupil and so forth. And remember, at this point in time, there's been no CT scan done, nothing has been done, but we are able to assess that there is a intracerebral catastrophe that has happened, and it is something which we need to be able to identify. So when we talk about raised ICP, the causes can be both within the brain, can be outside the brain. We always talk about hypercarbia, hypoxia, all these things, hypertension, hyperpyrexia, seizures. Drugs like tetracycline have been known to cause raised ICP, idiopathic hypertension, intracranial hypertension. But more importantly, from an acute situation, is generally the intracranial causes, especially the non-traumatic intracerebral hemorrhage, trauma, ischemic stroke, hydrocephalus, and any possible, as I said, intracerebral catastrophe, including subarachnoid hemorrhage. So there is definitely, these are the causes of a raised intracranial pressure. So whenever there's a raised intracranial pressure, the Monro-Kelly hypothesis comes into play. We need to understand that there are only 3 things in the brain. There's brain matter, there's blood vessels, and there's CSF. So once the brain matter is occupied by blood, the blood vessels the CSF shrinks. Once the CSF cannot shrink, the blood vessel shrinks. And once the blood vessel shrinks, the blood volume falls down, and as a result of which the compliance curve between the intracranial volume and ICP is that the brain can accommodate a large amount of volume, a little bit, not a large, but a little bit of volume before the ICP rises. But when it meets that critical threshold where the intracranial volume exceeds just marginally more than what it is, the ICP shoots up, and that's a very thin line that we are traversing here, and that's what is going to cause a problem. So as I said, the volume. This is called a Langford curve, which shows the demonstration of ICP and intracranial volume. And this is the intracranial volume. A marginal increase in intracranial volume will shoot up your ICP tremendously as the pressure, as the volume increases inside it. As a result, the purpose of this, the ICP, is to understand the concept of ICP, is that how, as the ICP increases, the brain, as I said, the first is the volume of CSF decreases, and then the cerebral blood flow adjusts. And the cerebral blood flow adjusts, very well. But irrespective of what happens to cerebral perfusion, the brain, before it gets affected, has got a wonderful auto regulation. So irrespective of what is the blood flow, whatever is happening, you will still be able to maintain a cerebral perfusion pressure between a wide range of pressure between 175 millimeter and about 55 millimeter of mercury. So it's only when these mean arterial pressure drops below 55 or goes be about 180 that we have problems in cerebral blood flow, and cerebral perfusion blood flow will happen. But this auto-regulation of cerebral blood flow, this standard curve that we're used to seeing, this S-shaped curve, also gets dysregulated when you have an intracerebral event. So you don't have the protective thing. So the cerebral blood flow is no longer protected by the auto-regulation that happens in damage, in the presence of a damaged brain. What's happening? So a question that is put forward: yes, we were able to recognize the fact that this patient is comatose and this patient has a raised ICP because of certain things in the case vein itself. We didn't even really need to have move forward. But how do you actually diagnose ICP raised elevated? Yes, it is the symptomatology. Obviously, is a clinical diagnosis which we already established. But the question that we ask at this point in how do we diagnose is the fact that what are the confirmatory tests, or how can you confirm that the ICP is raised? And still remember, still we haven't done a CT scan, and still we are not there. So we are not even reached that issue. Right now the issue is that the patient has a clinical evidence of raised ICP and herniation syndrome. So the diagnosis of raised ICP, like systemic hypertension, you need to confirm it by measuring it. And the best ICP would measure would be to place a pressure transmitting or sensing device in the cranial cavity. Unfortunately, the ICP monitoring has not been shown to improve outcomes. Even in a recent study with traumatic brain injury, to focus with an ICP less than 20 was not shown to be superior to care based on imaging and clinical examination. So measuring ICP is unfortunately not a great, it's not a very usual clinical practice in majority of the settings outside of a well-established academic center with neurosurgical facilities, where we do routine ICP monitoring. In certain situations, yes, everybody does it, but not in a routine situation. So how do you diagnose ICP? The answer eventually still remains clinical science. But remember, the clinical signs of raised ICP will be much later, that is after the tissue herniation has happened. So this is always a caveat, is that if you use ICP, you're going to have that. Just for curiosity, you guys have to know this, that when you look at ICP, it's not only the number of 20, but it's also when you're doing, especially when you're doing long monitoring with a drain, with a subarachnoid bolt, or with a intraparenchymal bolt, or with a EVD. You need to know that there is got to be, when you look at the ICP waveform, you're looking at the waveform like the percussion wave. The P2 is the tidal wave, and the P3 is the dichrotic wave. This is the classical three humps that you see in the presence of a in the ICP waveform tracing. And so when you're doing this waveform analysis, again, you have to understand that this is going to occur the same. The way you know that your waveform is correct is that the frequency is going to be the same as the heart rate, and they correspond to the transmitted arterial pressure variation. And at all peak waves will tell you that the compliance is shifting. The compliance of the Langfeld curve is shifting to the right. And you get these Lundberg A waves where there is abnormal plateau waves lasting for 5 to 10 minutes with pressures of as high as 100 millimeters. And they are a much better a way of telling you that the ICP is going to be elevated, rather than actually just looking at the numbers, or actually just looking at the waveform also in one way. So it's the Lundberg A waves, the looking at the peaking of the percussion wave, as well as the number. All these three things are the gold standard of diagnosing a raised ICP. All right. The other thing which we're doing much more nowadays is obviously transcranial Doppler. Again, elevated blood flow and PI, that is pulsatility index, may be used to estimate ICP. And the ICP correlates well with blood flow velocity and a relationship between intracranial compliance, intracranial pressure, cerebral perfusion pressure, and pulsatility index is there, and this is something, so it correlates well. So whenever if your normal values of pulsatility index is between zero point 0.5 to 0 point 0.9, and when it goes up to 1.19, you can the ICP may not be raised clinically. So this is why it is important to do these things as a measure of true measure of ICP, especially when we have a high risk patient who has a potential of getting into a brainstem herniation or a compression of the brain as a result of it. So obviously, so once in this situation, as we said, we have reached the situation where we just looking at the vignette, we knew that this patient is comatose, has got a catastrophic process, has got raised ICP. The question that will automatically follow in the exam is how do you manage the ICP, or in life it follows the question how are we going to manage this patient. So here it's going to be A, B, C, D. ABC is the standard answer for all critical care emergencies, and this is no different. Only thing is here is a D, where decompression of the pressure or identifying the disability becomes an important role to prevent the herniation from happening. In this case, we need herniation has already happened, and the horse is already bolted out of the barn. So maybe not very important, but yes, it should be part of the process. All right, so ABC, just quickly going through it, I'm not going to stress on it. You need to pre-oxygenate, a rapid sequence, short acting drugs. You get the head down only just before you're ready to, when everything is ready, not keep the head down and back for 10 minutes while you're getting things ready, which is what we normally do in the medical ICU. And then immediately after intubation, you again get the head end of bed. Make sure the map is always more than 80. Don't put secure tight neck bands around the ET tube to secure it, and maintain a PCO2 of 35 to 40 and a PO2 of about 100 millimeter of mercury after intubation. Then once you got the A and B secured in a patient, and you were able to get the PCO2 down to 35 to 40 and get the pH up to a PO to about 100, then you do an assessment of the what is the etiology of this raised ICP, and you go ahead and get an emergency CT. And the CT will now show you that there is, in this patient, as it showed, was a diffuse subarachnoid hemorrhage, and as a result of which now you know that the patient has got three diagnoses, has got a subarachnoid hemorrhage leading to coma and leading to raised intracranial pressure. So now obviously the management of coma is to recognize the cause and treat the cause. Now that you have a cause and a subarachnoid hemorrhage, and the other is to the complication of subarachnoid of the fact why the patient is in coma, because the coma is because of the raised ICP, which is causing the reticular activating system not to function well. So once we know the cause, then we need to treat the cause and treat the underlying pathophysiology. So obviously the underlying pathophysiology needs to be treated first, and the underlying cause obviously needs to be treated simultaneously. So how do we treat the ICP is the next question. So stepwise you need to manage it. So these are the steps. CSF drainage is the first thing, sedations, cerebral perfusion pressure optimization, hyperosmolar therapy, hyperventilation, barbiturate, coma, and hypothermia. So CSF drainage is a life-saving procedure. The advantage of doing an EVD is that it gives you a rapid decompression, and the same thing is you can actually manage it. In this vignette that we presented and the CT scan that you see, there's not much of a ventricular dilatation, so it's really difficult to do it. And unless you want to monitor the ICP, and as I said, it's not usual clinical practice in most of the centers. But this patient may be in a good candidate for doing ICP monitoring, because the patient has got a deep coma, but unfortunately herniation has already actually happened, so the benefit may not be that much before for you to do it. So if the patient had been in a situation where herniation has not happened but was in coma, maybe it would have been a useful situation. So all right, sedation, again, pain and agitation should be controlled. Use short acting like fentanyl and propofol, and this agitation leads to increased ICP, so you need to prevent that from happening. CPP optimization, there is cerebral perfusion prevention. Two concepts, the Lund concept and the Rosner concept. We talk about the Rosner concept, where you give a large volume of fluid, you get systemic vasopressors, you drain the CSF, you do everything to elevate the mean arterial pressure and to decrease the ICP, but you don't use measures to decrease ICP, such as barbiturate, hypoventilation, hypothermia. But when you just basically try to get the map up more preferentially. But when you do that, you use a lot of catecholamines and vasopressors, so you lead to a greater incidence of ARDS. So that's the concept problem with the Rosner concept. The Lund concept based to say, okay, let's decrease the hydrostatic blood pressure, increase osmotic pressure so as to decrease the cerebral blood volume, and improve the blood for the perfusion and oxygenation. So they do the Swedish group do this by maintaining a euvolemic state, a normal hemoglobin, normal albumin, and oppose vasoconstriction by reduction in concentration of catecholamines in plasma and sympathetic flow. So this is slightly different way of doing it, where the focus is different. But so most of us generally not don't do the Rosner concept, where we try to artificially keep the map up. Even when the map is say 100, we don't go for 130. We don't do that thing because of this thing. We generally tend to follow more or less the Alan concept of management of hyper. The other thing is hyperosmolar therapy. Mannitol is what we use, but unfortunately in our country, mannitol is like a standard medicine. It's like pantoprazole. We give it twice daily, thrice daily, but really, osmotherapy works by creating a gradient across the blood-brain barrier, leading to transient hypervolemia, hemodilution, and thus an autoregulatory cerebral vasoconstriction and decreased cerebral blood volume in ICP. It doesn't work if you continuously give it, but unfortunately, we do it continuously. Hyperventilation, again, when it works transiently, when you're in forced or pushed against the wall, you can get it down to 30 to 35, but less than 25 is harmful because it's going to worsen the vasoconstriction and cerebral ischemia. Barbiturate coma with pentobarbital is the next step. Again, we don't do it very often. If you're doing it, then you need an EEG to ensure buzz suppression has happened. And if you fail pentobarbiturate, we do hypothermia by surface as well as endovascular cooling system. And with like any other hypothermia protocol that we follow in the post-cardiac arrest, the same complications can happen here also. So once we do it, then as I said, the fourth is once we treat the ICP, and the next is treat the subarachnoid hemorrhage. To understand subarachnoid hemorrhage, the question that will be, what will be the cause of the subarachnoid hemorrhage, do you think? And these are the causes. So aneurysm is about 85%, non-aneurysm is about 10%, and rare causes like trauma, coagulopathy is about 5%. So majority of the time it will be an aneurysm, a very aneurysm rupture. So the best method of identifying would be to do a CT and digital subtraction angiography to identify the aneurysm. All right, so clinical findings would be the classical is a thunderclap headache, as was described in this vignette, with along with vomiting, change in mental status changes. We can also see seizures as a presentation. We can see focal neurological deficit and nuchal rigidity are the manifestations. The next question that comes up automatically is, how do you classify the severity of SAH? And there are two clinical classification and one radiological classification. The World Federation of Neurological Classification classifies into 5 grade. And our patient who has a GCS of less than 6 and the motor deficit may be present or absent, as I said, we didn't even do a full neurological examination, but we know just with pupillary examination and the GCS is good enough to tell that the patient has a grade 5 severity. You can do the Hunt and Hess, which is looking at coma again or extensor posturing. So grade 5 would be coma. And as I said, we don't really like this confusion stupor coma category. It's much better to do this with the GCS. So I prefer to use the World Federation classification than the Hunt and Hess classification. The CT scoring is again grade 1 is no SAH on CT scan. If there is SAH less than 1 millimeter deep is grade 2, grade 3 is localized at more than 1 millimeter, and grade 4 is extending into the intraventricular and intracerebral blood. So this would be a grade 2 or grade 3 in the R patient is what diffuse cerebral subarachnoid hemorrhage is to do. Say in case if a CT was negative, what would you do? That would be the question. The answer is an LP because it shows xanthochromia, but you have to understand that a CT brain in the first 24 hours is 95% sensitive. It's extremely unlikely that if your CT doesn't pick up that you have. Nowadays, there are modern techniques of MRI which can detect blood very well in the subarachnoid spaces. And aneurysm and angiography is only done for evaluation of aneurysm, not to prove the presence of subarachnoid hemorrhage. All right, so as I said, clinical severity grade 5, Fisher grade 2. How do you manage? That's the next question. So management of SAH also should now follow we manage the coma, manage the ICP issue, and manage the cardiac ABC, which you've already done. So now comes how do you manage it? So you prevent rebleeding. So 3 steps again: prevent rebleeding, prevent vasospasm and DCI, delay cerebral ischemia, and then prevent the subacute complications. So let's go one by one. So what are the how do you prevent early bleeding? So remember, early bleeding in the first 4 to 24 hours of SAH is discovery rupture is about 4 to 14%. So what you want to do is 3 things: blood pressure control, correcting coagulation parameters, and using early aneurysm repair. So blood pressure control, you want to get the BP, the SBP down to less than 140 millimeter prior to surgical treatment of ruptured aneurysm. You use beta blockades with labetalol or with an esmolol drip to do that. You can use hydralazine if you don't know, if the heart rate is already very low and you are very afraid of using further causing heart rate downs. You can use hydralazine 10 to 20 milligram, but unfortunately availability is an issue in all centers in our country. All right, so the next second step is to correct the coagulation parameters. It's very important, and you can use antifibrinotic therapy like to risk the re-rupture in 2% of patients as compared to 11% in non-receiving the therapy. And this is important when you, especially when you're transferring patients to another center where there is a neurosurgeon or where there's a DSA available. So you better do this when you're transferring patients out. As far as aneurysm repair is concerned, there are two choices: coiling and clipping. How will you decide? And the answer, now there are two clinical trials which will clearly show that both better functional outcomes with 1 year with endovascular treatment. So early repair is for Huntington's grade 1 and 3, for grade 4 and 5, like this patient was grade 5 World Federation classification. You want to first see whether the ICP, the patient's brain, is ever going to recover. There's no point in fixing the fixing the aneurysm unless the patient shows signs of decreasing CIP. So in this vignette, the patient is presented with a clinical grade 5 and should not be subjected to aneurysmal correction, is what I believe. So what are the acute complications of SAH? And these are two, again, diffuse cerebral vasospasm and delayed cerebral ischemia. Diffuse cerebral ischemia, vasospasm, almost in 70% of patients there occurs, which is visible angiographically. It happens, it starts at 3 to 4 days and ruptures in after the rupture and peaks at 7 to 10 days and resolves in 14 to 21 days. DCI is more important. DCI is diffuse cerebral ischemia, is a clinical syndrome of focal neurological deficit occurring after aneurysm rupture, usually 4 to 14 days after rupture. It is contrary to popular belief that vasospasm doesn't lead to DCI. It's a different mechanism. And DCI is not related to vasospasm, and nimodipine is the one thing that prevents DCI, though it doesn't, nimodipine doesn't alter the risk of incidence of vasospasm. Nimodipine administered orally at all patients at doses of 60 milligram for 21 days significantly decreases DCI. And clinical detection of DCI may be difficult in obtunded patients, so therefore we use transcranial Doppler. Transcranial Doppler is good for detecting vasospasm, but not good for detecting DCI. So what the diagnostic modality of choice to detect DCI is perfusion CT scan. To treat DCI, we use the double-edge therapy. It's no longer called the triple-edge therapy, hypervolemia and hypertension. And this hypertension is preferable only after the aneurysm has been secured. And this is achieved by administering IV fluids and alpha-adrenergic agents. So use a lot of phenylephrine, not beta-adrenergic agents. And DCI with vasospasm in a major vascular territory has to be treated with as selective intra-arterial vasodilator therapy by an interventional radiologist. And subacute complications, they are the medical complications and the neurological complications, the cardiac, the pulmonary edema, the ECG changes, the LV dysfunction, fevers, hyponatremia, SIADH, cerebral salt wasting, hypoglycemia. So we're not going to discuss each one of them. These will be covered in all this thing, but this is a question that's asked. And the neurological complication, most important one would be hydrocephalus, because the incidence can be as high as 85% in certain series. And that's because the blood blocks the CSF through the subarachnoid cistern. And again, this has to be recognized as a person getting worse after a few days after the subarachnoid hemorrhage or even after the aneurysm has been covered. And this is much more important when there's an associated ICH and IVH also. All right, so this is something to understand as for the various subacute complications. So I'm going to summarize and conclude saying that what we demonstrated in the last 30 minutes is the presentation of subarachnoid hemorrhage as coma with raised ICP and herniation syndrome. You need to recognize this as a medical emergency, the increased ICP. You need to follow the ABCD management, followed by the CT scans, then a stepwise reduction in ICP, optimizing the CPP according to the Lund's technique, recognizing, then finding the cause, and in this situation, a subarachnoid hemorrhage, then knowing how to classify its severity, knowing how to manage it, especially the management of blood pressure, knowing which method of technique of coiling or clipping, and understanding that coiling is always better, but in our country, the cost of coiling is prohibitively more expensive as compared to clipping. So maybe these needs to be addressed as far as, and then it's a local availability of neurosurgeons are much more easily available than interventional radiologists. So there are a lot of issues regarding that. And then finally, recognizing the complications, both acute complications, which includes the diffuse cerebral ischemia and vasospasm, and the subacute complications, which can be medical and neurological, and to be aware and manage all these things. All right. Thank you very much for having a kind attention. I went through a little fast because there's, as I said, it's otherwise difficult for to cover a large topic which includes both management of ICP as well as management of subarachnoid hemorrhage in the given allotted time. Thank you for your patience.
Thank you, Dr. Suresh. It was actually an excellent and very, very comprehensive, overview of the management of subarachnoid hemorrhage. And I think you've covered pretty much everything regarding the initial management, the Rosner's, the triple H therapy, everything that you've covered. We've got few minutes for questions. Delegates, please put the questions on the chat box. While we wait questions from the delegates, Suresh, I can ask you a few questions. Uh, the incidence of cardiac arrhythmias, cardiomyopathies, and troponins and ECG changes and stuff like that during subarachnoid.
ECG changes would be very high, almost 30 to 40% of people will have ECG changes. The true cardiomyopathy incidence would not be very high, and but about 5% you would still end up having some amount of LV dysfunction. And it's kind of almost like a stress cardiomyopathy, to be honest with you, because of the catecholamine surge that happens. So, not a true Takotsubo, but a stress cardiomyopathy to a same extent. And the incidence would be, as I said, of ECG abnormality would be almost 35 to 40%, and cardiomyopathy would be about 5%.
But it is only medical management.
Yeah, medical management is something. And again, decrease the catechol mindset. So one of the problems was one of the problems with the Rosner approach was the fact that when you try doing that, you end up having more arrhythmias, you end up having more ARDS because of the sympathetic stimulation that you're causing by doing it. So that's the issue. I think it's a
Great. We
question.
have a question. Well, giving vasopressors and nimodipine both, please explain, sir, and please explain about the Rosner and Lund concept again, which was the best for our recommendations. Okay.
Correct. So the Rosner's concept, as I said, is so the concept is cerebral perfusion pressure is MAP minus ICP. So you decrease, which one do you target? So you're trying to move the MAP up and decrease the ICP so that CPP gets better. That's the whole idea. So which one are you going to concentrate on? So most of us concentrate only on decreasing the ICP and do not concentrate on trying to increase the mean arterial pressure. We just try to keep a goal of mean arterial pressure of 80 and above, which is what the recommendation is from most of the societies. So when you're looking at when you're actually in the Rosner's approach, you're actively trying to get the mean arterial pressure up, so that the difference between the MAP and the ICP, even though the ICP is going up, the MAP continues to go up, so the difference in cerebral perfusion pressure happens. So this you do it with giving a large amount of catecholamines, really large volume of volume loading. So you give 5 liters, 6 liters of saline, you get phenylephrine at a very high dose, 200 microgram per minute kind of a dose, to get the map up to that kind of an extent. So when you do that, you obviously are going to have even though the ICP you cannot do much, they don't do barbiturate coma in the Rosner's group, they don't do anything else other than just drainage of the CSF, which is what is done everywhere. But they would probably balance that and then take it from there. So that is what would be the concept in Rosner's, is that you're gonna be increasing your mean arterial pressure much more. The other concept that you and the Lund approach is the Swedish group is basically, let's not try to raise the MAP too much, just keep it around 80, and let's work on decreasing the ICP by barbiturate coma, by hypothermia, and by doing every osmotic therapy possible, by ventilating them to a PCO2 of 32 to 36, and so on and so forth. So they are focusing aggressively on the ICP part, while the Rosner's group is focusing on the MAP part. So that's the kind of a difference that it's easier for you to understand. Right. And the question that I can also see is vasopressors and nimodipine together. The idea is very simple. Nimodipine is going to work as a cerebral vasodilator here, and it's going to prevent the cerebral DCI, diffuse cerebral ischemia. And to prevent that, you're going to do all these measures. So it's okay to give both of them, but obviously when somebody is severely hypotensive, you've got to hold them. So the treatment of and somebody is hypotensive, restrict the hypotension. At that time, obviously, nimodipine has to be held.
Right. Mm, yeah, the other thing, Dr. Suresh, is we often struggle with managing the temperature. Is there a particular way of temperature management? Are there any TTM protocols that you follow?
Correct. I don't think we don't, none of us have the external, the formal cooling devices, and none of us have really bought it. And now, and like in the Western countries where they have proper TTM equipment to do that, Arctic Cool or things like that, trade names are there and it's available on the net. But we really don't tend to use that that much. But I think cooling, what we do is use the latent heat of water and ice to get the to get the temperature down. I think basic class 10 physics is what is used to decrease the temperature rather than to do anything fancy. It works, and sometimes when they have a simultaneous ICH, IVH temperatures are very very difficult to get down. I agree, and it becomes a big problem. So deep sedation, as well as deep sedation in that situation, preventing shivering. So the problem when you give ice is the shivering. So then you have to give them Cisetra or Nimbex or Rocuronium to get the paralytics in. So this is the problem of icing or cooling or any of these measures to decrease the concept of decreasing the temperature. It leads to the other concept of restlessness and muscle shivering and the raised ICP because of that.
Um, Still don't have any questions. Meanwhile, what is normally followed, because there is a extensive use of transcranial Dopplers to identify or to early diagnose DCI. Is there any way to predict vasospasm?
No, I think the idea of transcranial Doppler is to detect vasospasm, but vasospasm does not necessarily lead to DCI. So that's the caveat that we need to understand, is that you might be able to detect vasospasm, and then if you go too aggressive about managing vasospasm is going to be detected in 70% of patients, and if you were to use transcranial Doppler, you will pick it up in all the 70%. Doesn't mean that it needs to be treated all the time. And it doesn't mean necessarily that vasospasm will lead to DCI. DCI is a different mechanism. So that is the controversy about monitoring either angiographically or monitoring vasospasm with TCD, is we don't know the relationship between the vasospasm and DCI and how we're going to treat it and how we're going to react to the raised to the vasospasm. So there is this concept, that is why we need to be aware of it.
Yeah, so the risk is to overtreat, to end up overtreating. There is another question, um, which is a better way, sir, to whether to coil or to clip?
I think coiling. So there's no two large randomized control trials which have clearly shown that coiling is better, and so it is that is what needs to be done. But unfortunately, the number of coils that you require and the cost sometimes makes it in our country a choice of some clipping more cost effective. To be honest, and it's not easy. The availability of good interventional radiologists across the country is also not there. So we might have to transfer a patient to a center where they have. So if you have a center where they don't have good interventional facility, that becomes an issue. So yes, if you have all the facility, then definitely there is a role. The coiling is always better than actually clipping.
Right. So there are a few questions regarding the vasospasm again. Is nimodipine used to prevent or prevent vasospasm or for DCI? And what is the role of milrinone? Because some literature is
Correct. So the nimodipine is used to prevent delayed cerebral ischemia, not exactly vasospasm. So it is to prevent DCI, not vasospasm. Role of milrinone, we have tried it a few times, but there is no real good data out that it does help in this thing. But in a center where you don't have papaverine, where you cannot do arterial vasodilatation, and where you don't have the ability to do angioplasty of the intervention with the interventional radiology, especially when you have the focal deficits coming up, maybe milrinone is useful at that particular point in time.
any prognostic scoring for DCI?
I
another
haven't
question.
come across anything, but I'm not offhand. I'm not aware of specifically for DCI any prognostic score. I think the higher the severity of your subarachnoid hemorrhage, the higher the chances of your getting into complications of DCI. But I'm not particularly, to be honest with you, aware of any new prognostication score specifically related to DCI.
I think
The
we've
current
run out
role
of
of
questions.
triple H, I think there's double H now. It's no longer triple H. So it's just, so the heme concentration is out, but everything else, hypervolemia and hypertension is there. So you volume them and you give them alpha adrenergic agonist to get the blood pressure up, and you get them, make sure that the fluid status is well filled up. So that's the double H rather than triple H for treatment of DCI and vasospasm.
Well, and no neuro topic gets over without the mention of steroids. Suresh, your comment on that?
No, so there is no role for subarachnoid hemorrhage. I couldn't find it in any textbook. But again, we use Ganga Jal. Dexamethasone is our has been always been the Ganga Jal for neurosurgeons, but now it has become the Ganga Jal for all COVID physicians also. So I think so. It's all part and parcel of getting used to Dexa.
Right. Well, that's been an exciting morning session, and I thank you, Dr. Suresh, for an exciting and wonderful talk on the subarachnoid hemorrhage. We are looking forward for the pulmonary embolism as well, as much as I did for the subarachnoid. So, see you again in the later after the day. Uh, Thank you so much, Dr. Suresh. We move on to the next topic of the day, and for the next topic, I am extremely happy to invite Dr. Kapil Zirpe, who is again a senior consultant and head at the neurocritical care at Ruby Hospital, Pune. That is the Grand Medical Foundation Hospital, and we all know that he's been the past president of Indian Society of Critical Care Medicine. He's been the president of Neurocritical Care Society of India, and he's been a very active member for ISCCM, as well as a very avid teacher in and around the critical care circle in Pune and in India. And he will be talking about the organ donation, because he's been the pioneer in organ donation and transplants in India. I take great pleasure to invite Dr. Kapil. Over to you, Dr. Kapil Jirpe.
Good morning, friends. And I must take this opportunity to appreciate and thank Dr. Atul Kulkarni and Shiv Bhosle and his team for this particular session of the BRITE. My topic is declaration of the brainstem death and donor optimization. We'll start with the typical case scenario for this topic. My patient is a 44-year-old man brought to the casualty following the witness cardiac arrest in the street. Bystander had immediately started the CPR and called for help. Paramedics arrived and return of spontaneous circulation was attended after the few minutes. The patient was shifted to the ICU for the further management. In the ICU, he was brought unconscious. GCS was around about 4 pupils were equal and reacting at the time of admission. His heart rate was 98, BP was 90/60, and he was on adrenaline. Then after that, we have ventilated him. Now, if we see the progress of the patient after the 5 days, there has been no significant improvement in the post-cardiac arrest situation. His GCS worsened. It was initially 4, now it is 3. And almost we have stopped the sedation for more than 48 hours. So he was off sedation for 48 hours. His other lab parameters are normal. Now the question is whether this patient is brain dead or his patient is not brain dead. Now we know the history. There is a history of the CPR. Then he brought in hypotension. His pupils were reacting on admission. Then he was put on ventilator, sedation. We tried to optimize for first 48 hours. and he was almost after the 5 days of the initial that unfortunate event. We are talking just now about the current condition, and he's off sedation, and there is hardly any movements are there, pupils are not reacting, and then naturally the question will come into the physician ki really it is really what to go ahead with the further aggressive treatment, whether is my patient is brain dead, because we need to talk with the relatives where what is the prognosis, because naturally the relatives will now start asking what is the prognosis of our patient, whether he's salvageable, he's non-salvageable, then what's the next plan, whether you are continuing the life supports or we are going to withdraw if it is allowed by the law. So then the question arises about the brain stem death or brain death status. So generally the frequently questions coming into the mind of the physician or asked to the physician are, what is mean by death? What is the difference between the brainstem versus the whole brain death? These terminologies we very routinely use in our practice. Brainstem death, somebody says whole brain death, and what is mean by the brainstem death? Or how you can differentiate from the whole brain death? Now, if we see the history over 50 years from the now, initially there was a definition of death was when there is a cessation of the cardiorespiratory function. This was a typical death of the typical defined death, and still in most of the cases we use this as a definition for death. But since the cardiopulmonary resuscitation techniques are now quite familiar with the physicians and the intensivists, now we have you are not completely relying on the cardiorespiratory function death. We are now moving towards the favor of the brain death. Might be patient is having the heart rate and the blood pressure and everything, but patient is brain dead. So can we declare him as dead? That's the question. So what is the difference in between whole brain death and brainstem death? Now, this continuity is divided into the two. The US following countries, they use the whole brain death. That means brainstem plus whole cortex is also involved. There should not be the motor movement. There should not be the any other signs and symptoms of the brain is working. So EEG is must in their confirmation protocol. While UK, generally we follow the UK continuity where we follow the brainstem death. That means the midbrain, pons, and medulla. If these three major organs are involved and they are not functioning, that is the brainstem is not functioning, that means the patient will not have the motor response, patient don't have the spontaneous respiration, and pupils are dilated fixed. Generally, these are the criteria where we can say that this patient might be the brainstem death, and that is the difference in between the brainstem and brain death. But now, recently, last year, there was an article published by the World Federation about the brain death by the neurological criteria. To avoid the confusion regarding the various definition, the criteria death by the neurological criteria was published in the JAMA by World Federation, and they have given a list of the thing when you will call that patient is dead by the neurological criteria. Don't use the word whole brain death or brainstem death, and avoid the confusion, because already organ donation program is on the back foot. It is not getting the momentum. There are lots of the hurdles for running this program, and on the top of that, if there is a confusion in definitions about the whole brain death versus brainstem death, this may affect on our organ donation program. And that was a reason World Federation coming up with this document. It's a huge document. They have almost enlightened each and every aspect of the brainstem brain dead as well as the related with the organ donation. So I think now there should not be the confusion over the definitions of the brain death. Now we can say that the brain death by neurological criteria, that is what the common terminology we should use across the globe. We are trying to take the consensus from the various societies across the world. Majority of the almost 80 plus societies agreed for this definition. Let's hope the more and more societies will join. Now, whenever we say the brain stem death or death by the neurological criteria, one need to establish certain thing. That is a responsibility of the physician and intensivist. First thing, there has to be the irreversible cessation of the all brain stem functions. There should not be even 1% doubt about the reversibility of this thing. Please don't declare him as a brain dead. So there has to be this is a mandatory criteria. There has to be the irreversible cessation of the brainstem function with whatever the test you are doing. We'll discuss in later on. Then there has to be the established etiology. If you are not aware about or not not able to diagnose the cause of the brain dead, then please wait. Don't rush towards the putting him in a brain dead definition. So either there has to be the IC bleed or infarct, or there's a malignant MC infarct, or there are contusions, or there are abscesses, or it is a post hypoxic brain damage. So there has to be the established etiology documented by the imaging. Then it is acceptable to go ahead with the diagnosis of brain dead. Then neuroimaging, already I explained there. Neuroimaging is much important in the case where you can document that yes, was not salvageable. And simultaneously, when you are confirming the irreversible status of the brainstem function, established etiologies with you, imaging has a confirmation, but please don't forget to rule out the pathological condition, confounders, and the reversible condition. So exclusion is also the equally important. So let's come to the what are the prerequisites and confounders. So prerequisites are the temperature has to be the minimum 36. If there is a hypothermia, again you cannot rush for the declaring the brain dead, because in hypothermia you may get the loss of reflexes and affected the brainstem function. So hypothermia is not a right condition. I have got so many calls for declaring the brain death in other hospitals, and when I reach, the first thing we check the temperature is 33 degree. We say wait, warm the patient, get the temperature more than 36, and then again call back for the evaluation. So the moment you find temperature is less than 35, please do not proceed with the this all confirmatory test for the brainstem death, clinical as well as the lab test. Then your blood pressure, arterial blood pressure, systolic has to be the more than 60, mean arterial blood pressure, or your systolic blood pressure more than 100. These are the very basic criteria. If the patient's BP is 60 systolic and the mean arterial blood pressure is less than 50, ideally one should not proceed with the diagnosis of the brain dead. Then pharmacological paralysis should be excluded. This is very important. Where generally in a tertiary care center, we get the patient from the outside and they are on admission, they are not responding, motor paralysis is there. Always rule out and just pick up the phone, speak with that particular referring center, what they given, whether it is midazolam, whether it is a propofol, whether it is a paralyzing agent. Just go through the half-lives of these drugs and try to find out which one is the ideal time to proceed with the testing of the brain dead. So whenever you are getting any patient from the outside hospital, or if from the another unit, and you are not aware of the which drugs he has received, please do not proceed with the testing or the declaration of brain dead. Then alcohol level should be less than 80. Again, the alcohol intoxication has to be the rule out. And then if the patient has a severe metabolic acid base or endocrine derangement, again you need to wait. So these are the generally basic prerequisites and confounders for declaring the brain dead. Now, you need to, if you are a doubt, just do the serial measurement of the drug level. Might be the barbiturate. You will not believe, I have came across the 2 cases where the patient brought to us in a post CPR arrest. He was, that particular one of the patient was a medical professional. He found to be in his car after the 12 hours in a arrested status. They resuscitated. They brought here. He was on all supports, hardly any response. And when we gone to the detailed history, there was a history of some psychotic illness, and he was taking few tablets. And when we checked the toxic level, there the barbiturate was positive. We did the dialysis. On 3rd day, he started responding. On 5th day, he was off ventilator and every support. And on 7th day, he was shifted out of the ICU. So this is the classical example where you should not rush for the brain dead on admission without detailed history and doing the drug. If there is a doubt, because this scan was normal, this patient, so this just created doubt what must be the cause of the this particular unresponsive status. And then typical history shows the psychotic illness, so he was in a depression. We thought of some toxication, and we were right in this 1 or 2 cases. Then you can do the ancillary testing. If suppose you are still not sure about his cause of this thing, then you can go ahead with the CT angio or EEG and just try to get the maximum information about his brain status. Now, there are some observation period, because there are so many prerequisites and confounders for declaring the brain dead. One need to know the what is the time limit. For example, post arrest situation, like in our patient, he received the CPR, so it was a post cardiac arrest situation. So any post cardiac arrest situation, you have to wait for at least 24 hours. That is the minimum period you need to wait before going ahead with the testing for the brain dead and going for the apnea test. Then if suppose there is a head injury, you can wait for 12 hours. If there is IC bleed, you can wait for the 6 to 12 hours. So like that, there are approximate time has been suggested for going ahead with this thing. But the bottom line is, don't rush to do that unless and until you have a collective evidence about the cause, irreversible cause of his unconscious state. Your imaging evidence, and you have adequately ruled out the prerequisite and confounders in that particular patient. Now documentation. Okay, now you know that this patient is more than 24 hours. You know that this is a fifth day. There is hardly any response. It is likely to be brainstem death. And then again, your physician relatives are asking what to do. So you say that, okay, we have to go ahead with the clinical test to prove that this patient is not in a reversible stage of disease. Then there are certain clinical tests which may help us to give some evidence that this patient is likely to be brain dead. So the first is the pupillary reflex. Now try and understand. One should know what test you are doing. One should know what you are going to see after doing that test. And there are some limitations of the every test. So these all three are important. Please mind it, the all three, like which test you are doing, then what response you are expecting, and what are the consideration. For example, pupillary reflex. This is such a simple reflex. You are putting the bright light over the person's eyes and looking for the constriction and the change in the size of the pupils. Now, what you are looking, there should be absence of the ipsilateral or contralateral pupillary reflex. That is what you are going to see. But there are some variation may happen. There are constricted pupils which are not consistent with the brain death because of the underlying cause, or pupils can be any shape, or there may be corneal trauma, or there may be ocular injection of the drugs. Like sometimes somebody has put the atropine and you are not aware, and these pupils are completely dilated. So one need to know before when you are doing the pupillary science. So this is like you are doing the pupillary reflex. You are opening wide, opening the eyes, and you are putting the light over the pupils to see the change in this thing. Now, corneal reflex. Again, what you are doing, we are touching the cornea with the cotton swab, or just very soft type of the sticks. And what you are seeing, whether there are the blinking of the eyelids. But now again, when you are doing such test, care should be taken to avoid the damage to the cornea. Unless and until two tests are done, it is not proven that the patient is brain dead or patient is not brain dead. And in setting of the anophthalmia, again in severe orbital edema or scleral edema, you need to be very careful. Like what you are doing, corneal reflex, you are touching the cornea with the small cotton very delicately and avoiding the now, the next another tests are oculocephalic or oculovestibular. Oculocephalic is generally the doll's eye movement, and oculovestibular, what we putting the syringe, cold water to the syringe into the ear. Now, again, most important thing, what you are doing, you are rotating the head briskly in a doll's eye movement. That is an oculocephalic response. You are tilting the head briskly horizontally to the both side. What you are now checking, you are taking the detection of the extraocular movement is not compatible with it. So this is a response you are, but then you have to be very careful while doing the or before doing the test that the confirm the integrity of the cervical spine. If you are not sure, please be careful while doing such tests. Might be patient is not brain dead and you are landed with the worsening of the cervical cortoma. Ensure the integrity of the tympanic membrane for the oculovestibular. Again, this test everybody knows. I will not go into the much details. I'm more of the concern of the when not to do such tests, like when you are suspecting the cervical spine, when they are not sure about the tympanic membrane integrity, or there is a fracture of the base of skull. Then again, please be careful while doing such tests. Or there is a severe orbital or scleral edema or chemosis effect may affect on the your results. So how you are doing, you are doing the horizontal movement of the head, and you are checking the ipsilateral or contralateral movement of the these eyeballs. That is known as a doll's eyeball. If there is no movements, that means the test is positive. Simultaneously, you are taking the cold water and putting to the syringe into the middle ear, and checking the eye movement. So this is a oculo-vestibular, and this is a oculocephalic, that is a doll's eye movement. But please remember when not to do it. Now, next test is like you are giving the motor, you are checking the motor response. That means you are applying the pressure. Now, one should know where to apply the pressure. There's nowhere you can just pinching and just creating the economic passage. That is not done. So, either you should apply the deep pressure on the condyles at the level of the temporomandibular joint, or supraorbital notch bilaterally, or sternal notch at the all four extremities. You can do that, and you just see the what is the response of that particular. But again, one should remember that the spinal responses may happens in this. So you should be careful though while doing in front of the relative. You have to explain prior to the relative that there are the spinal reflexes which may cause some flexion and extension movement of the upper and lower limbs, and the patient relative should not get disturbed that there is a movement and you are declaring the brain dead. So whenever that you are doubt, you can proceed with the ancillary test. So these are the sites. Generally, either you can bilaterally over the region, or you can just keep the pen or pencil and put the pressure on the nail beds or at the temporomandibular joints. These are the common sites where you can check the response to painful stimuli. Now, cough and gag reflex. This is again, we are checking the brainstem. So you can stimulate the posterior pharyngeal wall bilaterally with the tongue depressor or the suction catheter, or you pass the catheter into the your endotracheal tube and check for the cough reflex. What response you are trying to get? Absence of the cough and gag reflex. But again, in certain cases, in higher cervical cord injuries, you may not get the cough reflex very ideal, because it is get abolished in a high cervical cord injuries. So you should confirm with the additional ancillary test. Don't just rely on the cough. So either you are passing the suction catheter to the ETT and just checking the cough reflex, or you are touching the posterior pharyngeal wall with this thing. So this is for the gag and this is for the cough reflex. Now, apnea testing. Now, when first thing your timing, your 24 hours post cardiac arrest. The second thing, you have rule out the prerequisites like temperature is normal, it is more than 36, he is not in alcohol toxication, he is not under the effect of the drugs, he haven't received any sedative or this thing. Then rule out the confounders. You have done that. After that, you are going ahead with the cause. So you know that it is an irreversible cessation of the brainstem function, because he had has a large IC bleed, or in our case, it was a post-arrest hypoxic brain damage documented bilateral extensively on a MRI. So you have confirmed the irreversibility of the cause of the brain dead. Then second thing, you have rule out all these confounders. You are measure the temperature. Now you are clinically sure that he may be brain dead. Then you did the clinical test like cough reflex, gag reflex, cornea test, pupillar reflex, vestibulo-ocular, vestibular this thing. So these tests you have done, and by this clinical way, you are sure that this is likely to be brain dead. Now you are proceed with the apnea test. So apnea test, before going ahead with the apnea test, you need to have documented evidence about the clinically patient is brain dead, and along with the history and etiological factor. Now apnea test should be the last, and you should target in apnea test is a PCO2 generally. That is what the target. But again, there is no fixed value of PCO2. We'll come to that. So before that, when you decided for the apnea test, generally you should have the arterial line. It is better to have arterial line in place, and your patient settings are ventilators are almost, you have kept the normocapnia. That means the in between 30 to 45. The moment if your settings are low tidal volume or lung protective, and if the CO2 is 55, your targets are now 75. They will not be the 35 to 45. So you are not targeted. Your ventilation should be targeted to be the normocapnia. apnea, but your apnea test is a difference of the 20. And better to have arterial line if you are proceeding with the arterial line in a brain dead patient. Now there are different ways of doing the apnea test. The commonest is the oxygen insufflation. That means we disconnect the ventilator, we pass the suction catheter or oxygen tubing inside the that tube. I will show you the figure, and then you check the ABGs for the PCO2 and hypoxia. But the most practical point I am going to tell you that the internal cannula of the diameter to the endotracheal tube should be less than 0.6. What it mean by that? Your tube which is supplying the oxygen should not be the larger enough. Like for example, this suction catheter you are passing through. So through this, suction. This is the oxygen tubing. Through this you are supplying the oxygen. That is the oxygen inflation method. So this diameter of the tube and the diameter of this oxygen supply tube, the ratio should not be the more than 0.6. The reason is very simple. If suppose this diameter is more, then what will happen? There will be air trapping happen doing. So you are giving the oxygen with the 15 and 8 liter, and their diameter is higher, almost equivalent to the your this thing. Then there will not be the expiration, and their air trapping will happen, and you landed with the barotrauma or pneumothorax. I have came across the true tension pneumothorax during the apnea test when the ventilator was completely disconnected. Patient was on a oxygen without any ventilator support and with the only oxygen this thing, and the patient developed this thing. So one of the mechanism is the air trapping in this method while doing this thing. So there are two things that are more important. Your internal cannula diameter of the oxygen supplying tube to the endotracheal tube should be less than 0.6. And your oxygen flow liter should not be the 4 to 6 liters. Generally, we have tendency to keep it 15 liter per minute. I don't know why we are keeping. We need to have oxygen more than 94 or 95%. Even if the 2 liter oxygen, if it is 98 or 96%, why you want 10 liter and 15 liter? Because that flow is going to generate some tidal volume, and that going to may have the air trapping if the your tube size is not adequately titrated. So you need to see these both things while doing the apnea test: your diameter of the inner cannula, your diameter of the tube, and your flow rate. In certain cases, what happens the moment you disconnect the ventilator, the patient drop the saturation. Might be it is because of the lungs are in ARDS, or they are easily de-recruiting if you remove. So there is a provision that you can on the CPAP, you can continue on the pressure support ventilation, and you can do the test. But again, these are suggested alternatives for doing the apnea test. And in apnea test, your target is pH should be the less than 7.3, and your PCO2 should be 60, provided that your ABG prior to apnea test has the normocardiac apnea. Otherwise, your target should be more than 20 millimeter of difference. So, for example, my PCO2 before starting the apnea test was 65. So, my target cannot be 60. My target is now 85 post this thing. So, we take the baseline PCO2 for the difference of the 20. Suppose my PCO2 is 45 before starting the apnea test, then my target might be the 60. So, please remember that there has to be the difference of the 20 millimeter of mercury before in both tests, pre and post apnea test. Now, this is another alternative if the patient is in a ARDS or neurogenic pulmonary edema and it was not possible to disconnect the ventilator, and the moment you disconnect, there is a severe hypoxia. Now, in certain situation, you can use this technique, ambu bag with the PEEP wall. So the PEEP wall will help to maintain those lungs in a recruited fashion. So generally, if suppose my patient is on 100% oxygen and his saturation is 96 on 100% on the PEEP of the 8, and if I would like to go ahead with the apnea test, what I will do, first thing before the test, I will recruit the patient, because I know that the moment I disconnect, the chances of de-recruitment are very so before the test, I will do the recruitment. I will titrate my all ventilator settings. I will wait for a few minutes to lungs get settled down. Then I will keep the ambu bag and my PEEP wall ready. And within fraction of the seconds, I will remove the ventilator and I will disconnect the patient to the ambu bag with PEEP. So I will avoid the de-recruitment of the lungs, and that will help to maintain oxygenation during the next 8 to 10 minutes for the apnea. So that is what the technique we have done successfully in few patients whose requirement was more than 60 to 80%, and the PEEP requirement was more than 8, and they were used to drop the saturation moment we start the apnea test. Now, documentation. Okay, so you are doing the pre-oxygenation with the 100% oxygen prior to apnea, then obtain the ABG, disconnect the ventilator, again continue the oxygenation, and then ABG after 10 minutes, and your PCO2 difference has to be the more than. So this is a classical example. So this is a during the apnea test. This is a tube. Ventilator is completely disconnected. There is no correlation in between the ventilator and the tube, and you are checking the monitor for the oxygen saturation, pulse, and BP. So during this 10 minutes, so this was the prior ABG, it was 34 and the pH was 7.38, and the pH was 7.1 and PCO2 60. So there is a difference of the 20. pH is less than 7.3. I am observing for the spontaneous respiration. If there is no spontaneous respiration during this 10 minutes of the gap, then my test is positive. But the most important thing, I am interested in safety of the patient during the apnea test, because unless and until I complete the second test in the gap of the 6 hours, nobody will label this patient as a brain dead. So during the apnea test, I will continuously monitor the oxygenation, heart rate, and the blood pressure. Your saturation should be more than 95, your mean blood pressure should be more than 60, and there should not be the arrhythmias. That I would like to follow. I will take the first ABG before starting the procedure, and after 10 minutes I will collect the ABG, and then I will reconnect the ventilator. That is what the procedure of the apnea test. Now, already I explained what to monitor during this thing, but one should know that when to abort your apnea test. So you started apnea test and you find after 5 minutes there is a spontaneous respiration. Please stop that apnea test and reconnect the patient to the ventilator. Or your blood pressure is dropping, connect it to the ventilator. Your saturation is dropping, connect to the ventilator. Your patient has arrhythmia, connect it to the ventilator. So please don't rush for any apnea test in presence of the hypoxia, cardiac arrhythmias, or spontaneous respiration if you observe during that 10 minutes. 10 minutes is the time. Now, documentation. Okay, when you are documenting, you need to write down the etiology of the coma, absence of the confounders, full details of the clinical testing, imaging findings, reason if at all you have done the ancillary testing, time of the death, and the identify practical performance. So there is a committee. There is a committee appointed by the government where you can check the that committee will do this testing. So who is the qualification, who are the qualified for doing the brainstem death? So practitioners who have completed the training and license to independent practice medicine. That is the first. So registered medical practitioner can do the brainstem death. Then he is a periodically certified. There are certain certification courses are there. You can do that, and with the gap of the 6 hours. And there has to be the good training, continuous training, and that particular doctor should have that skill of communication with the relatives regarding the what test you are doing, how you are going to perform, what are their doubts, and if they are convinced, then only you can proceed with the apnea test. The most important thing in India, we follow the interval of the 6 hours. So if I do the first test at 1 o'clock, then I do the second test at 7 p.m. There is no shortcuts. In other countries like UK, they don't have any timing in between the first and two, or in USA, they only do the one testing. But in India, we follow the gap of the 6 hours in between the two tests. And at the end of the second test results, if it is positive, then only we can label it as a brainstem death. Now, there is a doubt. So even clinical tests we have done, which shows clinical brain dead, we have done the apnea test. But in certain cases, you might do for the satisfaction of the relatives or primary consultant, you may go ahead with the EEG or cerebral angiography or transcranial Doppler or evoke potential. But none of these are the diagnostic or confirmatory test for the brain dead declaration. The clinical and apnea tests are still valid for declaring, but sometimes you need to satisfy the relatives and the treating doctors. Now, this was the act, the THOA Act came in 1997, but after a few years, they have done the amendment. And this was a very positive amendment that initially only neurosurgeons and neurophysicians were authorized to do the brainstem testing. But all of us know that they are not available during the odd hours. So now any surgeon, physician, or anesthetist, or intensive care can certify the brainstem. So we have the large pool of the medical practitioners available to go ahead with doing this test, and that is what the we say that this is an important step in favor of the organ donation. So we will not lose the donors as well as the interest of the relatives because of the that particular specialist is not available. Now coming to the optimization, up till now we have discussed how to declare the bread dead and what are the various issues regarding that. But if you see, though it is 2016, I am sure by 2020 there is no major change happen, because last 2 years because of the COVID we lost every momentum. So our program is so slowly growing. So in spite of the huge awareness, in spite of the education and training available, why numbers are not rising in a significant way? They are like a creeping very slowly over a period of the year, like 0.4 per, our organ donation rate is 0.4 per million, 0.5, and now it is 0.6, and during COVID it dropped down to again 0.4 mostly. So there are various reasons, and we will only discuss what are related with us, that is the intensivist and physician. So one of the major reason is that the conversion rate. Like for example, if I came across the 20 branded patients throughout the year, how many are able to convert them into the organ donation? So 20 out of 20, or 16 out of 20, or 10 out of 20, or 5 out of 20? And what are the various reasons where I lost that donors? Again, I am not going to go into the social aspect of this thing, but mainly the for intensivist perspective, if you have seen, these are the common WhatsApp messages generally we are getting our WhatsApp group, what is happening to the donor. Hypoxia injury, patient is having the severe hypoxia and he requires a lot of support. Again, donor is not properly optimized, and he's not fit for going ahead with the organ donation or considering. Or lactate is 3.6, that means either he's not properly hydrated, or there is a sepsis or active infection. Now these are the really issues in day-to-day life that even families are willing, donor is there in your ICU, transplant teams are ready, but unfortunately as an intensivist or treating physician, we are not giving them to go ahead. We are saying that no, wait, there is an infection, because we are interested in the recipient, because they are already immunocompromised, they are in a debilitated state, and if that quality of the organ is not good, then you are not doing the donation, you are doing the half-hearted job. So I always say that the intensivists this is the intensivist domain, this is our domain. I don't allow always say that we should let the non-medicos promote organ donation in the social media and every forum. We should do it our job in our ICUs and in our limit. What is our job? Even if I get the 10 donors, I will try to do the at least 9 out of that, and out of 9 donor I will try to get the maximum organs, so multi-retrieval. So most of the hospitals are happy that we did the organ donation, only liver was possible or only kidney was possible. I say, why not all 6 organs, liver, kidney, lungs, your pancreas, your intestine, bone, hands, everything. So our target should be the maximum conversion, almost 90 to 95%, and multi-retrieval, that means the multi-organ transplant. And for that, we should know that the optimization part of the donor is one of the backbone of this program. So these messages are not good for donors in ICU. So there are generally principles. If we follow the very basic principles of the donor management, we will get the two things. We will get the stable donor and we will get the quality donor. I always say that the stable quality donor. Stable means hemodynamically stable, and he can withstand for next 24 hours till the relatives give the consent. And quality donors means the maximum organs are retrieval. I will be always happy that heart is also taken, lungs, kidney, as well as the pancreas and intestine. That's what the organ donation, rather than only kidneys or liver, then that is the half-hearted job. So there are generally generic intensive care, basic, very basic intensive care principles. Then you have to see the optimization of the maximum organs and do the frequent clinical assessment. Generally what I do in my ICU, I always say that the one donor is equal to 8 patients. So I allowed the one senior registrar or one junior consultant to do the job of the only maintenance of the organ donor till he reaches to the OT. My job finishes when I hand over my donor to the anesthetist transplant team. That is where we say that we have completed the job. So that particular consultant is just communicating one point, communicating link for the every transplant team. There is a heart team, there is a lung team, there is a kidney team, there is a pancreas team, there is a your bone. Everybody has the different requirement. So he will communicate, he will do the testing as well as the optimization. According to that, he will continue with the management. He will keep the everybody in a loop. He will inform to me, and if we require the help, we will provide the help. Like that, you do the frequent clinical assessment and the responses and try to get them as many as organs possible. So one need to understand when you can get the quality organ. Unless until you understand the pathophysiology of the brain dead patient, it is not possible. You have to anticipate the most of the things in a brain dead donor. What do you mean by that? There's a very thin line in between the acute severe brain injury and the brain dead. The moment the patient becomes brain dead, there are a lot of metabolic and other changes happens in the body. Like for example, looking at the screen, I can say that this patient is coning. If there is a sudden tachycardia or sudden bradycardia, or there is a sudden drop in blood pressure, or last 2 hours the urine output is more than 300 ml per hour, that gives you an idea that probably this patient is now coned and he's heading towards the brain dead. So this is how the like intracranial patients can lead to the herniation and infarction. There's after the brain dead happens, there's a loss of the central vasomotor control that can immediately cause the hypoxia and hypertension. So there's a Cushing response happens in immediate, and then later it drops off. So initially there is hypertension and followed by there is hypotension. Loss of the respiratory drive, hypothalamic pituitary axis control get damaged. Then there is a massive release of the pro-inflammatory cytokine. There are the decreased circulating pituitary hormones that leads to the further rise in sugar, drop in blood pressure, and so many things. Diabetes insipidus happen and related to adrenal insufficiency or hyperglycemia. So anytime during the the acutely brain injury patient, I came across one of these symptoms, we generally, okay, but this patient is mostly deteriorating. Now, the commonest is the arrhythmias. We can see the arrhythmias are because of there is a output is more than 300 per because of the diabetes insipidus. Then you can anticipate the hypokalemia, and there is immediately correct those hypokalemia, because that should not proceed towards the arrhythmias. So maintain the serum electrolyte like calcium, magnesium, calcium. Optimize the fluid status and the normalized temperature. This is my primary target in a brain dead donor, to normalize the physio. If at all, after the optimization also, if I came across arrhythmias like SVT, the standard drug of choice is Cardiron, or if possible do the cardioversion, but again as per the indication. And the bradycardia is very tricky. There is a loss of the vagus stimulus. So if you give atropine, it will not work. The drug of choice is either isoprenaline or pacing. Now, typical another problem is the central diabetes insipidus because of the loss of the hypothalamic pituitary axis. You get the polyuria, you get the low urinary specific gravity, hypernatremia, serum hyperosmolality, urine hypoosmolality, hypokalemia, hypocalcemia, hypomagnesemia, hypovasculemia, dehydration. Classical. Your treatment should be replace the fluid, that means hydrate, vasopressin, or desmopressin nasal spray. Nowadays, there are desmopressin nasal sprays are very frequently used. That will help to treat your central diabetes insipidus. Now, the next thing is the fluid management. The frequently asked question: how much fluid? How much per hour? What are the choices of the fluid? And if there is hypernatremia, what are the choices? The simple answer is that if the initial sodium is less than 150, you use the balanced crystalloid 100 to 200 per hour. If your initial sodium is more than 150, which is the usual story, you can use the 5% dextrose or half normal saline. And every 2 hourly, you can measure the serum sodium. Now, this is a in 2005 in textbook of critical care medicine, they have given a just approximate idea. If your sodium is in between 150 to 155, give 500 ml per hour. If it is 156 to 160, give 1000. If it is 160 to 165, give 1500 ml. If it is up to 170, 200, and if it is more than 170, more than 2000, that means the 2 liters you should pour the output over the 2 hours. And that gives you the idea ki what is the requirement of the patient. So these are the some good directions to use the fluids in BRITE. The next is, what is your hemodynamic target? One should know that what are the targets in your donor. Your blood pressure has to be the 60 to 65. Urine output 1 ml per kg per hour. Your ejection fraction is minimum 45 and low vasopressor dose. This is for quality organs. Generally, these are the requirement for your organ donor. Now, if suppose in spite of the adequate fluid challenge, still I am not able to achieve my target of the mean arterial blood pressure more than 60 or 65, or my vasopressors are still high, I can go ahead with the advanced hemodynamic monitoring. I can do the mixed venous oxygen saturation. I can go ahead with the lactate. I can go calculate the base deficit. I can measure the stroke volume variation or this thing and determine my fluid requirement. And after the adequate fluid requirement, I can go ahead with the vasopressors. But the most important thing, when you are doing the echo, and if your patient is hemodynamically unstable, that echo is not reliable. So what to do? You optimize the patient, you hydrate the patient, and then do the echo. That is more reliable. Generally, first 12 hours, it is not advisable to do the echo and rely on that report very confidently. You can do it after 12 hours of the optimization. Okay, in spite of the my all efforts, if the BP is mean blood pressure is still less than 65, I can, first choice of the drug is norepinephrine, the second is vasopressin. Generally, all these raised intracranial patients have the bradycardia. So dopamine is not completely out of your list. If your heart rate is less than 50, I will suggest use dopamine. Okay, the most important thing, in spite of the your all these adequate fluid management, the right choice of the fluid, the right amount of the fluid, vasopressor, still patient is not hemodynamically stable, then now there is a role of the hormonal treatment. So hormonal treatment is not suggested in a stable patient. Like your patient, mean arterial blood pressure is 65, he is not on inotrope, his saturation is good, he is maintaining the urine output, generally it is not indicated. So it should not be the blanket rule. The hormonal therapy may play a role after the adequate optimization with the fluids and the your vasopressors, if your mean blood pressure is not up to the target of 60 to 65. Then mechanical ventilation, typical normal normocapnia targeted ventilation, tidal volume 8 ml per kg, PEEP 5 to 10, plateau pressure less than 30, and your CO2 in between 35 to 55. These are the basic this thing. Whenever you need, go ahead with the lung recruitment. Whenever you need, go ahead with the physiotherapy. Whenever you need, change in position. So it is not contraindicated in a donor. Please remember. So improve the hormonal therapy, generally to improve the hemodynamic status, you use the hormonal replacement therapy. So what are these goals of the hormonal replacement therapy? Improve the hemodynamic, reduce the vasopressor requirement, increase the number of the extended criteria, and improve the post-transplant organ donation. So hormonal therapy plays an important role, not only improving the hemodynamic. Your patient should have the lesser number of the vasopressor and lesser doses, because it is related with your organ this thing. Because if the quality of the organ is good with the minimum support, your post-transplant organ function will be good and they will have the good life. So I always believe on quality donation, multi-organ retrieval rather than only donation. So I'm not interested in the 50 organ donation. I am interested in how many kidney, how many liver, how many heart, how many intestine, and what was the quality for 1 year, 2 year, 10 year, 15 year. That is more challenging. So if you see that this was a beautifully put it the role of the thyroxine. If you see those who received the thyroxine and those who so there are significant number differences there. So heart, lungs, and kidneys, as well as the pancreas, your thyroxine therapy helps. Its significant value is less than 0.001. So numbers are almost double. That means the organ stability must be good in this patient, and that's why the hemodynamic stability and the organ quality help them to get the more and more organs. So thyroxine has a definitely role. In liver, there is no major statistically significant number happen, but other organs definitely it has its role in a hemodynamically unstable patient. Steroids, yes, there is a role. Either you give a 1 gram or 50 milligram per kg or 250 milligram IV bolus followed by the infusion of 100 milligram per hour. Again, you can repeat the dose if the hemodynamic instability is continued in that particular patient. And the thyroid hormone already I explained. Now, the very frequently asked question about the infection. There are a lot of myth about the donor infection. Infection transmitted by donor is very rare. Suppose you see, generally they are for such a short period in your ICUs, 2 days, 3 days, or 5 days. So chances of having the infections are as such is rare. So it is not very common thing. Second thing, you need to do the assessment of donor. So the moment you declare the branded, set the blood cultures, culture, then your fungal cultures, your WBC count, your ETT secretions. You need to take the proper precautions because we know that our ICUs are full of the MDRs nowadays. So that just in any absence of this clinical evidence, you can go ahead with the assessment. Collect at least the 2 blood samples. It is a must. Then if at all, in spite of the all precautions, even if the patient has a bacterial infection, it is not contraindicated. You treat them with the higher antibiotic as per your culture, and you can proceed with the donation and continue your same antibiotic in the recipient for at least 7 days. So infection and even MDR infections are not contraindication for the organ donation. They are relative contraindication. You have to discuss with the transplant team. You have to find out what is the condition of the recipient, how ideal you are with your antibiotic cover, and what is your communication in between, the good communication in between the transplant team and the intensivist can save the patient. But invasive fungal infection are contraindication for organ donation, so be careful. So, my friends, I am coming to the end. My take-home message will be: donation consent is must. That is a skill of your counselor or social worker. I am more of interested in organ quality. Keep the patient's all values in a normal range, appropriate fluid management, whenever the indicated hormonal replacement therapy and appropriate antibiotic coverage are the backbone of your quality and the multi-organ retrieval. So generally there is a rule of the 100, heart rate around about 100, your blood pressure systolic more than 100, your CVP 10, your output 100 ml per kg, your electrolyte, normal electrolyte, blood gases, again the normal pH and normal capillary wedge, patient and cardiac index. That is what the target generally we expect in our organ donors. Thank you. This is my team with me who's doing all this fantastic job. And on behalf of them, I'm giving such lectures. Thank you.
Thank you, sir, for this excellent talk about brain death and sharing your personal experience about the management of patients with brain death, and also discussing the practical points of how to do a brain death test. I hope the delegates will get the understanding of management of brain death in real life and also in the examination. We have a couple of questions. So the first question is from Dr. Rashmi. The question is, for death by neurological criteria, what could be the time of death?
I already explained that timing in India, we need to do the 2 apnea tests. And the timing is always at the end of the second apnea. If you do it at 6:30 second apnea, that should be your time of death. So please, the brain death definition by neurological criteria is not something
Unmute, sir, please.
Sir, your voice is...
You're muted yourself, Kapil, by mistake, I think.
Sorry. See, we in India, the 2 apnea tests are must. There is no excuse. And after the second apnea test, we generally take this timing as the time of the death. So whether you are declaring brain death, whatever the timing, but the timing of the second apnea test is taken as the timing of the death.
Now, sir, there's one more question regarding this 2 apnea tests. So suppose after first apnea test, the family refuses the organ donation, and then they come back later after say a couple of days, then again you have to do the same 2 apnea test, or 1 apnea test would suffice?
See, the document says that the minimum gap should be 6 hours. There is no documentation of the gap maximum time, so you can do it. But the problem, I have came across the 1 or 2 cases from the other hospitals where there was 48 hours of the gap in between the first and second. Then I will be quite skeptical. I say rather than doing the after 48 hours, doing the both test with the gap of the 6 hours. That will be the ideal. But in India, anything can happen. After the first apnea, even after 7 days, also you can land it with the second apnea. These are all anecdote. We should not go for that. But minimum time lapse should be 6 hours.
One question by Dr. Venkateshwaran. What is the what dose of thyroxine do you use in your ICU?
So we use the 300 milligram, but already I have that slide is giving you the different various doses what you are using. But what is in our protocol? We give the steroids 1 gram methylprednisolone. We give the thyroxine 300 milligram, and we continue with the optimization. That is what standard we follow. There is a problem with the various transplant team. Generally, cardiac teams are not very comfortable with the steroids because they use the heavy immunosuppressant after the cardiac transplant. Liver teams are comfortable with the steroids, but liver teams are not very keen for the thyroxine. So there are ways, but when you are doing the multi-retriever, you have to follow the common pathway. So you have to discuss with the various team and just decide your immunosuppressant.
So you mentioned about the various ancillary tests like EEG and cerebral angiogram and Doppler.
Yeah.
So in your practice, when do you have to use this test apart from the brain death test?
Honestly speaking, these are ancillary tests. They are not confirmatory tests. Still, our law says the apnea test is the only confirmatory test. But sometimes what happens, unfortunately, if we are not good in communication with the relatives and we never explain them the spinal reflex, and moment relatives, one of the relatives come across the some flexion or extension, then they don't believe, they never believe on the teams which are managing. Or sometimes even primary consultants are not so in such situation, you can go ahead with the bedside EEG. It is easily possible. You do the MRI angio, do the CT angio, but again CT angio has some 10%. Again, there will be the difference of opinion. But I always say that why not to do that? If you want to convince, there is no need to force the relatives or primary consultant. If the patient is in a condition to move to the CT angio, please go ahead with the CT angio. At least you will get the good cooperation from them. And if a patient is not in condition, do the EEG. Bedside EEG is possible. So bottom line is, at any during the whole organ donation process and maintenance, there should not be the sense of force or sense of compulsion. It has to be the voluntary from the team, voluntary from the relatives, voluntary from the administration. So everybody should be more comfortable to do the organ donation rather than it's like compulsion. Okay, we need to do it.
So everybody should be on the same page when the patient
Yes. Absolute.
So meanwhile, while we are preparing for this organ donation, there is one more. If the patient has a cardiac arrest, this is a question from Dr. Rashmi.
Yeah.
Is CPR acceptable modality while organ retrieval is mobilized?
Yes. Now we never talk about the death after the circulatory, the organ donation after the circulatory death. That is the DCD. That is the next future of the organ donation. If we have seen, we have that curve is almost flattened in India. We are not going ahead with the RTAs. So next is the donation after the cardiac death. So there are this Manchester classification says class 1, 2, 3, 4, 5, and 4 and 5 is after the cardiac arrest. But there's a definite pathway you need to follow. For example, in brain dead patient, it is quite easy. Suppose you have already declared the brain dead, you have done the first apnea, and patient went to the cardiac arrest. Do the CPR, get the return of spontaneous circulation, maintain the organs. Even if possible, ECMO you can initiate to maintain the quality of the organ, and then you can again go for with the second apnea and you go for the organ donation.
One question from Dr. Raunak is why the gap of 6 hours between the two tests? Is there any?
Yeah, this is very valid question, but again, this is our that THOA Act says there has to be 6 hours. So At present, I don't have any answer why 6 hours. I personally agree if the first apnea, one apnea test is more than enough, because we are facing a lot of problem during the apnea. But again, probably we are a country with the diverse practices, and there is hardly any uniformity in the maintenance as well as the doing this test. So government wants to be rest assured that there has to be the two apnea tests done as per the advice, and minimum 6 hours gap. So that might be the reason, but there is no scientific reason after 6 hours why you should do the apnea test. I already told you in UK, you can go ahead with the second apnea test immediately. While in US, they only believe in the one apnea test, and might be in future amendment, it may get sorted out.
Now, sir, if the first apnea test is unreliable or insufficient, how long we should wait for the second apnea test?
See, again, you need to go back to your basics. Why that apnea test was unreliable? Whether it was a patient was hypoxic, or whether there was a spontaneous respiration observed, or whether there was some hypotension. So your timing is not fixed. You need to optimize. Might be next 4 hours, 6 hours. Might be after 24 hours. You have to before the next apnea. Your donor has to be in a stable hemodynamic status. Like in one of our cases, we did the apnea and sodium was 178, and the transplant teams were not comfortable with the 178 sodium and apnea test. There are certain relative contraindication. We document, we said that there is evidence with the 170 plus also you can go ahead with the apnea test, but transplant teams were not comfortable. Okay, we did it after the 4 hours. We brought down that sodium to the 160, 165, and we went ahead with that. So you need to find out why you are postponing the apnea, or why you aborted the previous apnea test. And after the adequate optimization, you have to go ahead with the your next step.
So we have one last question from Dr. Seema Joshi. How long steroid infusion to be continued?
Ideally, if you say generally the after the declaration till your ritual happen is a 24 hours maximum, and in certain situation it may go up to the 36 hours. It never happens 7 days. You have declared you did the second apnea then. So 1 gram bolus dose is sufficient enough. But unfortunately, suppose there is some delay because of the some untoward incidences, then you may repeat the second dose if your donor is unstable. So again, but you have to titrate whether there is any chance of the infection, what are the blood cultures, whether how many days the donor is with you, and what your ICU culture. If your ICU culture is flooded with the MDR organisms, I will say don't repeat your steroid dose, because you may harm the recipient.
So we have very interesting question related to our Indian practice. While waiting for the organ donation in private setup, who is supposed to bear the charges of the patient?
No, now there is not a question. See, the organ donation program is run by the government. There is a lot of transparency and uniformity. Let me tell you, there is a now readily available registry list is there, recipients waiting list is there. Now, second thing, by law, what our law says, once you declare the brain dead, when you complete the first apnea test, from that onwards, whatever the charges needed for maintaining the donor are generally taken care by the hospital. Now, whether this hospital, again, those charges are upper cap by the ZTCC and the ROTO and NOTO, and they collect it from, or they reimburse it from the recipient. So I think it's fair now. If suppose I declare at 12 o'clock today morning the brain dead, and I did the apnea test, after that, whatever the maintenance charges with the higher antibiotic, whatever they are taken care by the hospital. And this is a government. This is nothing to do with the private and government. This is a uniformity in the law, and government is doing the excellent job on this front. Even now, you cannot register as a recipient to the more than one hospital. I think that is what the maximum transparency will push this program in a smoother way, rather than having a lot of doubts in a donor's relatives' mind as well as the common public.
So we have one question about if the patient requiring very high inotropic support to maintain BP, can this patient be considered for organ donation?
Yes, again I'm saying why to lose the donor. There are the options in front of you. Suppose patient is on the high. What is your concern? Your concern is the quality of the organ. First thing, why not consider the ECMO? Consider the ECMO to maintain the perfusion, maintain the organ. Let the team decide. Transplant team can do the liver biopsy to see the quality. If they want the four-phase CT on the way to the OT, you can do that. On the table, they take the again biopsy to confirm. Echo can guide you in the next 24 hours. Repeat the echo and just find out the cardiac function is like. So, yeah, what we need to do is the optimization. Optimization is possible with the so many advanced techniques, so advanced hemodynamic, ECMO, and these things will help you to optimize the donor. Let the transplant team confirm the quality of the organs and go ahead. But don't waste the organ. Even out of 6 organ, suppose finally we landed with the only liver or kidney, I think that is also a win-win situation for the recipient as well as the team. So don't drop your shoulder at any point of this thing. No, this is on the 3 ino topic is not the ideal. I think we should go aggressively to manage that donor if the families are willing. Then the ball is in our court. We cannot deny on the way, and that's why I said there is a concept of the potential donor. This is an ethical concept. Even ATLS has mentioned that if the GCS on admission after the RTA is less than 5, it should be considered as a potential donor. Why not start the optimization from that point of view? Start the see the fluid management, see the electrolyte management, see the infection protocols, put the arterial line, do the ABGs. Again, somebody will say who will bear the cost? Where I have declared him the brain dead, might be that I am trying to save the life. So you cannot say that I am preparing him for the organ donor. I never prepared myself for the organ donor. As a physician, my first choice is to save the life. To save the life, if I maintain that patient, it's a right thing I am doing. So there are pros and cons. If we keep our consciousness intact and do honest and transparent practice, I think we are not answerable to anyone. We should go ahead with the quality donor. Unfortunately, that landed with the brain dead situation.
Yes. Thank you, sir, for the excellent talk and wonderful explanation of the questions. Thank you so much.
Thank you.
For being the right. Thank you, sir.
Thank you.
Now we have the next. Before that, dear participants, kindly post your questions to the question tab, which is there in the auditorium. Now, for the next talk, we have before the next talk, we have some announcements. So now the next talk is by Dr. Shubhal Dikshit. He is a consultant and ICU in charge of Sanjeevani Hospital and Director ICU of Sanjeevani MJM Hospital. And also, all of us know he was a immediate past president of ISCCM. And Dr. Shubhal Dikshit is going to speak about one of the core topics of the ICU, that is acute pancreatitis. So, over to you, sir.
Thank you, Dr. Atul Kulkarni and Dr. Sheel Bhosle for inviting me to talk in this BRITE 2021 program. I've been given the topic of acute severe pancreatitis, and I'll start sharing the screen here so that all of you can have a look at the presentation. So, most importantly, pancreatitis is a very important subject which all of us really need to know about it. And let's start off with a case-based presentation. We have a 32-year-old male was brought to the casualty with a complaints of severe abdominal pain since 3 hours, and the pain started after a party where alcohol was served. On examination, we found that the patient was conscious, anxious, and his was tachycardic and had a blood pressure of 150/100. He was tachypneic with 25 breaths per minute, and a blood gas which was done was normal, and the laboratory investigation showed that the elevated amylase and lipase, they were 5 times than the baseline. And then a diagnosis of acute pancreatitis was made, and the patient was admitted in the hospital for further management. So let us see what are the common causes of pancreatitis. We know that in India, the most common cause is alcohol, but about 30 to 40% of the etiological causes are mainly caused by gallstones, hypertriglyceridemia, ERCP. Post-ERCP is also one of the common causes of pancreatitis. Smoking, drug, infections, trauma, as well as vascular disease can also give rise to pancreatitis. The etiologies of pancreatitis, as we saw here, mechanical. It could be mainly because of the stones or the biliary sludge or the pancreatic malignancies or the peripancreatic malignancies or the ampullary of peripancreatic ampullary cancers. Alcohol is most common. You also see sometimes in organophosphorus poisonings or in scorpion bites, and drugs mainly metronidazole or tetracycline, sulfur drugs, chemotherapy drugs mainly in the form of asparagines, and immunosuppressants mainly azathioprine or anticonvulsants, valproic acids are mainly responsible. We know that the blood trauma abdomen can also give rise to a pancreatitis or sometimes even a post-ERCP can also precipitate acute severe pancreatitis. Infection-wise, common is mumps or Coxsackie virus or cytomegalovirus infections, or even HIV or even antiretroviral drugs can also sometimes precipitate acute severe pancreatitis, and certain bacterial infections like Salmonella, Mycoplasma, or Leptospira, or very surprisingly, Aspergillus can also precipitate. Certain congenital abnormalities like pancreatic diversium or the choledococele, also some of the rare causes of pancreatitis, and vascular insufficiencies, maybe pancreatic ischemia, SLE, or vasculitis are responsible. Other certain factors are pancreas or kidney transplant patient or the alpha-1 antitrypsin deficiencies, or in sometimes, majority times, it could be idiopathic. This is one of the rare cause, but you must remember in India, the most common cause is alcohol, and gallstones is important. The etiology, we definitely saw certain genetic. It could also be because of the catatonic trypsin gene, or it could be because of the pancreatic secretory trypsin inhibitors, or sometimes in cystic fibrosis, transmembrane conductase regulators. But there is a mnemonic which can also help us to remember is G is for gallstones, or the GS is for ethanol, trauma, steroids, mumps. A is for autoimmune, S is for scorpion or venom, E is for ERCP, and drug is for the various kind of drugs which are important. So for the diagnosis of acute pancreatitis, there has to be a typical epigastric abdominal pain, sometimes associated with back pain, which is very important. These patients also can have diffuse abdominal pain. They may have vomiting, and this patient has an acute onset of pain. There is elevated serum lipase and amylase activity, which is more than 3 times to 5 times. And we also find characteristic CT findings, where I will show you in the due course of time what are the various findings since are seen in the patients of acute pancreatitis. Now, the diagnosis most commonly is established by 2 of the 3 following criteria. As we saw that abdominal pain is consistent, usually epigastric associated with back pain, elevated amylase and lipase, which is more than 3 times normal, and there is a characteristic findings on abdominal imaging. And the CT and the MRI of the pancreas should be reserved for patients. In case there is a diagnosis uncertainty, there is a typical pain where you find a normal amount of enzymes, and in acute severe pancreatitis to distinguish from interstitial or from necrotizing pancreatitis. So those who fail to improve clinically within the first 72 hours after hospital admission, and to evaluate local complications. Mind you, initially in the first week, ultrasonography plays a very important role. And usually at the end of first week, usually the pancreatitis pictures start coming up. An acute abdomen, doing a CT scan on first 24 hours, sometimes the findings may be best, but ultrasound needs to be done, mainly for the diagnosis of gallstone pancreatitis, because this is one of the indications where you may have to consider for a surgical intervention early in the course of disease, in case if there is obstructed stones, but you need to rule out with a surgical opinion. The symptoms, as I told you, majority of these times, they definitely got fever. These patients have got physical findings of tachycardia, there is abdominal tenderness, there is muscle guarding as well as rigidity. The bowel, sometimes there could be abdominal distension, and also because of the gastric and the transverse colonic ileus, and guarding is present. And some of the patients may also show jaundice, which is seen about 28% of the patients. But very characteristically, some of the symptoms, as I told you, there is also the trademark or the theoretical way. There is the Monders symptom, is the voided spots on the face and the trunks. We can also see the Halsted symptom, that is cyanosis, which is seen of the abdominal scene, the gray symptom, which is a cyanosis of the lateral walls, and the Kellen symptom, which is the yellowing discoloration, which is seen near the belly button. The symptoms, as I told you, is the Corsi's symptoms. It is a painful resistance as the lumbar bar in the epigastric region of 6 to 7 centimeters higher to the belly region. Or sometimes the Blumberg symptom, which is seen in patients with acute pancreatitis, is more frequently a lower grade. Mind you, these symptoms are maybe of more theoretical way, but definitely the clinical history, taking a proper history is very important of acute abdominal pain. You should ask the history of having a binge or if he's a chronic alcoholic. And you can also see a typical absence of peristalsis because of colonic and gastric distension. So clinical history for diagnosis along with symptom plays a very important role for it. Now, the physical examination, you can see the gray Turner's sign. The gray Turner's sign is the ecchymosis, which can be seen in one flank or both the flanks, which is typically which can be seen in a similar way in the pictures what I'm showing you. There's a Cullen sign, which is a ecchymosis in the periumbilical area. You can see here from the picture that there is a Cullen sign in the periumbilical area, and this is associated with necrotizing pancreatitis, and it has got a poor prognosis. It occurs in about 1% of the patient. And certain absolute signs which can be seen are the Maunders sign, what I told you. They're the wildest spots which are seen on the body and the face, or the Holstead sign, which is cyanosis of the skin of the abdominal wall, and also maybe because it's maybe seen because of increase in abdominal pressure, which also causes a certain amount of compression and perfusion of the cutaneous skin. And there is also the Grunwald sign, which is the petechial skin rash, which can be seen in the navel areas. So the radiological findings are more important. You can sign, which can be seen on the X-rays, the sentinel loop. You can also see the colonic cutoff because of the paralytic ileus and the distension, which is commonly seen. There is a loss of the psoas shadow, which is important. Certain gallstones can also be radiologically significantly seen, and multiple calcifications, if it's acute or chronic kind of pancreatitis, multiple calcific pancreas can also be seen. And you can have bilateral effusions. More commonly left is more than the right. So this is the typical X-ray findings. What we see here, there's a colonic distension or a colonic kind of cutoff. We also see abdominal distension of the where abdominal gas filled abdomen, which is seen. And the differential diagnosis of this type of sign could be a pancreatitis, it could be an inflammatory bowel disease or a toxic megacolon, carcinoma of the colon. It can also be seen in obstruction, but mind you, more importantly, there are no air fluid levels, which is a diagnostic, or mesenteric ischemia, which can also be used as a part of diagnosis, where you can definitely see a thumbprint kind of impression, which is seen especially into the mucosa, which is very commonly seen here. Now, cholecystitis, and this is very, very commonly seen. The radio halo sign or the normal or the radio halo sign, which can be seen here now. This is the typical radio halo sign, which is seen into the kidney area, that is the perinephric area. We can see the black spots or the black kind of fat kind of discoloration, which can be seen. This is commonly seen as the renal halo sign. And this has to be the gas, it should be not a distended abdomen. The radiologists really need to look very, very, very classically, and it is mainly seen very classically on a CT as compared to the sonography. Now, the classification of pancreas, various pancreatic classifications were taken into consideration. This was a publication which was published way back in 2012 by Dr. Peter Banks. And the main significance of this study was the Atlanta classification of pancreatitis in 1992 was updated. So definitely they wanted to update it. And the two types of acute pancreatitis have been described as acute edematous pancreatitis and necrotizing kind of pancreatitis. And the description of the pancreatic and the peripancreatic corrections was quite confusing. So what are the new findings? The current global consensus classification, it all gives you a comprehensive classification of pancreatitis, the severity, and also takes into account the peripancreatic collection. And this new information of etiology, the pathophysiology, and the radiological descriptions, which can be seen. And this classification helps you to differentiate acute pancreatitis from acute pancreatic fluid, a pancreatic cirrhosis, acute necrotic collections, and also from a Waldorf kind of a necrosis. So as I said, the two types of pancreatitis which is seen, interstitial pancreatitis as well as necrotizing pancreatitis, the severities may be classified into mild, moderately severe, and severe. And the definition of pancreatic and peripancreatic joint collections could be seen, the new information of etiology, and it helps you to differentiate peripancreatic fluid, the pancreatic cyst, acute necrotizing kind of collection, or any ward of necrosis, which can be commonly seen here. The old 1992 Atlanta classification maybe had mild pancreatitis in 80% of the cases, and acute severe pancreatitis, which accounted for about 20% of the cases. But the revised Atlanta classification had definitely a mild pancreatitis where there was absence of organ failure and absence of local complications, where moderate to severe pancreatitis had local complications of swelling or a peripancreatic fat stranding, and there was a transient organ failure, and severe pancreatitis was mainly defined with persistent organ failure for more than 48 hours, and there was associated find of death. While in the older classification, definitely there was organ failure, there was shock associated, there was hypoxia, which could also be seen, but they revised it into a persistence of organ failure, which is lasting for more than 48 hours and which can give rise to death into these patients. So the revised classification, as I told you, it is mild, moderate, and severe. Mild is just no local complications, and severe, there is a persistence of organ failure at the end of 48 hours. The local complications include the peripancreatic fluid collections. It could be a pseudocyst formation. It could also be the necrotic collection, or it could be a third space pleural effusion, which is seen more commonly on the left. And the organ failure, the mainly organ dysfunctions, which is seen here, is the respiratory because of the effusions which get collect, the cardiac because of the increase in abdominal pressure or because of shock or because of hypovolemia, as well as the renal failure or hepanological and neurological could be mainly because of sepsis or hypoperfusion kind of state. The Atlanta classification was defined as organ dysfunction where there was a systolic blood pressure of less than 90, was associated with pulmonary insufficiency with the PF ratio or the hypoxia of PO2 of less than 60, renal failure with creatinine of more than 2, and was associated with GIT bleed of more than 500 ml per 24 hours. And the local complications, there was pancreatic necrosis in 30% of these patients, so there was a well-circumscribed lesion in the form of an abscess or collection of pus with little amount of necrosis, and a pancreatic pseudocyst which is formed as a collection of a fibrous tissue along with certain fluid with later in the course of the disease, and the Ranson score of more than 3 or Apache score of more than 8 was taken as a part of calculations. Now, the revised definitions of morphological features of pancreatitis, yes, there were acute interstitial find and the contrast enhanced CT scan, but without any evidence of tissue necrosis. And here, the pancreatic enhancements could be seen by intravenous agent, but there was no peripancreatic necrosis, and the necrotizing pancreatitis is mainly associated with pancreatic swelling. There is a parenchymal amount of necrosis, or there is also a peripancreatic necrosis, but mind you, there is a lack of parenchymal enhancement, which is seen on IV contrast, and the presence of the peripancreatic necrosis. And acute pancreatic fluid collections. Now, these fluid collections usually associated with interstitial edematous and is not associated with peripancreatic necrosis. And this term is only applies for areas of peripancreatic fluid, which is mainly seen within the first 4 weeks after the onset of interstitial edematous pancreatitis without the features of a pseudocyst. Pseudocyst, mind you, it comes later in the course of disease as the pancreas starts healing. And the criteria on the contrast enhanced CT, it occurs in the setting of acute interstitial edematous. There could be a homogeneous collection with the fluid density, which is confined by a normal pancreatic facial planes. There is no definable wall capsulating regions, and adjacent to the pancreas, and there is no intrahepatic extension which can be seen. And sometimes you can also see a wall of necrosis, which is called as a WAN. And here you can see a heterogeneous air as a liquid. That is definitely a wall of necrosis, which can be fluid with fluid. There is a well-defined wall which can be seen, which is completely encapsulated. It could be intrapancreatic or it could also be extrapancreatic. And the pseudocyst collection, this is of course an encapsulated collection of fluid, which is after the sequelae of pancreatitis where it starts healing, is usually associated with or without necrosis. And this usually occurs more than 4 weeks after the onset of interstitial pancreatitis. This is lesions on a CT scan, is seen in well circumscribed, quite oval, homogeneously filled, well amount of liquefied component, well-defined wall is there. Usually it depends upon the size of the lesions, how and when to intervene as far as the treatment. And necrotic collection, definitely both fluid as well as necrosis can be seen here. And this peripancreatic collection occurs as a part of abscess form. There is no definable wall and the localization which can be seen. So more importantly, if you see the severity is defined as mild pancreatitis or moderately severe pancreatitis or severe pancreatitis acute, where there is a persistence of organ failure, either single or multiple, which is lasting for more than 48 hours. That's important. So how the severity of the scores? The various scores have been taken into consideration: the BICEP score, the Ranson score, the Glasgow score, the Apache score. There is also the CT severity score, which are defined by Balthazar's, the modified CT score, the HAP score, the revised Atlanta classification, and also the various assessing the SOFA score and the modified Marshall assessing score. The various scoring systems which took into consideration were organ failures. Basically, they helped us to identify the severity of the lesion. It also helped you to identify whether they're depending upon the collection size, how many lesions are maybe present. It also took into consideration the PF ratio, the third space loss, the calcium levels, the urea levels, the sugar levels, and of course the severity score as per the Apache score scoring, the systemic inflammatory response, and the bedside severity assessment scoring. It was called as a BICEP scoring, and it helped you to grade the pancreatitis. It helped you to predict the mortality, and it also helped you to tell and discuss the and counsel the relative what sort of severities the patient has, and that will help you to plan the course of treatment. The points to remember: mainly these predictive models are intended to predict the severity of pancreatitis. This is used on admission or even after about 2 to 3 days once the patient is being hospitalized. And all models definitely have got a low amount of specificity, but they're mainly useful for a group of patients, and they do not have a high accuracy in giving the patient's bedsides for predicting the regions, but they really help you to counsel the patient's relatives, especially when they ask you questions as far as what is the severity is concerned. So let's talk about the Ransons, which is the age-old, way back from 1970s, which have been using it, and it takes into consideration the age, the WBC count of more than 16,000. If the sugar levels are more than 200, the LDH is more than 350, or the SGOT, HCPT levels are more than 250. And it also 5 parameters were taken, and it uses 11 parameters during 6 hours. That is, whether there's a reduce in the hematocrit value, which is more than 10%, if the urea levels increases by more than 5% despite IV fluids and good fluid optimization. Mind you, now the fluid optimization techniques are much more better. We have got CVP, we have got ultrasound, we have also got the 2D echo, which helps you and guided flow amount or how fluid needs to be optimized. The serum calcium level of less than 8, and if the oxygen level is less than 60, and if the base deficit is more than 4 milliequivalents, and fluid sequestration of more of positive fluid balance of 6 liters. So mind you, in the age-old techniques, when these fluid optimization techniques of ultrasonographies or 2D echo were not available, definitely certain fluids used to be optimized till the patient starts getting an effusion. But mind you, this can now be disastrous. We definitely use the ultrasonography technique and a central venous line to see how much amount of fluid really needs to be given. Now, the Ranson's criteria for gallstones and non-gallstone pancreatitis, definitely Ranson's criteria for pancreatitis is associated with mortality. And we have seen that if the Ranson score is more than 7, then the associated mortality is almost about 100%. So higher the Ranson score, higher is the mortality, and that's what is important. And therefore, you need to monitor it at admission within the first 48 hours. And in case if the patient has got substituted of gallstones, then the age of 70 comes into picture, the glucose levels, and definitely all other features are remaining the same. So remember one thing: higher the Ranson score, higher is the associated mortality, and so on and so forth. And if the parameters are alcohol induced or gallstone induced, definitely these same parameters take into consideration. So in simple terms, Ranson's criteria, it takes into consideration the hematocrit, the blood urea nitrogen, calcium, the oxygenation status, whether the fluid sequestration or collection of effusions has occurred, and whether it is in a positive balance, if more than 6 liters or 4 liters. But mind you, the higher the Ranson score, higher is the mortality, and it helps you to tell you and predict the mortality and also discuss with the relatives. The Ranson's criteria, it represents about mild pancreatitis, the mortality is about 3%, and higher the score, the mortality rate goes on increasing. And however, the larger meta-analysis also found that the Ranson score was a poorly predicted severity, and this was published way back in Critical Care Medicine in 1999. But the Ranson's criteria mnemonics for remembering is the GALA, that is the glucose, the age, the LDH, the SGOT, HCPT, and the WBC levels, so on and so forth. This is a theoretical. I won't go into the discussions. There's also the Georgia law, with the gall or the addition of sugar levels of more than 200, if age is more than 55, if the LDH is more than 350 and the SGOT, ACPT is more than 250, or there is leukocytosis which is seen here, and even at the end of 48 hours, you find that the hematocrit is more than 10%, there is evidence of hypoxemia of less than 60, or the base excess of more than 4, and the sequestration has been occurred by in the form of collection of effusions. So more importantly is glucose, electrolyte imbalance, oxygen, and the hematocrit, and the SGOT, SGPT, IV fluid optimization and pain control, and develop the predictive mortality and widely used in patients applied for patients of acute pancreatitis. The Apache score, as I told you, it mainly has got disadvantages. It is quite complex. It is cumbersome. It does not differentiate between the necrosis part or the interstitial part. And it also does not differentiate between sterile and infective necrosis. And it is a poor predictive value at the end of 24 hours. But more importantly, it has got a net negative predictive value. And also it can be performed daily. So the SIR score, which took into consideration of pancreatitis, where it was associated with mortality as compared to pancreatitis without SIRS, and 25% of these patients with persistent amount of SIRS from admission versus 2%, 0% in those where there was no SIRS. Now, the BICEP score is the bedside assessment. This was developed way back for validation of large number of patients. It took into consideration the blood urea nitrogen level, the mental status, the SIRS, age above 60, and 1 point was awarded to each of these patients into the first 24 hours. And the BICEP score of 0 has mortality of less than 1, while the score of 5 has got a mortality of 22%. So higher the score, higher are the chances of mortality, and the urea and nitrogen needs to be above 50, impaired mental status, there has to be effusion which is present, and the age also needs to be on the higher side. So the harmless acute pancreatitis score, it takes into account the presence of normal hematocrit and normal serum creatinine, and it can be calculated on admission and also has accuracy of almost about 88 hours, while 98%. And the organ-based failures, it is distinguished helps you early within the first 72 hours of admission, and also associated with prolonged hospital stay, increased mortality, and various organ failure scores is the Glorious, Marshall's, Bernard score, the sequential so far, or also the Lodge score, which is taken into consideration, where they take into consideration the PF ratio, the increase in the urea creatinine, the cardiovascular, the systolic blood pressure of more than 90 or less than 90, whether the patient is fluid responsive or not fluid responsive. And for non-ventilated patients, the FiO2 can be taken into consideration depending upon the need of oxygen. And the European Society of Intensive Care Medicine also suggested that if the higher SOFA scores are high, then the chances of mortality is very much on the higher side. And this was also a very important assessment. So they help you to predict mortality or suspect, and it could help you to discuss with the relatives also. The Glasgow Coma score is similar, where they took into consideration, more important, the albumin level percentage of less than 3 or 3.2, but definitely urea, the hypoxemia, the glucose, all the subsequent parameters were the same. And the Bali score also took into consideration the urea nitrogen level, the age, the lactate, and more importantly, the interleukin-6 level. Mind you, we all got interleukin-6 level at the time of COVID, but remember, it's a marker of inflammation. So any form of inflammation, it also helps you to predict the severity of the inflammation. So higher the interleukin-6 level, higher is the possibility of a pancreatic inflammation. So it's a marker of inflammation, which is not only restricted to COVID, but it can also be used in patients of pancreatitis. So the intra-abdominal severities is equally important. Now, the International Association of Pancreatology or the American Pancreatic Association, they recommend the use of these predictive scoring systems in all patients with acute pancreatitis. And whether you use the biceps, the Ranson's, the whatever score, the Balthazar score, the modified CT score, all these, it really tells you to help you to outcome or predict the clinical outcome into these patients. Mind you, if you see the mortality in mild failure is just 11%, and if you find about 5 to 10% there is severe acute necrotizing where there is a 60% of organ dysfunction, definitely the mortality definitely goes on increasing, and especially if there is infected necrosis, the mortality rate goes on increasing to about 15% to 25% depending upon the severity of necrosis or there is fluid collection. Mind you, treatment does only just help you to diagnose, but more important part in the administration and management is how to resuscitate patients, how do you give fluids, how do you give nutrition, and discuss the role of antibiotics, which is very, very important. Fluid resuscitation is mainly done now. As I told you, we have got CVP lines, we have got 2D echo, we have got ultrasonography. We also see the collapsibility of IV fluid. Fluid optimization is very important within the first 24 to 48 hours. You should use crystalloids, which is very important with the help of normal saline or ring lactate at the aim of 5 to 10 ml per kg body weight. And caution should be used in patients who have got renal failure or cardiovascular compromise. And those patients who are presenting with hypotension or tachycardia because of gross hypovolemia, you should be giving these solutions at a faster rate of almost about 20 to 30 ml over 30 minutes, and then increase by about 3 ml per kg body weight for hour for about 8 to 12 hours. In those patients, if you have got severe hypercalcemia, then lactated Ringer solution is contraindicated because it contains calcium, or starch should not be used for resuscitation because increased chances of renal failure or platelet dysfunction. Mind you, you need to have goals of resuscitation, that if the tachycardia should be down to less than 120, the MAP should be about 65 to 85, the urine output should be about 0.5 ml to 1 ml per kg body weight. There should be a hematocrit of about 35 to 45, and the reduction of blood urea nitrogen over the 24 hours, especially if we find that the initial levels are on the higher side. And fluid resuscitation should be done for the first 24 to 48 hours. Over rigorous fluid resuscitation is to be avoided later, because to avoid further third space loss and accumulation of fluid. Mind you, these patients are extremely pain. They have got tremendous amount of pain. Opioid analgesias is very, very useful, and you should use fentanyl about 20 microgram as a bolus and then followed by infusion. A pain control anesthesia or the patient control anesthesia is preferred, and nutrition in pancreatitis in mild patients, IV hydration alone is sufficient, and this can be followed by oral diet as well as tolerated within a week. Only in those patients where we have got severe pancreatitis, these patients require usually nutrition support. Mind you, there is no correlation between the amylase or the lipase levels with the initiation of nutrition support. These patients can also be started feeding early in the course of disease, and you can put in a jejunal tube, and you can start feeding the patients with the help of prokinetics and try to achieve 72% of the caloric, 70% of the caloric goal within the first 72 hours with the help of use of prokinetics, which is there. Mind you, the pain management is equally important. Use NSAIDs in the form of paracetamol. You can use a step ladder pattern to go up gradually in case if paracetamol is not taking part. You can use non-opioid form of codeine, and then further on you can go on increasing the use of high potent opioids, which can be used, or in the step 4, the high potent plus adjuvant therapies can be considered. So mind you, pain relief is equally important. It also takes care of the anxiety, the tachycardia, which is also associated. The pain management, again, I told you, sometimes it can be taken with the help of epidural catheters, or nutrition also needs to be given. And experimental drugs were also taken into consideration, like nitric oxide inhibitors and magnesium. But mind you, pain management is mainly resolved about NSAIDs, opiates, or sometimes epidural anesthesia also needs to be given. The principles of nutrition, as I said, is mainly jejunal and nasogastric is preferred over TPN. These patients should be initiated with clear liquids within the first 24 hours in the absence of any paralytic ileus, which is important. And it should be gradually enhanced to a low residue, low fat of diet. And you should see that definitely those patients who do not tolerate oral feeds, a nasogastric or jejunal tube with high protein and semi-elemental feed, mind you should always use definitely the blenderized or the commercially available formula feeds, and because they are the ones which give rise to less amount of infections, much more tolerated. You exactly know the exact number of calories which are also going to be delivered to the patients. And parenteral nutrition is started only if you do not tolerate the ordinary jejunal food. And sometimes you can also use partial parenteral nutrition to bridge the deficit number of calories which cannot be provided. There is no role, of course, of prophylactic antibiotics should not be used. And if there is a suspicion of infection, definitely extrapancreatic antibiotics may be used. But mind you, blood cultures, inflammatory markers need to be monitored. The procalcitonin can also be monitored for evidence of infection. But if the cultures are negative and a source of infection cannot be determined, these antibiotics should be de-escalated and should be stopped. So mind you, initially, To summarize it in short, start with fluid optimization, give more of fluid about crystalloids, about 10 to 20 ml. In case if the patient is in shock, increase to about 30 ml. My use pain management in the form of fentanyl or pethidine is with the preferred over morphine. Monitor for EBG, hypoxia, urine output, electrolytes, calcium, magnesium. The sugar level should be kept reasonably well to between 150 to 170. And if the patient is in ICU, definitely the bladder, urine output, as well as intra-abdominal pressure monitoring should be done for compartment syndrome. Nutrition should be initiated early with the help of nasojejunal tube. So SOS supplement them with the help of partial parenteral or total parenteral nutrition, and antibiotics only if cultures are positive. And if you're really suspecting infection into the collections, that should be used. So what is the role of imaging into these patients? As I said, the contrast-enhanced CT scan is performed in only moderate and severe kind of pancreatitis. And if you find that there is evidence of sepsis or clinical deterioration at 72 hours after initial presentation, and the evaluation is done to assess the presence of acute pancreatic or extrapancreatic fluid collections or necrosis, or if you find that there is a localized collection, so the number of collections. Mind you, it also helps you to grade the severity up depending upon the number of collections and also the Balthazar score. But as we saw here in the two phases, the first week is the early phase and the second week. Usually it is mainly helpful into moderate and severe form of the disease. But the two types, if you do it early, you can definitely just see about edematous form of collections, which can be seen here, or pseudocyst about 4 weeks. And the necrosis is mainly seen sometimes in severe form of pancreatitis, where there's a necrotic collections, or there could also be a walled off necrosis, which is seen if the duration of the necrosis is for more than 4 weeks. So going further here, after 48 hours, this patient who still complains of abdominal pain, he's been given fentanyl as well as a patient control anesthesia. His demand for analgesia is increasing. He has started getting fever. We have got a CT scan is performed, and it shows there is edematous pancreas and a collection which can be seen in the tail of the pancreas. Because of the pain, the patient is restless, and he also starts demands to be on oral feed. The CT scan which is done, it shows the Balthazar scores as well as the necrosis score, and the severity scoring. It mainly tells you if the grade A, if there's a normal pancreas, the score is 0. If there's just a focal or a diffuse amount of enlargement of the pancreas, the score is just 1. If you find that there's a peripancreatic inflammation with no abnormality, score of 2. If you find that the fluid collections are within or just outside the pancreas, the score is 3. And if there are 2 large collections within the pancreas and also involving the retroperitoneal area, the score can be 4. So the Balthazar score, it gives you grade of A1 to A, B, C, D, E, depending upon the number of collections, whether it's a localized form or just edemized. So higher the score, then the severity also goes on increasing. It also tells you that you're dealing with a severe form of pancreatitis. And this pancreatitis score, it also tells you the presence of necrosis. Necrosis is mainly absent if the score is 0, and the necrosis percentage goes on increasing as the scores goes on increasing from 2 to 6, and the maximum is approximately, you can predict it to about more than 50% of the pancreas in necros if you find the CT severity score is more than 6, which is there. This is mainly calculated by adding of the 2 scores for a maximum of 10, and the CT severity score of more than 6 indicates severe form of disease, mainly, as I said, depending upon the local inflammation of pancreas, whether there's a peripancreatic fat necrosis, whether there's a single collection, or whether there are more than 1 collections, and also associated with extraintestinal complications, or like in the form of effusions, ascites, or vascular or GIT complications. So what is the approach and how you should deal with these local amount of complications? Is there any role of antibiotics, and when you should start antibiotics, and how it should help you to guide the treatment? The complications of pancreatitis, as we saw, local. It could be acute fluid collection. There could be necrosis, which can be seen on a CT scan or a sonography. You will have development of pseudocysts later in the course of disease. There will be a pancreatic abscesses. There will be a portal vein thrombosis or splenic vein thrombosis, or sometimes a vascular pseudoaneurysm may be formed if you have a collection with the artery. But more important is the systemic form, because the systemic complication sometimes kills. There could be ARDS. There could be atelectasis, pneumonias, hypotension. These patients also develop a polycirrhosis and a pericardial effusion. There is a coagulation abnormalities in the form of DIC, acute tubular necrosis. There could be sepsis-induced encephalopathy and subcutaneous fat necrosis, which can also be seen. So these fat necrosis, if you find that there is an interstitial amount of necrosis here, then The acute pancreatic collections can be seen if less than 4 weeks, and if more than 4 weeks, there is a pseudocyst collection. And if there is a necrotizing pancreatitis within 4 weeks, you have a necrotic collection. And if the duration of the necrosis goes on increasing over a period of time, you'll get a wall of necrosis. Now, these four, whether you have got a pancreatic collection, which is acute less than 4 weeks, or a necrotic collection, which is again less than 4 weeks, a pseudocyst, or a walled off necrosis, these all can be diagnosed with the help of a sonography or a contrast enhanced CT scan. It helps you to plan the further course of action, whether these patients require surgical intervention, whether these patients can be managed purely with the medical management, and how and further it should be taken, and the onset, whether the imaging features have shown a fluid attenuation, whether there are retroperitoneal structures which are involved, whether the fluid collections is well circumscribed. Depending upon that, we call it acute localized necrosis or a pseudocyst or a walled off amount of necrosis. And these are the typical features which can be seen into these collections. But these local collections, whether these develop early or they do not have a well-formed necrosis, these local collections sometimes are asymptomatic and they can resolve on their own within about a period of 7 days to 10 days. Or necrotic collections, which can also see the second part, these usually occur after the second week, and the patients will have signs of infection. There could be a certain amount of fever or gas, which can be seen also into the necrosis and also can be seen in CT. These patients require antibiotics, mind you, carbapenem or imipenem alone, or in combination with ceftazidime or cefepime is required. These patients sometimes also need to be considered for a necrosectomy, and these necrosectomy should be performed with minimally invasive endoscopic surgeries or percutaneous form of drainage. We should avoid surgical intervention because early interventions of surgeries, definitely the mortality rate goes on increasing. And if you are dealing with the infected necrosis, mind you, there is a sterile necrosis, antibiotics have been used early. These are usually rare within the first week. They increase the morbidity or the mortality, and the need for antibiotics and active intervention is equally important. Usually, I told you in 60% of these patients, conservatively necrotizing pancreatitis can be treated, but certain patients require a surgical or endoscopic intervention in about 40% of these patients, and these are usually called as pancreatic abscesses. You should send cultures, then antibiotics in the form of carbapenem should be initiated. And our patients, and we saw that we initiated feeling, we complained of abdominal distension, hence he was kept NBM. We definitely saw that the abdominal distension was increased. The X-ray chest showed effusions, the abdominal girth was increasing, it was quite tense. And for the past 3 years, we also found that the urine output is also decreasing. Mind you, it's important, it's a part of a compartment kind of syndrome these patients can also develop because of gaseous distension, and it could also compress the kidneys and also reduce the GFR, and that's why the urine output may also start dropping down. So what are the characteristics of the pleural effusions which can be seen? Typically, they are small, usually in about mild form, but usually more common are left-sided, sometimes bilateral in about 20% of these patients, usually clear. Sometimes in severe forms, it could be hemorrhagic, and they are definitely exudative, where the protein component is more than 3, and the amylase levels are definitely high, more than 1000. Usually the causes are because of the blocked lymphatics which are traversing the diaphragms, or because of the leak from the pancreatic duct, or because of the pancreatic pleural fistula which is there. Now, as I told you, the management of local complications, usually these effusions or peripancreatic collection don't require any treatment. Sometimes if a pancreatic necrosis is there, you need to have antibiotics started. You should do a CT scan or ultrasound guided aspiration or necrosectomy, send for cultures. Or if there is a vascular complications in the form of splenic vein thrombosis, where you definitely, if they are symptomatic, you should use anticoagulation. You should monitor the compartment pressures with the help of the Abweisser or the intravesical pressure, which equals to that intra-abdominal pressure. And this is a sustained increase in the intra-abdominal pressure of more than 20 with a new organ of onset of dysfunction. Definitely, you have to have a very careful observation. You need to see how to reduce these compartment pressures, because increased intra-abdominal hypertension can also produce a variety of syndrome of called as compartment syndrome. It may also hamper the venous return. It can also precipitate shock. It can also reduce the GFR by causing compression pressure onto the kidneys. So the grading system of these injuries, the acute gastrointestinal injury, this was defined way back by the ESICM in 2012, that is the GIT function in the intensive care patients. And this was a lovely paper which was published, and this was published by Manu Balbrain, who also runs the conference of the intra-abdominal hypertension, the acute GIT injury, there's an increased risk of development of a GIT failure. If the grade 2, this requires intervention to restore the GIT functions. J3 means that there is gastrointestinal function which cannot be restored even with intervention. Mind you, these patients require monitoring with the help of intra-abdominal hypertension. You should exclude the undiagnosed abdominal problems of cholecystitis or bowel ischemia. And the last is definitely GIT severity is a life-threatening amount of GIT complications. So the guidelines, as I told you, for diagnosis or management of acute gastrointestinal amount of complications of ischemia, 80% of these patients, you should give them feed. I find you enteral feeding 80% of the caloric yield. If you cannot give them, the patient is in shock, see whether the patient is in shock. If yes, you reevaluate and start them very minimal amount of fluid of just 20 ml. But if the patient is not in shock, and if you can see here that if the EF ultrafiltrate is definitely contraindicated, if GIT symptoms are present, so definitely you should reevaluate whether feeding can be given or if feeding cannot be given. If you can feed the patient, definitely if the peristalsis is there, you should continue to feed them. But in case if you can't feed them, definitely don't stop feeding. See for there is no hemodynamic shock, you can use prokinetics and start monitoring the intra-abdominal pressure and continue to feed them with the help of prokinetics. But mind you, every minute of time, you have to see that you give small feeds, consider post-pyloric feeding with the help of prokinetics and try to achieve the caloric goals, or sometimes supplement them with partial parenteral nutrition. So most important into these features is what is the intra-abdominal hypertension and how we do measure it. As I said, intra-abdominal hypertension is going to be defined as there is a steady increase in the abdominal pressure. And this increase in the abdominal pressure of 5 millimeters to 7 millimeters in the adult ICU, and intra-abdominal hypertension is when defined. And if there is a persistence of these pressures of more than 12 millimeters of mercury. And as I said, we have the intra-abdominal hypertension and the compartment syndrome. There were the consensus guidelines. So you need to, which were published by the European Society of Pediatric Neonatology as well as the ESICM, and they retain certain definitions. The intra-abdominal pressure is a steady state of increased pressure concealed within the abdominal cavity. So you need to monitor it. It can produce a variety of other symptoms and can also produce a hemodynamic compromise. And the consensus, they gave you a definition of intra-abdominal hypertension and they graded it from grade 1, 2, 3, 4, 5. And definitely increased pressures is mainly associated with complications. So you need to monitor the intra-abdominal pressure into patients who have got abdominal distension, where there is a definitely a gut ischemia, in acute severe pancreatitis, severe form of ascites, and it also helps you to predict and also plan if those patients will require surgical intervention so as to reduce the intra-abdominal hypertension. Various abdominal hypertension also takes into consideration the abdominal perfusion pressure, like the cerebral perfusion pressure. The mean arterial pressure is also taken into consideration, and the abdominal perfusion pressure is equivalent to the mean arterial pressure minus the intra-abdominal pressure. So you have to maintain it. The intra-abdominal hypertension grade 1 is about 12 to 15, and as the levels go on increasing, if it's more than 25, it is called as abdominal compartment syndrome. And any given of time, you have to see that the pressure remains below 12, and gradual increase is definitely warranting us for complications, and you have to monitor it. And you have to see that as the abdominal pressure goes on increasing, you not only monitor the pressure, but it is also associated with organ dysfunctions in the form of sometimes hepatic injuries. It also associated with increased reduced GFR. And therefore, there is increase in the urea levels and the creatinine values, which also goes up. The primary intra-abdominal hypertension is defined as which developed due to injury of a disease into the abdominal pelvic area, and this requires interventions either surgical or percutaneous. And secondary is mainly cause is not present into the abdominal pelvic area, and this intra-abdominal hypertension is defined as I told you, or the abdominal perfusion is the mean arterial pressure minus intra-abdominal hypertension. So the risk factors which are there, decreased compliance of the abdominal wall can also occur following a laparotomy, if there are major burns, face scars, if the patient has got trauma, if the patient is in prone position, And sometimes if the abdominal contents in acute pancreatitis, there is intra-abdominal fluid collections in the form of ascites or peritonitis, abscess, increased contents into GIT lumens if you have found gastric distension, or there is a valvulus, or there is a massive amount of capillary leak or a positive fluid balance, mind you, increase in the abdominal pressures, like sometimes a positive mechanical ventilation of the P that can obesity, all of these increase in the fat tissues of the abdominal muscle wall that can also give rise to increase in the intra-abdominal pressures. So you need to monitor it. You need to see that any or no organ dysfunction mainly occurs. The risk factors, which as I said, is mainly because of gut ischemia. There could be gastroparesis. It could also be associated with pancreatitis, ascites, also with liver dysfunction and cirrhosis, and definitely increased PEEP levels of more than 10. But mind you, whatever it is, you need to monitor it. That's more important. It can also give rise to large amount of complications in the form of shock. It can also give rise to a decreased fluid overload. It can also sometimes give rise to decrease in the cerebral perfusion pressures, and the patients can also get confused. And the refractive fluid overload, which occurs from abdominal hypertension, as I said, because of over-resuscitation, there is a volume overload, and this can also give rise to ascites because of a third space loss. Because of intra-abdominal hypertension, the GFR gets compromised, and the patients land up into renal failure. You again, at this time, you give diuretics, then there's ongoing volume resuscitation. So it's a vicious circle in which you definitely get entangled. So you need to monitor it directly or indirectly, as I told you, with the help of intravesical pressures, or sometimes indirectly the stomach pressures also tell you that is intragastric catheters. But the most important is the direct or the peritoneum or the intraperitoneal kind of devices which we use. The consensus statements recommend that studies of intra-abdominal hypertension, abdominal compartment syndrome, they adopt the trans-bladder technique as a standard intra-abdominal pressure monitoring technique. Is quite cheap. You can have the advisors which are available in which you can monitor it, or sometimes if you really want to do it the cool way, you can monitor it exactly the way how you monitor the CVP into these patients. So this is the device which is easily available to monitor the intra-abdominal pressures, and you should have a chart as what you keep for the CVPs. Increase in the abdominal pressure, you should also take a gastroenterological and gastrosurgical opinion whether these patients also require any interventions. And these compartment syndrome, as we said, there is a sustained increase of more than 20 with or without an abdominal perfusion pressure of less than 60 is associated with organ dysfunction. And we saw here definitely increased abdominal pressure. There is a vascular compression, decreased venous return. There could be venous stasis. There could also be the DVT. There could also be a decrease in the cardiac preload. Therefore, the MAP levels go down, or the systemic vasculature resistance also goes up. Because of the cardiac complications or the cardiac compromise, definitely the CVP levels goes up increasing. And because of this, again, there is a decreased cardiac contractility. This patient's cardiac output goes on decreasing. Patients may also get precipitation of shock. There is organ compression. Therefore, renin-angiotensin system of the ultrasound goes on increasing. There's a systemic overload. The cardiac output goes on. So it's a vicious circle which usually gets compromised. More important, remember, vascular compromisation, organ dysfunction is the most important key where you need to see it. The balance keeps on swinging. You should definitely see the abdominal pressure remains normal. It should be definitely the normal pressure is about 0 to 10 millimeters of mercury. See that the pressure goes on increasing, and definitely management also requires sedation, analgesia, neurovascular blockade. The patient should be kept definitely calm and cool. You should give diuretics, but see that the patient is not given high amount of diuretics. You should fluid optimize the patients and avoid a positive fluid balances. Give a proper body positioning. You should use a continuous renal replacement therapies. A nasogastric or a podonic decompression should also be considered, or a percutaneous drainage should be used. Or in those patients, sometimes surgical intervention should be considered with the help of temporary abdominal closure techniques in those patients who require. Sometimes if it's a pancreatic surgery, they need to keep the abdomen open. Also in certain amount of situations in order to control the intra-abdominal hypertension. So in view of the shortage of time, I won't go into the details of it. This is easily available. Mind you, you really need to monitor the intra-abdominal pressures, look for any organ dysfunction. And if there is increase in the pressure, please take a gastroenterological and a surgical opinion, and definitely try to consider for early surgical intervention, which is equally important. And the indications of ERCP into these patients, as I said, if you have a bile duct or a bile stones with severe pancreatitis, or if there is cholangitis, these are poor candidates for early cholecystectomy or post cholecystectomy. And there is evidence of a biliary obstruction persistently, which can also be diagnosed by an MRCP. These are the patients where definitely you can consider to do an ERCP. But the contraindications of doing a ERCP in acute pancreatitis is definitely if you have got a suspicion of retained bile stones, or definitely if you have got a cholecystectomy which is being planned. So mind you, ladies and gentlemen and students, acute pancreatitis kills. You need to diagnose early clinically, take a proper history. It's a multiple organ failure dysfunction syndrome which can occur into these patients. These patients require good amount of analgesia monitoring. These require good fluid optimization. These patients require nutrition, use antibiotics judiciously, definitely monitor for local complications, local collections, and also for systemic complications. If they are there, definitely you should monitor the intra-abdominal hypertension, keep the intra-abdominal hypertension well under control. If not, definitely take for early surgical intervention to reduce the intra-abdominal hypertension so as to avoid the complications, and try to reduce the morbidity and mortality into these patients. So thank you very much. And I would
Thank
Sheil,
you, Dr.
uh,
Subal. Yes, sir.
Sheil, uh, just wanted to talk to Subhal about uh, the concerns expressed by some of the delegates. Um, Subhal, they want to know if there is no tracking number or anything for the books that they have ordered. So maybe we need to talk to CBS and give some sort of
No,
acknowledgement.
the tracking,
Yeah, please go on.
yeah, the tracking number, talk to them. Yeah, number, I will just talk to
Yeah, talk to CBS and please
will be
ask
getting a
them
tracking
to
number so they can
reassure
track the
our.
order to CBS.
Yes, yes.
Yeah,
Okay, okay.
yeah, I will ask them to write to everybody personally that
Yes.
your order has been confirmed and it's in the you receiving the book. And we'll also confirm the delivery address what they have mentioned. I will talk to CBS.
Okay. Thank you so much. She'll please take over.
Yeah,
Yeah,
CBS can get the details from our
yeah.
database. So, Dr. Subal, it was an amazing and a quite comprehensive presentation of pancreatitis as well as compartment syndrome. We have got a couple of questions. I'll start with the first one is by Dr. Rashmi. Is aggressive fluid resuscitation useful if patient has presented after 48 hours? Or do you only use maintenance strategy? And if you are using fluids, what are the markers of fluids that you are using? Whether you use PPV, whether you use ultrasound, how do you guide fluid therapy in such cases?
Basically, fluid therapy is given with the help of fluid optimization, with the help of CVP, and by monitoring with the help of ultrasound. We see for the inferior vena cava collapsibility. So, initial first 24 hours of fluid resuscitation is very important. In patients of pancreatitis. So, once after fluid optimization in the first 24 hours, monitor the urine output, monitor the CVP, try to maintain the CVP about 10 to 12 centimeters, and look for the inferior vena cava collapsibility. That's the
Okay.
easy way to fluid optimize these patients.
Okay. Dr. Rajat is asking, can you once again repeat the clinical signs? I think he probably must be meaning that since there are so many, scoring systems and, assess the severity of disease, what do you actually look at in terms of assessing the severity? Do you look at the the quantification of the serum amylase lipase, like the amount of lipase increase, does it really correspond to the grades of severity of
No,
pancreatitis?
no, the amylase lipase just help you for the diagnosis. They do not actually per se contribute to define the severity of the cirrhosis. Severity of cirrhosis depends upon the percentage of necrosis which is there on the CT, whether evidence of necrosis or intellectual effusion in the X-rays. The amylase and lipase have got no correlation with the severity of the pancreatitis.
Correct. Yeah. So, are there any other biomarkers that you look at? Because literature does mention looking at procal, CRP. We have looked at neutrophil lymphocyte ratios in
Yeah,
COVID, but
CR,
yeah, yeah, go on, go on.
see CRP and all CRP or procalcitonin. Basically, CRP is a marker of inflammation. That's one. Procalcitonin initially is a marker of inflammation, but later on, after the second week, if the patient starts getting fever, it also helps you find whether any element of cyst which is being in the or pancreas help you to help of culture. See, antibiotics very find the amount of necrosis and prophylactic.
I think your voice is breaking, Dr.
Hello.
Subal. We've got you back. Yeah.
Yeah, yeah, yeah. So, yeah. So basically, procalcitonin will define any element of secondary infections which have occurred, and it is again a marker of inflammation. CRP is again, and therefore a marker of inflammation is this. Again, procalcitonin will be helpful if necrosis is present, and in the second week onwards, if any secondary infection is occurring.
Okay. So Subal, there's another question regarding the book, that there are some delegates are not able to book the textbook. It says that the book is out of stock. So the CBS
No, no.
publication need to,
I will talk to them. Everybody, you can just book your orders, and you can definitely everybody will get the books. So
yeah.
you need not worry about it.
Yeah. So because when they are trying to order it, it is saying out of stock. So maybe it
No,
needs
no,
to.
no. I'll definitely talk to them, and we'll definitely get it rectified. You don't
Okay.
have to worry. Yeah.
Okay. I think we don't have any more questions. Last question, just for the benefit of the delegates, is: do you wait for the pain to subside till you start enteral feeding, or how do you plan that? Dr. Subal, your voice is, yeah, you're not audible. Okay, I think because of the difficulty in the network, I think we'll move on. We can't hear Dr. Subal, so please try and book the textbook, because they probably will reactivate the link if some folks are not able to pre-book their textbooks. So we move on to the next topic, and that is the traumatic brain injury. And for that, I would like to invite Dr. Pratima Ramachandran, and she's been quite gracious enough to accept our invitation and help us in this topic. So sure, Dr. Pratima is a consultant at Apollo Specialty Hospitals in Chennai, and her area of expertise again is trauma. So she will be speaking us about traumatic brain injury. Over to you, Dr. Pratima.
Good day, everybody. Happy to join and be a part of this BRITE course. I hope it is as bright as it sounds. And this topic had been very close to heart for me because my area of interest is neurocritical care, and it had been a very nice job satisfying field. So we will go into this session of traumatic brain injury without much delay. So neurocritical care is a very job satisfying field because we can help a lot of patients. The outcomes are really very heartening. So traumatic brain injury had been a silent epidemic of modern times. As we know that it is a very high third leading cause of death and a major cause of permanent disability worldwide. I know you heard me saying worldwide, not only in India, it's been worldwide. So it has an enormous impact on the social and economic situation of the world. So if treated appropriately, better outcomes are really heartening. It is going to be a very challenging field, but is very job satisfying. So objective of traumatic brain injury management is based on Brain Trauma Foundation guidelines, which is the 4th edition, latest is in 2016. You all can go and have a look at it. It is extensive and very nice guidelines which we can apply it in our day-to-day scenarios of neurocritical care. So management is mainly by control or monitoring of the intracranial pressure, and we can have to avoid the intracranial hypertension and maintain the cerebral perfusion pressure. So what do we do is we ensure adequate oxygen delivery to the injured brain tissue. So brain should be happy with good perfusion and good oxygen. What is a pathophysiology? So traumatic brain injury had been a very common scenario to all of us, and of course we know the pathophysiology, but it is to instill the same kind of language which we hand over and take over, and this has to be running in our mind for any scenario in neurocritical care, not only in traumatic brain injury. But whatever it is, we'll just start with the pathophysiology so that we brush upon before going into our case scenario. So pathophysiology of brain injury is like any alteration in brain function or other evidence of brain pathology caused by an external force. So we start with a brain injury, primary brain injury. So primary injury happens at the point of accident or the site of accident or the impact. So what happens is there is activation of, once the injury happens, there is activation of biomolecular mediators of the injury that causes a neuronal damage. So neuronal damage progressively happens. There is edema, more edema, cytotoxic edema. So what happens is there is a lot of cerebral vessel damage. And of course, the blood-brain barrier is breached. There is increased interstitial fluid and tissue pressure. So tissue pressure increases, interstitial fluid increases. So there are a lot of vasogenic edema. So there are two types, as you can see. One is cytotoxic and vasogenic. So it mounts up and out and it causes a decreased cerebral perfusion pressure. So what happens is when there is a edema and there is a lot of inflammation going on, there will be increased cerebral blood flow, and that cerebral blood flow increases the volume, which increases the intracranial pressure. So intracranial pressure with vasodilatation together causes decreased cerebral perfusion pressure. So what happens? So this is something which we cannot prevent because it has already happened. But what we can do is we can avoid or control the secondary brain injury. So what is secondary brain injury? Secondary brain injury is a direct consequence of the primary brain injury. So it is ongoing ischemia, and there will be a lot of release of excitatory neurotransmitters with cellular energy failure. And there's this, if it proceeds, causes a cascade of neuronal death, again cerebral edema, inflammation. So brain starts swelling, it becomes really angry and upset, it starts swelling and swelling. So primary injury has already occurred. So what we can do is, if we could try and control the secondary brain injury from happening, or we can keep it controllable, we can heal the brain faster and we can make the brain happy. That's what our total objective is about. So primary injury has already happened, and we are trying and preventing or controlling or the secondary brain injury, which is happening at a greater scale. So primary injury, as I said, it can be anything. So at the point of impact, there can be hematoma, hemorrhage, or something called a diffuse axonal injury. So diffuse axonal injury is when there is not one point of injury and it is like spread all over the brain, and the person is not having a conscious level which is matching with the imaging. So diffuse axonal injury, there is no particular imaging finding, but we can definitely know that it is not correlating. The consciousness is not correlating with the imaging. And the secondary injury, of course, as I described earlier, is ischemia, excitotoxicity, increasing inflammation, and release of pro-inflammatory cytokines and other neurotransmitters. So what are the causes of secondary brain injury? This has to be like our day-to-day mantra in our mind when we deal with neurocritical care patients. So what causes secondary brain injuries? Hypoxia, ischemia, hypotension, seizure, increased temperature. These all irritates the brain, makes it more angry and upset, causing brain compression, and there will be increased intracranial pressure. Hematoma expansion can increase the secondary brain injury, leading to a lot of cerebral edema and neuronal death. That's what we don't want to. So what do we have to do about it? So we will go with a case scenario. So that is Miss X. I don't want to name any person, so we'll keep it as Miss X. So 26-year-old female, she was brought to the emergency, or actually we got an emergency call saying that there had been a road traffic accident and a 26-year-old female is injured. She was unresponsive on the spot, and there was bleeding from mouth, nose and right ear. So vitals are 150, 100 of blood pressure. Heart rate was 120 per minute and saturation was 90%. But there was no obvious chest or limb injuries, which is fortunate for the patient. So the ambulance rushes to the point and we see the patient on the floor. So what next? So why I come with this scenario from the place of accident is that the trauma guidelines say that the best outcomes are achieved when the care starts at the pre-hospital setting. So what do we do? And time is brain. So what do we do in the first 1 or 2 hours really matters in the outcome. So deaths occur at 3 points in time after the injury. Either it is immediately after the injury, which we cannot do anything about, or within 2 hours after the injury, or 3 weeks after injury. So after immediate, if the death happens, we cannot control that, but the other things are a little controllable. In first 2 hours, if we put our best effort and do whatever is needed to prevent the secondary injury, of course, the outcomes would be better. So what about our patient? So what do we do? What is our focus now? So we have a patient. So what might be the flow chart? First, the treatment starts in the pre-hospital setting. So patient is at the point of trauma, site of trauma, ambulance drivers rush there and they see the patient. So what do we do there is one, a guideline is about. Then there our guideline starts, the protocol starts. Then the patient is brought to the emergency department, and from there either the patient goes to the operating room after a imaging, or to the intensive care unit, then operating room, or vice versa. So there is going to be all this type of action with this particular patient. So what do we do about it? So pre-hospital care. So we need to know what was the mechanism of injury. Why is it important? Is it can be direct impact or indirect impact. So there is something called a coup and counter coup injury. So in this, we can see there is a hit on the left side, and the brain hits has another impact on the opposite side of the skull, and there is injury on both sides. So coup and counter coup we need to know, because we have to see whether the patient, what does the lateralizing sign, which place injured, is there a hematoma? Almost we have to be having a idea about the mechanism of injury to know how severe the injury is. So it all really matters in the treatment. So how the patient presents. Patient presents with unresponsiveness, seizures, sometimes agitation, and it is very, very important to quickly transport the patient to the nearest neurosurgical center. And there is something about the basilar skull fracture we need to know. Of course, our patient has a right ear bleed. So we need to think about a basal skull fracture. If there is any bleed in the ear, nose, or we can see that there are like raccoon eyes where there is black discoloration around the eyes, because scalp is a very loose tissue. Any part of scalp get hit, or any head injury, or in the base skull of basal skull fracture, we can see something called the raccoon eyes. And also a battle sign. So there can be no bleeding, nothing. Patient is just unresponsive. But these are signs of hidden injury. So occult injuries which might have happened, and definitely there is an impact. And the patient might have mild ooze from the ear or nose. So how do we know there is a CSF otorrhea? Is like when we dab with a gauze piece or a tissue, we can see that the blood is in the center, and the CSF has gone perforating through, and we can see a halo sign. So this shows that there is CSF leak. Why is it important? We'll be seeing in later slides. Okay, so base skull fracture, we have to think about when there is a hemotympanium, battle sign, and otorrhea or rhinorrhea. So pre-hospital care, what do we do? It is always a ATLS. So ATLS guidelines give a very, very clear guideline of ABCDE. So airway A is airway and cervical spine protection. In any patient, the cervical spine protection has to be taken care of, because we have to assume that there is a cervical spine injury unless we are cleared off, or radiologically or clinically the spine gets cleared of injury. B is breathing, ventilation and oxygen, and C is circulation. D is disability, how far the patient has a head injury or a neurological issue. E is exposure and environment, how many injuries. It's not like isolated injury, or is it having any other distracting injury? Is the patient bleeding from somewhere? ATLS is not only for head injury, it is for the entire trauma. So pre-hospital care, the paramedics have to have a quick look of this ABCDE, and the main objective or main thing what they have to consider is just putting in an oxygen, avoid hypoxia, and putting placing IV lines, wide bore IV lines, and giving a bolus of fluids to avoid hypotension. When hypoxia and hypotension are prevented at the point of accident in the pre-hospital care, outcomes are definitely better. So our Miss X is attended by the paramedics, and she's all put in a lot of care taken over the spinal board. Her cervical collar is placed, and the spine is protected. She's on a board with a headgear. So we can see that. So she's transported to a hospital in an emergency room. We again do the ATLS guidelines. So primary survey is done, ABCD again and again till fixed. So in ATLS, people who have done the ATLS, we would know that the ABCDs are done again and again in a proper protocol till it is fixed. And stabilization, the patient needs to have a good oxygenation and avoiding hypotension, good fluid boluses for the same. So primary survey is done, stabilization, then transfer to imaging or the operating room as the imaging is needed. For our patient, we need a CT scan brain as soon as possible. And secondary survey is done if the primary survey is completed, or we would have to just go by ABCD again and again till it is fixed. And finally, when the primary survey and secondary survey are done, transfer to ICU is done. And once the patient is awake, there is a tertiary survey. For our patient, what we do, so airway, when do we intubate a patient with a traumatic brain injury? So GCS score, if it is less than 8, if there is a moderate TBI, we will see what is a mild, moderate and severe TBI. But if the patient is having a GCS score less than 8 and there is moderate TBI with severe agitation, severe extracranial injuries, there is a rapidly declining mental status. We see that GCS had been 12 and now it is suddenly going to 6. Then we would have to protect the airway. And if there is any transfer, it is better to intubate the patient and do a transfer for a better and a safety transfer to be done. So breathing and circulation. So airway is set. We have put the cervical spine protection, and in need of intubation, we need to always protect the cervical spine. Okay, traumatic brain injury, it's not only brain, we have to take care of the cervical spine also. So there will be a manual inline stabilization. The neck should not be moved up or down, no flexion, no extension. So there should be a mild jaw thrust for ventilation and intubation without much of flexion, and it should be done by an experienced person. So breathing and circulation, we have already told that less than 90%, or if the PaO2 is less than 60, that increases mortality. So we need to provide oxygen. So hypotension in the field, I again mentioned that, previously mentioned that. So brain hypoperfusion is going to cause or increase the secondary brain injury and worsen the neurological outcomes. So what is our goal of SBP? This is again the Brain Trauma Foundation guideline. So the systolic should be maintained above 110 for 15 to 49 years. And if it is more than 50, then we can maintain it more than 100. Okay, for older people, it's always better to maintain more than 110. This is what the guidelines are given. So we will roughly have an idea that systolic should be. So disability, how do we check the disability? With the GCS, and we see the lateralizing signs, and we do neuroimaging. So neuroimaging, we have multiple types of hematoma. So first is the epidural hematoma. Then there is contusion. You can see all the pictures. Diffuse axonal injury. As I said, there is no particular or localizing mass lesion in a diffuse axonal injury, but the patient is unresponsive. It is because of the pulling of the axons, and the neural damage is done, but it is not visible with any bleeding or any particular hematoma or localized mass lesion. So there is also something called the subdural hematoma, which we can see. Actually, the EDH and SDH can be differentiated by the shape. So biconcave, it is like lens type is the epidural hematoma, and which is convex on convex on the outside and concave on the inside is the subdural hematoma. So these are very common findings. There is also a subarachnoid hemorrhage with an intraventricular extension, which you can see in the picture, and nothing at all. It can be just a diffuse swelling with all the concussion. So, and the CSF leak. If the CSF is leaking much, and we won't be seeing the cisterns open properly, and there will be a very diffuse swelling. So whom do we admit? So how do we differentiate the traumatic brain injury? If the GCS is 13 to 15, then the patient is having a mild traumatic brain injury. If it is moderate, 9 to 12, it is severe, 3 to 8. So 3 to 8, we call it severe. So Glasgow Coma Scale, I know everybody knows about it, but we need to have it in the tip of our fingers. So keep going through it again. So then our patient, what have we done now? The patient had been shifted. Our patient had been shifted to the emergency department, and airway protection done. A patient was intubated under proper cervical spine protection methods. Then imaging was done, which is showing a diffuse axonal injury. There is of course some hematomas here and there, and we can see the cerebral edema. So the patient had been given fluids, and the patient had been given good oxygenation, and once stabilized and looked for other injuries, screened for other injuries, which is not present fortunately in our patient. Patient was shifted to ICU. So this is our patient. She had been taken to a OT after the ICU. Then decompressive craniectomy was done, and she is back in ICU with all the features. So we now know that we have come to this stage. So in ICU, we play a major role. Most of us work in ICU. We don't get involved in emergency, but we need to know which is the very important protocol-based care of the TBI. So emergency, the patient was there in the road traffic accident site, where the primary care was done, pre-hospital setting care was done. She was given oxygen, IV fluids, and transported with a good cervical spine, and she was transported on a spine board without much of a movement to the spine. And she had been intubated in the emergency room after a primary survey. She was taken to our imaging, and we saw in the imaging she has diffuse axonal injury with increased cerebral edema. So she went to the OT, and she had a decompressive craniectomy, and she was brought back to the ICU. So now our treatment or management continues. So what do we do? What are we going to do with this type of patient in our ICU? Patient has landed there. We have taken over this patient. So general considerations. So again, our mantra, we have to think about it again and again. Avoid fever, seizures, fluctuation in blood sugar levels, fluctuation in the blood pressure, neither too high, not too low. Hypercarbia or hypocarbia should be avoided. So what do? We maintain euvolemia. Okay, we don't overload the patient, overfill the patient, or keep the patient dehydrated. Of course, the patient will be treated with mannitol, which we'll be talking about later, but cerebral edema measures are also given, which shouldn't have a hypovolemia. The patient volume should be maintained very well, and there should be euthermia. There should not be hypothermia, which will worsen the situation, or it will cause more coagulopathy. We have to not have the patient's temperature high, because fever also increases the cerebral metabolism, so that the brain is not happy either, and edema is going to increase. So we have to keep the brain happy. So what sugar level should be maintained? Neither too low, not too high. So we know that we are working between two levels. So for the volume, for the temperature, for the blood sugar values, which is 140 to 180. And if there is any focus of penetrating injuries, if there is any infections, if you feel that the patient is having an obvious infection. But the thing is, we do not get very early infections, or nor do we give prophylactic antibiotics. Operation theatre, they do give prophylactic antibiotic as a part of surgical prophylaxis, which is stopped in 24 to 48 hours. And adequate sedation for her because she is ventilated. Okay, so sedation is quite tricky, because assessment of GCS is quite a problem when there is a sedation. But if we do not give adequate sedation, the patient is going to get more restless or agitated, which is going to increase the cerebral metabolic oxygen. So what do we do with the sedation is always immediate post-op, or immediate post intubation, or immediate post injury. It's better to give adequate sedation if the patient is ventilated, so that the cerebral metabolism or oxygen requirement comes down and brain's edema totally settles. So first 24 hours at least we have to keep the patient calm and sedated. So seizure prophylaxis. So we have to avoid seizures. What are we going to do? So start seizure prophylaxis within 24 hours of the injury. So, and it should be continued for 7 days and not more than that. There can be early onset of seizures, which is 24 to 7 days. And there is something called a early post-traumatic seizure, because blood is in the wrong space, or because of the cerebral edema, the neuronal excitatory transmitters irritate the neurons, causing desire activity, causing a seizure. And seizure is going to again increase the brain injury, as we talked about again and again, secondary brain injury. So seizure prophylaxis is a must. And what we give is phenytoin and levetiracetam. And specific management, what do we do? So our patient was operated. So why was she operated? There can be a lot of clues for it, but what are the guidelines? So when there is a moderate to severe TBI, we need to call for a neurosurgical consultation. Mild TBI with other extracranial injuries like facial bone injury or mandible injury, we need to call them for a consult. And if there is a skull fracture, and of course if there is a depressed skull fracture, it is a very, very emergent situation where we have to give a seizure prophylaxis immediately and call for a neuro consultation in an urgent way. And if there are signs of CSF leak, in our patient we did have a right ear bleed with a CSF leak. And lateralizing signs, if there are lateralizing signs on neurological examination, if there are unequal pupils and focal weakness, just before imaging also we can call the neurosurgeon to make time for them to come to the place as soon as possible. And unequal pupils are like, we have already lost the window of saving the patient, but it is always better late than never. So we will talk about increased ICP in our later slides. And if there is cerebral vascular, you feel that there is a vertebral artery dissection or a ICA dissection, we need to call them as soon as possible. So interventions are, we have already told. Just to keep this slide very simple, we can say that if there is a very big SDH, EDH for any EDH, it's better to call, because it has a good history or good track history of rebleed again and patients dying before our eyes. So it's better to call for a neurosurgical intervention soon. And depressed skull fracture, of course, I already mentioned that we have to call for a neurosurgical consult. So this is for the neurosurgical intervention. So ICP monitoring and management, what do we do? What is our role in this? This is what we do in a day-to-day neurocritical care ICU. So what do we do is we go as per the Brain Trauma Foundation guidelines, and there are strict recommendations to maintain ICP less than 22 millimeter of mercury, because if it is more than 22, is a profound increase in the mortality. So it's better, or it is very crucial to keep the ICP less than 22 millimeters of mercury. So in secondary injury, if we are doing our protocol or our inputs right, then the ICP is controlled well, and the secondary injury comes down and outcomes are better. So invasive intracranial monitoring, how do we do this? There are two types of monitoring. It is like continuous and it is like on and off monitoring, and there is also invasive and non-invasive monitoring. So before, it was a golden standard to put in a ventricular catheter and use it as a ICP monitoring. When there is a extraventricular drainage, we use that, we connect it to a ICP monitor and control or monitor the ICP pressures, ICP, and we do that. That had been a gold standard. There are a lot of new things coming up. There is a brain tissue oxygen monitoring. So in EVD, we have one more feature of advantage, is that when the ICP goes high, we just open and let some CSF down out so that the ICP comes down and we are able to relieve it as a rescue measure. So that is one. And brain tissue oxygen monitoring is good in the sense that we can monitor the tissue perfusion, or how much the brain is getting oxygenated. And there is one more non-invasive monitoring tool which is gaining very, very good appreciation, is transcranial Doppler. It is gaining more popularity these days. So what are we worried about? We are worried about brain herniation. If ICP, what if the ICP increases so much? There is going to be brain herniation, which is our worst nightmare. So it can present as a non-reactive pupil, unequal pupils we call it very, very commonly. So extension posturing and a progressive decline. If there is sudden drop in GCS of more than or equal to 2 points, then we need to keep our antennas straight. And there will be a Cushing's response. Progressively, there will be hypertension. We shouldn't be treating them with anti-hypertension drugs, but we have to first think about the Cushing's response and increased ICP. So what is wrong? What is happening? And patient will be having an irregular respiration if not intubated. And there will be a combination of, this is a triad basically, with a hypertension, bradycardia and irregular respiration. So why it happens? So it all boils down to Monroe-Kelly doctrine, which is a concept of increased ICP. So as we could see in that, it is a normal state of ICP. Brain contains venous volume, brain mass, arterial volume, and CSF. So these are the four components which is like filling the brain fully and is just tightly packed within the skull. So skull is non-expansile. So you know there's a rigid tube. Imagine like that. And when there is some mass lesion, it can be a mass or a bleed or a increasing hematoma after a trauma. What happens is a brain has to somehow accommodate and keep it alive, keep itself alive. So what it does, it just reduces, lets out some of the venous volume and helps in auto-regulating pressure and gives the mass extra space. It just helps to accommodate the mass inside itself. But if it is constantly increasing, then it will start to shift the CSF. If it is still increasing, then the compensatory mechanism fail and there will be less less blood volume, and the patient will start to have a swelling of the brain. The ICP goes very high and brain starts herniating. So there are various types of herniation which you can see in this picture. So anything will result in death. So what do we do? How do we help? What is the concept of reducing the ICP? So reduce the CSF volume. So letting out a little bit of CSF can reduce the ICP for some time. It is just a rescue measure. So extraventricular drainage helps in doing that. Then comes reduction in the venous volume. So how do we do that? We give hyperosmolar agents and we hyperventilate the patient. When we hyperventilate the patient, the carbon dioxide in the cerebral circulation comes down, thereby causing a vasoconstriction. So hypocarbia causes a vasoconstriction. This should be done as a rescue measure temporarily. If we do it in a very vigorous way, prolonged way, then there is going to be the low blood flow to the brain, causing more infarcts and ischemia, which is going to not help the patient but worsen the situation. So that is one type of reducing the venous volume. Then evacuate mass. This is the definitive treatment. Like any mass which is causing the issue has to come out. Then there will be a space for the brain to again get back to normal. And decompressive craniectomy, if there is no particular mass, it is just the brain edema increasing, then the surgeons come into play and they remove part of the skull to give the place for brain to swell. So this is not a definitive treatment, it is just a rescue measure. And Brain Trauma Foundation says that a good fronto-temporoparietal decompressive craniectomy is very important. A small part of skull is removed, then it doesn't help. So it has to be in a very good amount so that the brain is given space to swell and the ICP is not causing the brain to lose its blood supply and herniation is avoided. So, okay, the patient is in our ICU. There is ICP. Suddenly you see in the ICP monitor, the ICP is more than 22. What do we do? So there are a lot of things for ICP management, from CPP optimization to osmotherapy to sedate, intubate and whatnot. So what we are doing is all put in one slide. This is various tiers of treatment. This is like therapeutic intensity level 1. It is like every time we do something and see whether the ICP goes down, we check our basics. No, ICP doesn't go, we increase. So we are going to go by parts because this is going to be a very important discussion. We'll go through it. I know it's too much, so we'll go by part by part. So before treating the ICP, first we have to check the confounders. Is the ICP monitor tube kinked, or is there anything else which is increasing the pressure? Is it the high PEEP, or is it a pneumothorax? Some other things which is falsely showing a high ICP. Okay, no. So we have to do a fast check. We shouldn't be wasting time. So what do we do is like we check the confounders. Okay, now we know that it is not that we shouldn't be in denial. It's really the ICP going up. So what do we do? So we do the tier 1 things. So what do we do? Are we keeping the patient's neck in a neutral position? Is head turned to one side? Then keep it straight. There should be a head and elevation of 15 to 30 degree. So adequate sedation and analgesia. Is the patient restless? Is the patient having seizure activity? So we need to know what we have given. We need to recheck the chart. If need to give a bolus, then we have to give a bolus of sedation and analgesia. And mild hypocapnia, and maintain cerebral perfusion pressure. Are we maintaining a good pressure? Is the patient having a fever? If the patient adequately fluid filled? So we have seen this and it doesn't work again. Still the ICP is high. Okay, act fast. We need to act fast. Time is brain. So increase sedation. Again, okay, we go to the next level of treatment. Just increase the sedation. Give big doses, big bolus doses of propofol, midazolam infusions, whatever we have. And we have already intubated the patient, so we know it is manageable. And we have to start on osmotherapy, mannitol or hypertonic saline, which we will be mentioning a little later also in detail. So a mild hypocapnia is again needed. I know I just talked about the hyperventilation and how to optimize the cerebral perfusion pressure with hypocarbia. And this is the time where we have to repeat the CT scan. We should know whether the hematoma has increased. We should know if there is any new bleed, what is happening, why is the edema increasing or the ICP increasing. So still the same. Okay, we go to tier 3 of management. What do we do is we give, till now we had been having a profound hypocapnia. Now we just go hyperventilate the patient. But with there should be a brain oxygen monitor so that we don't overdo it and cause less oxygen supply to the brain. And higher doses of osmotic therapy. And we try and optimize CPP, consider repeating a CT scan. So if we hadn't done in the tier 2. Okay, we re-evaluate, we re-see the monitor. If it is still more than 25, then we need to be having our fingers crossed because it is the worst period. We need to put the patient in a barbiturate coma. which is done with a thiopenton, 5 to 10
Sorry,
milligram
I
per
called
kg
you.
as a bolus, and later infusion with
No,
3 milligram per kg
the
as a
people are
infusion.
booking on
This
that
is to
thing.
buy time before a decompressive craniectomy. We can get a CT scan in tier 2. If there is increasing mass, then we can go for a decompressive craniectomy at any stage. But till that, we have to buy time. It is like if we could just push in a patient into the theater for a decompressive craniectomy, that is well. But often it is not the situation. So we need to keep buying time. We must make sure the patient's vitals are stable. We shouldn't be overdoing with our sedation and causing an issue, which is quite possible. We need to know that if we increase the sedation or put the patient into barbiturate coma, there is going to be a low blood pressure, hypotension. We need to be prepared for addressing that and managing that also. This is the time where we have to talk to the patient's family again and just explain them what's happening, and there might be high chance that we might lose the patient, or the patient can go into a brain death situation. So hyperosmolar therapy, what do we give? We give hypertonic saline and mannitol. So mannitol, it is not the 100 ml bolus we give. It is we have to give a proper dose of 0.5 to 1 gram per kg for the patient as a rapid bolus. So many conditions where we think that mannitol is given as an infusion helps. No, it doesn't help. Rapid bolus has to be given, and it has to be given only when the ICP is increasing. It helps more. According to the Brain Trauma Foundation, I know there are a lot of styles of different intensivists and different neurosurgery consultants, but the thing is, this is what is given in the foundation guidelines, and we are discussing as an academic basis. And it is given to a peripheral IV over 5 to 10 minutes, just a bolus, that's it. And hypertonic saline, this is better when if it is given as a slow infusion, and our sodium, we have to just monitor the sodium. If it is around 150 to 155, we have to stop it. Our target is to maintain the sodium. For mannitol, we must be having a look at the osmolarity. If it is increasing, if it is getting near 300, we would have to stop using it. So what are the contraindications of mannitol? When patient has pulmonary edema or the patient is already in renal failure, we shouldn't be using mannitol. If the patient is hypotensive, we shouldn't be using mannitol. We have to have a check while using mannitol. And hypertonic saline, it really helps when there is a hypotension. We can even give it as a sudden bolus. We can give it as a bolus to help with the hypotension and the osmotic therapy. It helps in both ways. So physiological targets, as we discussed, it is a goal directed. This has to be, if this is maintained well, then the patient really makes it to home in a very literally walking way. Okay, so saturation more than 90 percentage. Carbon dioxide in the arterial level, it should be 35 to 40. And very less will cause vasoconstriction, less blood flow. Too much will cause increased ICP. And pH, the normal pH we have to maintain. ICP, of course, it is the center of our treatment. It should be less than 22 millimeter of mercury. CPP, it is to be maintained at 60 to 70 millimeter of mercury. Brain tissue oxygenation should be more than 20. If we do have a monitor, that is not available in most of the places. So I will just mention it for academic basis. Okay. So blood pressure more than 110 millimeter mercury. Temperature, normal temperature, euthermia is enough. Sodium, if it is 135 to 145, well, if there is increased ICP, then we would have to maintain it at a higher level around 150. And glucose should be in a very tight control of 140 to 180, so that we don't get extra infections and superadded infections or hypoglycemia, which kills the neural cells again. And platelets, to avoid bleeding, it's better to maintain it more than 1 lakh. Hemoglobin should be more than 7 grams per deciliter for good oxygenation. INR should be less than 1.4. Coagulopathy correction is very, very important. So what are the miscellaneous things? We would have to talk about these when we talk about traumatic brain injury. So steroids in TBI is a big no. Total contraindication, and it is harmful. It increases the risk of death and disability. This has been in the crash trial. So in Brain Trauma Foundation, level 1 recommendation is to avoid a steroid in TBI, steroid use in TBI. And prophylactic hypothermia, now hypothermia has lost its usefulness in any part of neurocritical care, not only in TBI. And coagulopathy reversal is very, very important. We shouldn't let the brain bleed. If we correct the coagulopathy, most of the bleed doesn't progress, and the neuro health maintains in the patient. So, of course, we must not forget the fast hugs BID. I know, of course, everybody knows about this and practices this for the patients daily. So, in a traumatic brain injury, we start feeding whenever we have finished our neurosurgical interventions. Patient is not under any observation with the unprotected airway. And feeding or fluids can be started. If the patient is awake and if the swallow test is good, the patient can be orally fed. Otherwise, start with the rice tube feed. And analgesia, of course, it's very important. Sedation, if the patient is not intubated, we need to be cautious about the sedation. Thromboprophylaxis, in this patients, if it is like the bleed is not ongoing or if there is no neurosurgical intervention planned, then we would consider to start it after 48 hours of the hematoma stabilization. If there is no other bleeding, if the patient is getting better, it's better to start early DVT prophylaxis. So DVT prophylaxis on the day of trauma, it can be if the peripheral limbs are okay, if the lower limbs are okay, we can start putting sequential compression devices. We call it SCD. And it is very, very important to have a head-up position for reduced ICP as well as avoiding VAP. And ulcer prophylaxis, we know that in a trauma patient, ulcer prophylaxis is very important. Glycemic control, 140 to 180 is our place of work. We have to work between that. And of course, the patient should not be totally sedated and always kept under ventilation. We have to give spontaneous breathing trials whenever we feel that the patient's neuro situation is better and the brain is happy enough to go for it. And always very, very important to give a good bowel care, and we need to make sure that the plastics are removed off faster, and there is a drug de-escalation, including the osmotic therapy also. So I just want to just mention a few studies which are really important in TBI patients and of academic use. So there is SAFE study, which is had been done for a fluid resuscitation in patients, and in that subset, we actually got a new finding, which was a little incidental, that in a traumatic brain injury patients, albumin is really increasing the risk of death. So we avoid using albumin in TBI patients. That came in the SAFE study. You can go through that. DECRA is one study which showed that decompressive craniectomy is giving a very worst outcome. And of course, later came the rescue ICP, which showed that mortality benefit is good with decompressive craniectomy. Actually, the selection of patient and the patient populations were different. That's why these were showing different outcomes for the same treatment. But rescue ICP had been done in a better protocolized way. You can just go back and get into the study and have a look. And CRASH is one study which we remember always in traumatic brain injury. Steroids increase the mortality. And CRASH 3, it gave a mortality benefit study of tranexamic acid safe in TBI. When given within 3 hours, it reduces the head injury associated deaths. So these are the important studies which we can have and quote and see, and they have a significance in traumatic brain injury patients. So to summarize everything, we had the patient in ICU. We brought the patient from the point of accident. We had brought under good circumstances. Paramedics took a very good care. Emergency people took a very good care. And patient was sent to OT. Patient had a decompressive craniectomy. The patient was in ICU. It's all a teamwork, and the intensivists have taken a very good work. So the patients definitely will have a very good outcome. So neurocritical care is an evolving field. As I mentioned, it is very close to my heart because it really has a very good impact when the patients get better and leave, because we can avoid crippling. Crippling is even worse than death. So if we could give a very good protocolized care to these patients, they will really survive, and they will not only survive, they will have a good quality of life. So prevention is of course very, very important. Prevention of the injuries is very important, but that is not up to us. It is for the government and the society, entire society. to take care of the traffic rules, awareness, and helmet use. And early intervention is very, very important. From the pre-hospital setting, we have to just keep on in a proper protocolized based care. That will give a good outcome. So time is brain, and appropriate care and treatment gives better outcomes. And we have to keep the brain happy. If we do all the things properly, if we have a team which could manage all these, then the patient is fine and ready for discharge, and it is going to be a happy ending. Otherwise, we know what it is, so we don't want those things happening. So thank you. Have a good day and have other wonderful sessions ahead. Thank you so much for getting me into this way of session and giving me a good opportunity to talk about this. I introduce myself. This is Dr. Pratima. I'm an intensivist in Apollo, Chennai. Thank you, everybody.
Thank you, Dr. Pratima. It was absolute pleasure and delight to have you. We have a few questions here. Though it was a pretty comprehensive talk, we still have got questions. I'll start with them. One, Dr. Rashmi is asking, what is the single most intervention to prevent secondary injury, whether it is avoidance of hypotension, hyperthermia, hypoxia, or ICP lowering, which are associated with improved outcomes?
Hello, sir. Good afternoon. Good afternoon, everybody. Hope the session was useful. So, to answer this question, I think initially I did mention first is the hypovolemia. We have to correct the hypovolemia, and good oxygen therapy helps. So, single most is avoidance of hypoxia and hypovolemia.
Right. The other question is, should we continue hyperosmolar therapy even after decompression? And for how many days?
This is clinically, we have to assess the patient and decide, but definitely we continue this osmotherapy even after decompressive craniectomy. Decompressive craniectomy is just a part of the procedures which we do, or maneuvers which we do to reduce the ICP. We have to be continuing it. And once we think the patient is improving and we see the flap which is post craniectomy coming a little loose, soft, we don't see signs of other signs of ICP, we can slowly stop it. And one more thing is we have to have a watch on the sodium also.
Right. Delegates, please put your questions on the chat box for Dr. Pratima. So, Dr. Pratima, I mean, while we await questions, you had a phenomenal algorithm about the various tiers of management or the therapeutic intervention level 1, 2, 3, 4. The crux was on the ICP monitoring. So even with level 1, so I understand that we have to monitor ICP at all points. Is the transcranial Doppler good enough as an ICP monitoring? With the level of learning and the inter-observer variability and things like that. How do you go about it?
It is not as ICP is the only monitor which we use. Neuro, that is what we had discussed. But the thing is, there are other signs of ICP. When the patient is intubated, sedated, we can definitely do this pupillometry. There are extensively multimodal neuro monitoring nowadays available. The EEG, a lot of things which will come into help. As it was more of an academic session, I just dealt with ICP monitoring, so that it is even with a less resourceful state, we can definitely give the patient a good care. So ICP is controlled with all these type of monitorings, and of course transcranial Doppler, if available, is the best measure to keep on monitoring, and non-invasive, so it is an advantage in that way too.
And another question is, any role of glycerol for ICP control, and when would you start it?
It is definitely known measure, but when we start the feeds, we just cannot mix the oral glycerol, and we can really titrate oral glycerol in the ICP protection as good as this other osmotherapy. So it is not really a very great measure, but it is being used. Personally, I don't use it. I don't have much of a faith in that, but it is being used by some people, which is like might help, but we are not sure about how much. So it is not like real time. We can just titrate the level also.
Right. We have another question. When do you start DVT prophylaxis?
DVT prophylaxis, as I mentioned, should be as early as possible. So as early as possible, totally we know neurosurgeons do not like to immediately start any DVT prophylaxis with the chemical prophylaxis. So mechanical prophylaxis, straight away we put on the SCDs and the flow drums. But for the chemical prophylaxis, low molecular weight heparin, we can start it if the hematoma expansion is not there and it is stabilized, at least after 72 hours or within 7 days.
Right. Well, I think we've run out of questions. It was a pretty comprehensive overview of traumatic brain injury, and so I'm not surprised.
Thank you, Dr. Pratima.
Oh, well, we
Thank
have
you very
one
much.
indication for DECRA, role of optic nerve sheath diameter.
As I told, ultrasound is now gaining importance field in ICP monitoring. DECRA is an entirely different study. So we have to go into the nitty-gritty stuff of the study as a journal club. It has showing a very bad mortality situation in DECRA study, but rescue ICP, I think, has answered all the questions. And in this new optic nerve sheath monitoring, it is definitely helpful, but it is like we cannot fix it. It is just either high or very low. We cannot really titrate with the numbers. We can just screen and do it.
Okay, and what is the target sodium when giving 3%? I think you've covered it, but somebody needs to know more.
It is, we have to maintain 50 to 155 for a good level. And once it is reached already 150, we would have to stop it, because there can be a DI going on diabetes insipidus. There can be a dehydration. Patient can have a shoot up in sodium level also. We need to be very closely monitoring the sodium level. If it is going on above 150, we can stop the 3% saline. My target will be 150 to 155.
Right. Okay, I think, oh, well, we have one more. I mean, 23% versus 3%.
Hypertonic is definitely useful. I have personally not used any hypertonic saline of 20 more than 3%. So I think whatever we are used to and we are using it regularly, it's better to go with it.
And in terms of anti-epileptic, which one, phenytoin or Levera?
Levera is being used very commonly nowadays. There is also a Breville which is increasing its popularity. It has a 10-minute minute time to onset. So neurosurgeons are going more towards it. Now, like phenytoin has become older. Whenever we lose faith in levetiracetam, we will come back to phenytoin, I believe. But it is a good old drug.
Okay, and choice between mannitol or 3% in patients with CCF and liver disease, I believe.
Mannitol is one drug which is both advantageous and dangerous as well. It is advantageous when we have a sudden increase in IC, we can use it. But in case of CCF patients, we should use mannitol with very much of a caution, because it has sudden fluctuations. Mannitol we use as a sudden boluses. It's not like we are going to give it as an infusion. So anything which we give as bolus and which has more fluctuations, we have to use cautiously. So if these are the patients with CLD and CCF, I will go with hypertonic saline.
Yes, I think that's about it. Thank you so much, Dr. Pratima. And I will hand over it to Atul, sir. Sir?
Just one announcement. I spoke to the JP people, there were some questions about the tracking, there being no tracking ID or anything. So the publisher, the JP publications will write to you, your order is booked now. So they will write to you, they have your email IDs, they have your phone numbers, and they will get in touch with you regarding the delivery of the books. Don't worry about that. About the other book, where there is concern that the book is out of stock, the book is currently being printed, so it is not out of stock, and it will become available to you once you book it. So within a month, we expect the delivery of the book to your homes or whatever address where you. Please take over, Sheel. Thank you.
Okay, so don't get hassled by not being able to get through the purchase of the books. It will be made available. So continuing with the session, again, it's a great pleasure to invite our Dr. Deepak Govil. He is the director of critical care medicine at Medanta, and he is also the president of Indian Society of Critical Care Medicine. And we've always taken pleasure to hear Dr. Deepak Goel. He's also an expert in ventilation, hemodynamic monitoring, and his interest in ultrasound is well known. Over to you, Dr. Deepak Goel. He'll talk about acute liver failure in intensive care.
Good afternoon, dear friends. First of all, I would like to thank Professor Atul Kulkarni for inviting me and giving me this opportunity. In next 25 minutes or 30 minutes, I would like to talk about the acute liver failure. So there is a 25-year-old male who is admitted with fever and altered sensorium for the 3 days. His jaundice was noticed 7 days back. There is no past history of any liver disease. He, on examination, his heart rate is 52 per minute, blood pressure is 132 by 78 millimeter of mercury. His pupils are sluggishly reacting, 4 mm bilaterally equal. His bilirubin is 12.2, INR is 4.5, ALT is 2600 and AST is 2200. So what could be the clinical diagnosis? If we talk about the definition of acute liver failure is a rare, rapidly progressive, often fatal syndrome characterized by encephalopathy, coagulopathy, jaundice, without any prior history of liver disease, and should be less than 26 weeks of duration. How do we evaluate such patients? History is very important in any evaluation. We have to consider the age of patient, look at if patient is female, look at the childbearing age or pregnancy. We have to take the history of drugs. ATT exposure is very common in India. In Western world, the paracetamol is very common, but in our country, the ATT exposure is common, some anticonvulsants, NSAIDs and paracetamol. Then we have to look for the sepsis and look for any underlying cause of chronic liver disease as well. Etiology. In India, the commonest etiology is viral infection, hepatitis B, hepatitis A, hepatitis E, which is sometimes called as non-A, non-B as well, hepatitis C virus, cytomegalovirus, Epstein-Barr virus, and herpes simplex virus. They are the causes of viral infection. Alcohol, anti-tubercular treatment, anticonvulsants, Halvar products, NSAIDs, nutritional supplement, and acetaminophen can also cause acute liver failure. Amanita phalloids or CCl4 are the toxin which can cause liver failure. In pregnancy, acute fatty liver of pregnancy and HELLP syndrome can cause acute liver failure. Wilson's disease can cause, and autoimmune hepatitis and shock liver also can cause the acute liver failure. So in this patient, if we talk about the differential diagnosis, patient with fever, jaundice, raised liver enzymes, with encephalopathy, these could be the causes: malaria, rickettsia, leptospira, and hepatitis, hepatic tuberculosis, and amoebic liver abscess. If we look at all these, they will almost give the similar type of picture. Fever, encephalopathy can be there, and liver can be deranged. So how we should work up in this patient? Of course, LFT is the first and foremost test, then the coagulation parameters like PT and INR and activated partial prothrombin time, APTT, complete hemogram, G6PD levels, uh, direct clotting time, indirect clotting time, renal function test, viral markers like IgM HAV, HBsAg, IgM HEV, HIV, herpes 1 and 2 and 6, Epstein-Barr virus, HCV, and CMV. Arterial blood gases with lactate levels, arterial ammonia, ultrasound abdomen, liver Doppler to look for any vessels, and CECT abdomen. So these are the basic workup. What else should be sent in such type of patient? If patient is young, check for Wilson's disease. To check for Wilson's disease, we send serum ceruloplasmin and free copper level, and 24-hour urinary copper also sent. If patient is female in the childbearing age, then urine pregnancy test should be done. Diabetes or thyroid disease should be checked if we are looking at the autoimmune, and autoimmune markers also to be done. So how we classify the acute liver failure? It could be a fulminant hepatic failure. This jaundice to encephalopathy time is less than 8 weeks. Subfulminant hepatic failure, where jaundice to encephalopathy time is more than 8 weeks to 26 weeks. And other terminology like O'Grady et al. Has given other terminology. And hyperacute, onset within 1 week, acute 1 week to 3 weeks, subacute 3 weeks to 26 weeks. What could be the symptom and sign? As we have already discussed about the symptom of this patient, patient came with the altered sensorium, so encephalopathy. Then if we, in the examination, we can see the flapping tremors, or patient himself can tell, family can tell that patient is having flapping tremors. Patient is having hyperventilation, hypotension, oliguria, edema, bleeding diastasis can be there. Patient is in encephalopathy, coagulopathy is there, jaundice is there, hepatomegaly can be there, hemodynamic disturbances can be there, cerebral edema can be there, and renal failure can be there. In this picture, although this is a little busy picture, if you look here, these are the clinical features of liver failure. So starting from the brain, there could be hepatic encephalopathy, cerebral edema, intracranial hypertension, heart, there could be a high cardiac output state, frequent subclinical myocardial injuries, they could be there. Pancreas, if we look at the pancreas, there could be possibility of pancreatitis, particularly in acetaminophen related disease. In adrenal glands, inadequate glucocorticoid production and contributing to hypotension. Kidneys, they can go into the kidney failure, or frequent dysfunctions are there. Portal hypertension may be prominent in subacute disease and confused with chronic liver disease. If we look at the systemic inflammatory response, there is a high energy expenditure or high rate of catabolism is there. In lungs, it could cause acute lung injury or acute respiratory distress syndrome. In liver, loss of metabolic functions is there, decreased gluconeogenesis, so a patient can present with recurrent hypoglycemia, decreased lactate clearance is there, so you will find lactic acidosis, decreased ammonia clearance, so hyperammonemia could be there, and synthetic capacity is also decreased, so coagulopathy appears. If we look at the bone marrow, frequent suppressions are there, particularly in viral and seronegative diseases. Circulating leukocytes, they are having impaired function with the immunoparesis contributing to high risk of sepsis. What are the targets of the therapy? Mainly, if we talk about the therapeutic efforts, there are 3 goals: specific therapies for individual cause of ALF, treating multiple complications, and evaluating various artificial or bioartificial support system. So if we talk about the specific therapy, if there is a paracetamol poisoning, then N-acetylcysteine is the drug of choice. Hepatitis B, CMV, Epstein-Barr virus, herpes, antivirals are one of the possible treatment. If it is related to pregnancy, then delivery or termination pregnancy can be done. Amanita phalloids, then sibyllimin and penicillin G is there. Silibinin, and penicillin G is there. Autoimmune hepatitis, one can try steroid plus minus azathioprine. Coming to the grades of encephalopathy, because it is very important to understand the grades of encephalopathy. If grade 1 or 2 is there, then patient can be kept in the ward with quiet environment with skilled nursing. But we have to do a frequent neurological assessment, avoid sedation at this stage, oral or rectal lactulose to be given to clear the gut and to decrease the ammonia levels in the gut. Then nutrition has to be supplemented and CT brain has to be done. Grade 2 to 3 or 4 encephalopathy patient should be in the ICU. These are the different grades. So they are West Haven criteria is there, and there is a minimal hepatic MHC is minimal hepatic encephalopathy. So unimpaired, there is no encephalopathy, tested and normal. This is a no unimpaired like there is no encephalopathy. Minimal is requires psychometric test to demonstrate, and clinically normal psychometric tests are abnormal. This grade 1, which we clinically can identify, there is a trivial loss of awareness. Patient may be in a euphoric state or in an anxiety state. There is a altered sleep rhythm. Or comments, if you talk about the orientation to time, it is maintained. Grade 2, lethargy or apathy, disorientation, hysterexis, and dyspraxia. Here, the orientation to time is lost. Grade 3, patient is disoriented, bizarre behavior can be there, semi-stuporous and responsive to only stimuli. Here, the orientation to space is also lost. Grade 4, patient goes in the coma, may be unresponsive even to the pain. Indications to the ICU admission, one indication I have already talked to you. If his hepatic encephalopathy grade 2, 3 or 4 is there, patient is in coagulopathy, altered sensorium, high grade of encephalopathy, high INR, presence of renal failure, presence of hypotension, presence of upper GI bleed, and inability to manage such patients in the ward. Many times they are too irritable to be managed in the ward. How to proceed? We have main point of examination is to look for the altered sensorium. If grade 3 or grade 4 encephalopathy is there, then patient may need airway protection and mechanical ventilation. If we are going for airway protection, then we should use rapid sequence intubation, precaution to prevent increase of the ICP and brain stem herniation during the intubation. So patient is already altered sensorium in grade 3 or 4, so substantial amount of cerebral edema is already there. So if our intubation is not fast enough and we don't take care of the raised ICP, multiple attempts are being done or patient is in a lighter plane, then herniation or further worsening of ICP can happen. So we generally use the propofol, atracurium and fentanyl in such patients, and most experienced person of the team which is present that time should. Initial resuscitation, again breathing, spontaneous breathing, hyperventilation. If patient is on spontaneous, might be having hyperventilation. We try to achieve normoxia, maintain normocapnia as well. Circulation, if mean arterial pressure is less than 75 millimeter of mercury, then we have to maintain. If it is more than that, it's okay. If it is less than that, then we have to avoid hypertension. Measure the correct blood sugar and electrolyte, and proper sedation and anti-cerebral edema measures should be given. General supportive measures like organ support, hemodynamic optimization, respiratory stabilization, neurological protection, preserve renal function, and try to maintain metabolic parameters. And side by side, one should start the workup for liver transplant as well. Same principle as for any other patient in the ICU applies to acute liver failure patient as well. One has to maintain a strict hand hygiene because these patients are in an immunoparalytic state, and so they are very prone for any infection. So stringent infection control practices should be followed. Routine surveillance culture should be done if patient is not on any antibiotic. Central venous line or other invasive lines to be put under ultrasound guidance. Why specifically ultrasound guidance? Because these patients are coagulopathic patients. So if there is a multiple puncture, then you had it, then surely hematoma formation will take place. Hemodynamic unstable patient, same as sepsis, septic shock. Features of distributic shock is there because here there is a usually the low mean arterial pressure is there because of the low SVR and high cardiac output state is there. So distributive shock type of picture is there. Normal saline and balanced salt solution should be the fluid of choice. Noradrenaline or vasopressin are the choice of vasopressors, and if need be, hydrocortisone should be tried little early because I have already discussed that these patients may have the deranged adrenal function. Volume status to be assessed clinically and with IVC, LVOT, VTI monitoring and other cardiac monitoring tool as per your protocol of your institute and expertise. Our patient was intubated in view of rapidly progressive encephalopathy. The ventilator settings were tidal volume 500 ml, but again this tidal volume 500 ml will depend upon the patient's ideal body weight, respiratory rate 14, PEEP. They have given little high PEEP. I don't know why this PEEP of 10. I would give little low PEEP. Although this is my patient in my unit only, but I ratio 1:2. ABG rating with this is 7.28, PCO2 is 44.2, PO2 is 78, FiO2 is 0.21, and bicarb is 26.2. What is wrong with the ventilatory settings? So this is the question. Why these ventilatory settings are wrong? So again, as I already discussed in the discussion, the tidal volume seems to be quite high because if we calculate an average body weight patient who is a 5'6", tidal volume, ideal body weight, tidal volume comes to around 375 to 350 only. Respiratory rate we need to keep little high, and PEEP because patient doesn't require high oxygen, so we should bring down the PEEP because of the 10 PEEP. There is a chances of increase in the cerebral edema is also there. Always controlled ventilation with sedation and muscle relaxation should be done to avoid any increase in the intracranial pressure. Lung protective ventilation should be done because these patients are very high risk for developing ARDS. Normocapnia or normoxia should be maintained. No excessive washing of CO2 should be done. Intermittent sedation vacation should be done to assess the sensorium of the patient and look for acute lung injury and watch for ARDS because these patients are very, very susceptible to develop ARDS. Patient needs central venous line, arterial line. What precaution should be taken before the procedure? Would you like to correct coagulopathy or not? So subclinical vitamin K deficiency is there. Single dose 10 milligram subcutaneous can be done. FFP cryoprecipitate platelets to be given only if the bleeding or invasive procedure planned. Prophylactic transfusion is not recommended. Mind you, prophylactic transfusion of FFP, cryoprecipitate and platelets are not recommended. Clinically significant spontaneous bleeding is very uncommon in these patients. Next day, his bilateral pupils are not reacting to light. Focal seizure of left hand was noticed by the doctor on duty. What could be the cause? So it could be the hyperammonemia leading to cerebral edema. Cerebral edema and intracranial hypertension is most serious complication of acute liver failure. About 30% of the patient developed uncal herniation while awaiting transplant. So in 30% patients, it could be the cause of death. Without transplant, the mortality is around 90% for the patients of high ICP. This is the pathogenesis of cerebral edema and its intervention. If you look at here, it's a little complicated slide. If you look at the ALF in the center here, it is the ALF. So antibiotics and hypothermia can be done to decrease the inflammatory cytokines. We can use the cytokine inhibition here. Then COX and prostanoids could be, COX inhibition could be done. These COX and prostanoids can cause vasodilatation. Here there is a hyperventilation is there, increased cerebral blood flow is there, and this can cause cerebral edema. Whereas in acute liver failure, it causes hyperammonemia. This hyperammonemia can cause Arnose formation and antioxidant can be there. MTP is cyclosporin A can stop this. TCA inhibition can be tried, glutamine synthesis, astrocyte swelling is there, glutamine synthesis causes astrocyte swelling, and mitochondrial dysfunction can also cause the astrocyte swelling, and high adenosine level can cause vasodilatation. So everything causes the cerebral edema, and mannitol and hypertonic saline can be tried to avoid that. Risk factors for cerebral edema: grade 3 to grade 4 encephalopathy, serum ammonia more than 150 microgram per deciliter, rapid or hyperacute progression is there, sepsis, vasopressor support, and hemodialysis or SLED can also cause the cerebral edema. Raised ICP management signs are hypertension, bradycardia, focal seizures, decerebrate postures, abnormal pupillary reflexes. Management: mannitol 20% mannitol, 0.5 to 1 gram per kg stat. Stat means within 20 to 30 minutes, followed by 1 gram per kg 8-hourly hypertonic saline, 3% hypertonic saline or more. Serum sodium to be maintained around 145 to 150 millimole per liter. Elevate the head of the and the trunk 30 to 40 degrees. Avoid hyperthermia. Remove constricting tapes around the neck to facilitate the venous return. Avoid vigorous endotracheal suction. Hyperventilation. If it is an imminent coning is there, then one can target PCO2 30 to 35 millimeter of mercury for some time. Mind you, if you try to do hyperventilation for a long time, it will be a counterproductive. This is the algorithm for ICP monitoring. In acute liver failure, grade 1 to 2 HE, improved, let it be. If it worsens, grade 3 to 4 HE or the worsening of the 1 to 2, then go for head CT. If there is no ICP bleeding, one can plan for ICP monitor. And if ICP is less than 20 or cerebral perfusion pressure is more than 60, then one can leave it like this. If this is the target, if ICP is more than 20 millimeter of mercury or cerebral perfusion pressure is less than 50, then one can go for mannitol, hyperventilation, no improvement, hypertonic saline, hypothermia, thiopentone, and indomethacin can be tried. Hypothermia in ALF patient, moderate hypothermia, that is 34 to 35 degrees centigrade, may prevent this cerebral edema, rise of ICP. Prevent development of cerebral edema, preventing hyperemia, stabilizing blood-brain barrier, altering blood-brain ammonia, glucose metabolism, or by a combined effect. In young and in paracetamol poisoning, it can be tried. On to our case, our patient was receiving 20% mannitol 8-hourly. Later in the day, the nurse noticed that his urine output is decreasing. So how to manage this? AKI is one of the common complications caused by either dehydration and syndrome similar to hepatorenal syndrome or acute tubular necrosis. More common with paracetamol toxicity or with toxin ingestion. There could be alkalosis, but mainly we find acidosis. Protect renal function by optimization of hemodynamics. Avoid nephrotoxic agents, including diuretics, and early use of CRRT should be done. Metabolic issues in acute liver failure. Hypoglycemia is a frequent finding, as I have discussed earlier also. Hypophosphatemia, hyponatremia, hypokalemia is common. Lactatemia due to inadequate resuscitation and sepsis is very common. Enteral feeding should be started as soon as possible. If not feasible, then one can go for parenteral nutrition. How to suspect sepsis in acute liver failure? This is a big challenge because ALF also presents like a patient who is in a sepsis or an inflammatory syndrome. So sepsis is difficult to differentiate in ALF. Second leading cause of the death. Prophylactic parenteral antibiotic should be given to all acute liver failure patients waiting for liver transplant. Third generation cephalosporin is given. Fungal infection is very common, so prophylactic antifungals can be given. Surveillance cultures should be sent, and high index of suspicion and low threshold for starting broad spectrum antibiotic should be there. GI bleeding is a recognized complication of acute liver failure. Mechanical ventilation of more than 48 hours and coagulopathy are independent risk factors for GI bleed. PPI or S2 blockers has to be used. Sucralfate, second line agent, is there. What are the causes of mortality in acute liver failure? As I have already discussed, cerebral edema and brainstem herniation is a cause of death in close to 30% of the acute liver failure patients. Sepsis and multi-organ failure, acute kidney injury, and GI bleed are the other causes. Coming back to our patient is a male, had history of jaundice and encephalopathy of 4 days, had no history of suspected paracetamol or toxin ingestion, had other causes of fever, encephalopathy ruled out, like I have discussed with malaria and leptospira, other causes have already been ruled out. So can we prognosticate such patient? Grades of encephalopathy can help you in prognostication. Prognostic indicators are there. Patient who develop acute liver failure within 7 days of development of jaundice, they are having good prognosis. Prognosis better with the liver transplantation. What is the selection criteria for transplant or poor prognosis? So if we talk about the non-paracetamol poisoning, prothrombin time more than 100 seconds, or any three of the following: age uh, less than 10 or more than 40 years, non-A, non-B hepatitis, drug-induced hepatitis, icterus encephalopathy interval more than 7 days, PT more than 50 seconds, if INR is more than 3.5, and serum bilirubin is more than 17.5 milligram per deciliter. In paracetamol poisoning, the criteria is little different. Plasma pH is less than 7.3, or arterial lactate level more than 3.5 millimole at 4 hours, or arterial lactate level more than 3 millimoles per liter at 12 hours, or PT more than 100 seconds, INR is more than 6.5, serum creatinine more than 3.4 milligram per deciliter in patients with grade 3 and grade 4 encephalopathy. One criteria is the MELD scoring, model for end-stage liver disease. Another is Clichy criteria. In Clichy criteria, they take factor 5 levels. If it is less than 20% of normal, less than 30 years of the age, or factor 5 level less than 30% of the normal in more than 30 years of the age. In Indian patient, more than 3 parameters indicate 90% mortality, age more than 40 years, cerebral edema at admission, PT more than 25 seconds, and bilirubin more than 17.5 milligram per deciliter. When and when not to transplant? Early referral to transplant center could be a life-saving thing. Emergent liver transplant is a definitive therapy for acute liver failure, especially in the Wilson's and Amanita phalloids poisoning. Contraindication for transplantation: uncontrolled intracranial pressure, patient who is already suffering with the AIDS, sepsis with multi-organ failure, refractory hypotension, advanced cardiac or pulmonary disease. Is there any role of liver assist devices? Artificial or artificial devices are coming into the market to bridge to transplant. Artificial is Mars, Prometheus can be there, high volume plasmapheresis is there. There is a lot of papers and lot of interest is coming into the high volume plasmapheresis. I would like to take 1 minute to discuss about the high volume plasmapheresis. High volume is where we use close to 30 to 40 FFPs in a single sitting for plasmapheresis, and normal plasmapheresis is extended up to 6 to 8 hours. Bioartificial livers are hepatocytes in bioreactors. Hepatocyte transplantation can be there. If I talk about the summary of acute liver failure, the ALF, immediate consultation with liver transplant center and intensive medical management should be done. Etiology of a specific treatment, if there is a specific treatment as per etiology, should be done. If patient is having contraindication to the transplant, one has to continue the intensive care support. If there is no contraindication to a transplant, transfer the patient to liver transplant center. Emergency liver transplant should be done. Poor prognosis, if it is there, then one has to see the organ donor. If the donor organ is available, then one can go for liver transplant. If recovery is likely in such patients, as per we have already discussed the prognostic criteria, then ongoing intensive support or reassess recovery is there, or is there any contraindication to transplant? Thank you very much.
Thank you, Dr. Govil. Since Dr. Govil is not able to join back for question and answers, we will not be able to take the question and answers for this session. So we move ahead for the next talk of the day, and that is by none other than Dr. Dhruv Chaudhary. Dr. Dhruv Chaudhary has been the is the professor and head department of respiratory medicine and critical care at PGI Medical Sciences, Rohtak. He is also the president of Indian Society of Critical Care Medicine, um, the um, uh, the immediate past president. He was he is also um, uh, the fellow of Indian College of Critical Care Medicine and Indian College of Physicians. So he will be speaking on the exacerbation of COPD management in the intensive care unit. Over to you, Dr. Dhruv Chaudhary.
Good afternoon. Right at the beginning, I would like to thank Dr. Atul Kulkarni, Professor and Head, Critical Care Division of Department of Anesthesia, Critical Tata Memorial Hospital, for giving him an opportunity to discuss with you an important topic in pulmonology and acute respiratory failure and critical care 2 of acute exacerbation of chronic obstructive pulmonary disease. My dear friends, let's start with the case and we will see how things they unfold and how we manage these cases. It's a story of a 60-year-old farmer who has been a reformed smoker, non-case of COPD on MDI tiotropium for past 2 years. He has also been having systemic hypertension for a year on amlodipine and presented to us with a fever of 2 days, low grade, with no chills and rigors. He had a cough of 2 days duration, minimal whitish sputum, and there was no hemoptysis. Developed breathlessness a day later, and it was pretty severe and rapidly escalating to grade 4. But there was no orthopnea, no paroxysmal nocturnal dyspnea. There was no history of chest pain, palpitations, pedal edema. Neither there was a history of rash, vomiting, loose stools, or dysuria. This is a story of a 60-year-old reformed smoker, non-patient of COPD, who has come to us with increasing fever, breathlessness after an episode of febrile illness, which was associated with increase in cough and breathlessness. Therefore, when we define exacerbation of COPD, and usually we follow GOLD guidelines, and we label it as acute worsening of respiratory symptoms requiring additional therapy. That's what we see, and primarily it is because of increasing airway inflammation, which leads to increased mucus production. As a result, there is an increased obstruction leading to marked gas trapping. Remember one thing, in patients of COPD, we always see that during expiration, the equal pressure points, which are responsible, where you tend to have an equalization of pressures, it tends to move distally, and the net result is that because there is no support, they tend to close early with an obstruction and leading on to marked gas trapping. The net result of this increased inflammation, mucus production, obstruction leading to gas trapping is increasing breathlessness. Because of increased mucus production, you find increased sputum volume and later on becomes purulence. And also because of the inflammation, you tend to have an increased degree of cough and simultaneously wheezing can also come. So when all these three symptoms predominantly are present, then we usually see that is dyspnea, cough, and sputum volume and purulence. It is the severest of the exacerbation we look at from Anthonysen's classification. On the basis of that, you put it up into grade 1, 2, and 3. All three grade 3, only one grade 1. And wheezing, yes, may increase, but wheezing is primarily a feature of asthma. In this case, if you auscultate these patients, primarily you will see they are elderly people. They have a history of smoking, but in 1/4, You may not have a history of smoking, but they may be the non-smokers having COPD, and there is a marked decrease in the intensity of breath sounds. It is important for us to understand that whenever we label somebody as an acute exacerbation of COPD, and we already said and described that these patients may have decreased volumes or decreased intensity of breath sound, therefore you need to rule out significantly other things, more so when things are happening so rapidly. So it brings up to a question is when will you label somebody as an acute exacerbation of obstructive pulmonary disease? In other words, you need to know the differential diagnosis and you need to exclude those symptoms. The commonest one which you tend to see in these patients is pneumonia. The classical picture of pneumonia will be pain, high-grade fever, maybe moderate in elderly. Along with it, they will have a pain chest, cough, and purulent sputum. And sometimes you can also see you can see a black currant, red currant, jelly-like picture in Klebsiella. You can have a rusty sputum in patients of classical lobar consolidation, which you see in step pneumonia. Another important component which we must never forget, which is commonest, actually very common is, I won't say commonest, but it's very common, is pneumothorax. Similarly, pulmonary embolism because of systemic and pulmonary vasculopathy can also happen. Same as the age group of the people having a coronary artery disease, and therefore not an uncommon thing to have an active coronary because they have the same risk factor, that is the smoking, and you may have pulmonary edema. And also another important thing which is related with it, in that elderly hypertensives, not unusual to develop atrial fibrillation, and not also uncommon to see people developing PSVT or multifocal atrial tachycardia, which are not uncommon in patients of obstructive pulmonary disease. Now, when we evaluated this patient, so this is how you look at the differential diagnosis when you start taking the history. And when you see the patient is conscious, patient was oriented, he has tachycardia, but normal blood pressure. But what was very important finding was his SpO2 was only 80%, 82% at room air. But what was more astonishing along with, or what was more prominent was tachypnea, and he had a respiratory rate of 26 per minute. And along with it, he was having a relatively increased work of breathing characterized by use of accessory muscles of respiration. For that, you tend to see LNAZ, you tend to see intercostal retraction, and you also see how your sternocleidomastoid, trapezius, and other muscles they work. There was, however, no parallel interest clubbing cyanosis. Cyanosis obviously can be a feature which can be difficult sometimes, especially if the person is anemic. But by and large, these patients will be cyanosed, and jugular venous pulse was not raised and the pressure was not elevated. But when we evaluated the respiratory system, as expected, patient had a barrel-shaped chest, which classically is seen in these patients where you see that anteroposterior diameter tend to go much increased than compared to your epidiameter than the lateral diaphragmatic diameter. So that ratio gets altered and the chest becomes barrel-shaped. But it was symmetrical. As I said, he was using accessory muscles. And on an auscultation, patient had vascular breath sound, they had a bilateral wheeze, and intensity of breath sound were less. Cardiovascular examination was normal, so was CNS examination. Abdomen was soft, non-tender, and there was no organ of beginning. So when the duty doctor saw this patient in the emergency, the first thing what he did was put him on salbutamol nebulization. He had a wheeze. He is a known patient of obstructive airway disease and was having hypoxemia. He simultaneously, for the purpose of information, gave him hydrocortisone. This patient was febrile and was increasingly throwing out the sputum. He started this patient on amoxicillin. Because of hypoxemia, this patient was started on nasal prongs oxygenation at the rate of 4 liters per minute. When he was evaluated, hemoglobin was 12. Ideally, you should expect in these people more than 40, but nevertheless, it was just a borderline case and other parameters are normal. Same was true of urea. Creatinine was just borderline elevated, and other tests were normal. Random blood sugar is a little high, but what is most important here is that when you look at the pH, when you see the blood gas analysis, in this patient we found person was having acidosis. Now this acidosis, when we wanted to know, you see that PCO2 is elevated. So this patient, in other words, had respiratory acidosis. Obviously, we are finding falsely elevated values of PO2 because this patient is already on 4 liters of oxygenation, hence SpO2 from 82 to rose to 98, and person also was having a significant bicarbonate. Now, if you see it, what was expected, rise in bicarbonate, if you really ask me, will be roughly in this patient is around about 37, and for looking at it, we will see for every time there will be a rise of 4. So if I look that way, 16, 12 to 13 has to be elevated. And the calculation is that this patient had acidosis, no doubt about it, and that is respiratory. And along with he started also retaining the bicarbonate, which was expected, but he also had a little bicarbonate excess. So this patient, in nutshell, had hypoxemia, along with the metabolic abnormality was in the form of acute and chronic respiratory failure because of the bicarbonate retention. That is what it is saying. And obviously, he had a normal blood gas, a normal anion gap. So one can simply say that the net interpretation of this blood gas is patient having respiratory acidosis with some evidence of with metabolic alkalosis. Obviously, this is uncompensated because pH is beyond that range, along with hypoxemia, with normal anion gap. Why we are saying normal anion gap? Because to rule out any other third mixed disorder, in this case grossly, but for that I will not go beyond that. Now this is the electrocardiography, in which you will say simply tachycardia is there, nothing more you can see, except some non-specific changes in V1 to V2. So how will you confirm the diagnosis? What you should do? So the question is there, we have done the electrocardiogram, we have done other things also. Blood gases are available which are telling us, and there's the history. So the best way to go for this, obviously, we are not in a position to do a pulmonary function testing. That should have been the gold standard. But what we try to look at it, looking at the differential diagnosis. So for the confirmation, we went for the X-ray chest. And from this X-ray chest, we should come to know which is the likely of this patient. The answer for that is C, because if you see this one, this patient had in the A figure A or the X-ray A presence of pneumothorax. Here we are seeing bilateral extensive pulmonary edema. You can see cardiomegaly and a parahilar shadows, which are coming along with the cephalization of vessels, which is there. And here, if you see, you will see that this patient has got pneumonia of the right lower zone, looking more like a right middle zone getting affected because some amount of ciliate is getting affected. So this is the one which you see is a classical example of COPD, where you're finding hyperinflation, flattening of the dome of diaphragm. Obviously, instead of the tubular heart, there's a slight enlargement, there's some amount of irritation, but nevertheless, we need to further evaluate. The ECG is not suggesting anything extra. So he is now seeking your opinion regarding further management. The resident called us. He asked me, what do you think? What I should do next? So to do something extra, you need to classify the severity of expiration. You need to look when you're doing it, the severity, obviously, you see clinical evaluation, you try to look at it, is there presence of respiratory failure or not? If the respiratory failure is present, is it life-threatening or it is non-life-threatening? That's how you go sequentially in these cases. So when you want to see the severity of exacerbation, my dear friends, you need to look at it 5 important parameters, and the single simple clinical parameter is respiratory rate. Higher the rate, more is the problem. But nevertheless, we try to see in these patients already have a high drive. especially in emphysematous patients. In patients who dominantly have the blue bloaters, they may have a relatively lesser drive, but nevertheless tachypnea is a rule than an exception. Most of the time, if you find that the rate has gone beyond 30, probability of life-threatening is much more, provided it is associated with use of accessory muscle. And single important factor which comes up from the clinical perspective is the mental alteration or mental change, which tells you not only about the hypoxia, but predominantly it means there is a carbon dioxide retention, and it can be associated with throbbing headaches. Hypoxemia is important, but you need to see most of the time 1 to 2 liter up to 4 liter is good enough. If you calculate it, that is what we find out, 24 to 35% of FiO2 for every 1 liter you increase by 0.04. So if I give 4 liters, that means roughly that this patient was getting 0.21. You add nearly 33% of the oxygen was being given. On the other end, when you come up these patients, ideally we should use a Venturi mask than a simple oxygen prong. I will discuss about later, because quite often you will see as these patients have ventilating very fast, they may have a low or a high requirement, ventilatory need requirement. So when you give Venturi, which is a high flow system, takes care of it, and the probability of these patients going into worsening is much lesser than we are trying to use a nasal prongs, or we are trying to use simple nasal masks. So if somebody patient does not improve, then again it's a life-threatening, and it becomes imperative for us to rule out any other cause what we discussed, because majority of the patients will definitely respond to up to 35% of oxygenation. Partial pressure of carbon dioxide becomes important because it represents the acid component, and when we find it out, it is beyond 60 with a reduction in pH of less than 7.35, or if further worsening, when you see it, if it is less than 7.25, that defines the severity of acidosis. So in nutshell, if somebody asks you what defines the severity of exacerbation, you will straight away say respiratory rate, use of accessory muscles, what is the acute alterations in mental status, worsening hypoxemia, not responding to up to 35% of oxygenation, and marked elevation of carbon dioxide, leading to clinical evidence of acidosis, that is pH less than 7.35, worsen and the fairer, where you defend the look like the life-threatening less than 7.25. And these are the gold criteria. Another parameter when we tend to see is a DCAF and a BAP 65 score of MRC. DCAF stands for dyspnea, eosinopenia, consolidation, acidemia, and atrial fibrillation scores. If you see it, atrial fibrillation is a consequence of ventricular arrhythmia, which can happen in these patients. Breathlessness is a consequence, what we talked about. Eosinopenia usually tells you that there is a more neutrophilia, and this is unlikely to be allergic manifestation, which usually combination of asthma can be there. And if there is an associated consolidation, tells you about pneumonias, and acidemia tells you CO2 retention. On the other end, when you start looking at the BAP, first and foremost, you look at it clinically, like you have so what we see is the confusion, respiratory rate, urea, and the blood pressure for defining the severity of pneumonia. The MRC has given us simply, in this case, whether the blood urea nitrogen is getting elevated or not, along with what is the mental status, and whether tachycardia is there, and if age is more than 65. They're all probabilities. So both scores are important, and both can be done clinically on the bedside and with the simple investigations available. And both have very high sensitivity specificity, though BAP tends to be a little more sensitive in these cases. Once you have made the diagnosis of exacerbation, the next question starts coming: how am I going to manage it? Answer is straightforward. Obviously, you will try to give the pharmacological treatment, and simultaneously, because these patients also have developed respiratory failure, hypoxemia, hypercarbia. For hypoxemia, you will try to give oxygen therapy, and for the hypercarbia, ventilatory failure, which is starting up, you need to provide ventilatory support. On the other end, when you start looking at the pharmacology, when we talked about these patients have bronchospasm, so for that you need bronchodilators. Now then because there is an inflammation, how you tackle it, for that you need a glucocorticoid. And if there is a secondary bacterial infection or we find there is a bacterial thing which is happening, then we say, okay, we need to give these patients antibiotics. And as far as the bronchodilators are concerned, it is always going to be the short acting, where you can have a beta agonist with or without combination with anticholinergic. That is what we look at it. The common one which is used, SAMA, that is short acting muscarinic antagonist or anticholinergic, is your ipratropium, other drug of choice, preferably in combination than alone. Question comes up to give them with an MDA or nebulizer. Data shows they are both effective, but when person is breathless, it's much easier to take a nebulizer. And both are supposed to be equally effective, but because of the compliance and easier for the sicker patients, we prefer nebulizer. Another thing which is very important is when you nebulize, please do remember, never ever nebulize with oxygen. If you have to do it with air, or you simply use it with the nebulizer, but never ever do with oxygenation, which you otherwise could do in patients of bronchial asthma. Long-acting bronchodilators can be continued, which are like this patient has been on tiotropium, or if it has been on a LABA plus combination, we don't stop it and we continue. And if we have stopped it, we need to restart as soon as possible. Systemic steroids are very important. They shorten the recovery time, they improve lung function, and simultaneously when they improve oxygenation because they're acting at the level of inflammation. However, when you withdraw it, there is always a risk of early relapse because of subclinical response, because of the persistence of inflammation, and obviously they are also extremely important to reducing treatment failures and length of hospitalization. Standard recommendation is 40 milligram prednisolone, which is equivalent to 8 milligrams of dexamethasone for 5 days. But if person has been dependent for a long time, you gradually taper it to. The oral and the intravenous drugs are equally effective. Sometimes we do use nebulized budesonide, but this is a combination. This is not an alternative to oral one. However, those patients who are eosinophilic, that is one of the reasons the prognosis tends to be worse. They tend to be less effective. Now, this patient was given amoxiclavinic acid in emergency. So if I put a question to you, which will be the antibiotic of choice in this case? What will you like to use? Whether you would like to give these patients amoxicillin, or you would like to use a combination of amoxiclavinic acid, that is beta-lactam inhibitors, or quinolones respiratory, or injectables, or you don't need antibiotics. What is very important to understand the choice, whether a patient requires antibiotic, what are the triggers for exacerbation? Commonest are the viral infections, and most common tends to be rhinoviruses. Now we have been seeing some pattern of exacerbations in these patients with other viruses, including coronaviruses and COVID viruses. Secondary bacterial infections are not uncommon, but they can cause it, like pertussis, like your Bordetella, and other pneumococcal can also cause it, and so on and so forth. Air pollution is another important factor. And if somebody had from ambient temperature change from low to high or high to low, you can have it. But these are the guidelines, have a different BTS, gold, or ATS. They differ on the use of antibiotics. But what is very important is that you need to consider antibiotic if the 3 cardinal signs are anthonicin class 3 is present. That means there is a breathlessness with increased volume and purulence. If 2 of the cardinal signs is there, then you need to see what is the extent of purulence of the sputum is important. And if person requiring ventilation, you do need to consider it. And if you are monitoring CRP and procalcitonin and they're high, then probably is again the time to use these patients and the time to take these patients on antibiotics. But by and large, we are using antibiotics because of the secondary infection. Commonest cause of exacerbation are the viral infections, rhinoviruses, but nevertheless secondary infections are not uncommon, and hence by and large antibiotics are prepared. The first line today if you go to the Western world, is amoxicillin. We have been using very regularly at my institution, doxycycline and azithromycin. But when these patients do not respond, then we go to the second line. And fluoroquinolones we avoid primarily because of tuberculosis. But if you read the Western guidelines, they do talk about it. So this patient, if you really ask me, was coming to us, the commonest choice would have been doxycycline and azithromycin. But they have straight away used amoxicillin is not wrong. But if you go in a sequential manner, probably it should have been the second line than the front line. Now, as we know, this patient required oxygenation because this has a hypoxemia on the room temperature, and we're requiring around 4 liters, on which we have a more than 142. We don't need this much of a PO2. So what is important is question which comes up to it. Pick up the true statement what when we are given this patient an oxygenation of 4 liters with the PO2 142 and has a room temp oxygen percentage of 82%. He did not require oxygen as COPD patients are chronically hypoxemic. Nasal prong is the ideal device for this therapy as it is comfortable. Target SpO2 for him is 94 to 96%, and Venturi mask with a target of 80 to 90%, which is the true statement you need to look at. So when you see it is the fifth vital sign. And what is the target saturation? We try to keep, because these patients are chronically hypoxemic, we try to keep them around 82 to 90%. Therefore, if you see in this patient, we have given far more than what was required and desired. So what you simply required was 2 to 2 liters to 3 liters, maybe 1 to 2 liters, seeing and titrating it at the level of 82 because they're chronically hypoxemic. And when you give them oxygenation, you can actually induce hypercapnia because there is a worsening of VQ mismatch rather than the drive. But primary thing is VQ mismatch getting worsened, followed by abolition of ventilatory drive and the Haldane effect, which is an opposite effect of poor absorption and electricity with oxygen is not uncommon. And along with it, rebreathing can occur if low oxygen flow rates are used through face mask. Therefore, it is very important for us that whenever you do it, start with a small dose, a small prescription of 2 to 3 liters in patients of COPD in particular, and preferably try to use Venturi mask than anything else. It takes care of most of the things. But if person does not improve and requirement is more than 35%, look for an alternate cause for extubation. Now, in this case, if you see it, we can start, as I said, with the Venturi, you keep on stepping it up. Nasal cannula, you start with 1 liter, keep on doing it, and higher flow rates will be needed, especially when person has marked tachypnea, because at that point of time, high flow rate requirement becomes an important part of it management. So blood gas measurement should be measured as soon as possible within 30 minutes, and sudden cessation of supplementary oxygen therapy can, if you find there is a hypercarbia blood gas, please don't stop oxygenation. You can cause life-threatening rebound, hypoxemia, and patients can have arrhythmias and they may die. And similarly, when you use too much of an oxygen, you can cause significant hypercarbia, as I explained earlier, leading on to these patients developing hypercapnia and become altered sensorium and intubating. So be careful. Even after nebulization with salbutamol ipratropium, you still take it. How, and using accessory muscle, how will you proceed? You will use theophylline, you will use Mexel, or you will use NIV or intubate and mechanically ventilate. The question is to you, let's see what we will do. We will go in this patient continues to have work with the NIV in acute extubation. It is preferred over invasive ventilation and as the initial mode of ventilation, provided person is not unconscious, has not an arrest, or is not having significant severe hypotension, but that can also be because of orthopeak. So it is important is that it improves oxygenation and acute respiratory acidosis. So it's actually an excellent tool to reduce mortality, morbidity, and improve the outcomes in AECOPD. Today, not offering an AECOPD having respiratory failure, if they're conscious and not very severely acidotic, is actually giving poor treatment, and you are liable to be prosecuted or to be charged for it. Indications, we always look respiratory acidosis, pH 7.35, CO2 more than 45, And along with it, you have a significant breathlessness, accessory muscles, paradoxical motion, or you have a persistent hypoxemia despite supplemental oxygen. So this patient had all the indications for NIV. He was shifted and was put on the NIV. While you set the NIV settings in acute exacerbation of COPD, patient interfaces are important because that is how you will be delivering it. So it's a mask ventilation. So you can use nasal, oronasal or full face, but we prefer oronasal because full face has increased dead space, and same is true for helmet, we don't use it. And we try to use pressure targeted modes, but along with today we have now the option of using pressure targeted plus volume assured modes as well. IPAP, the positive pressure support, improves the alveolar ventilation and helps reduces CO2. EPAP opens the upper airway, neutralizes autopy, and it improves the oxygenation. Usually we use spontaneous modes with the backup of apnea mode. Commonly we start with an IPAP of 8 centimeters and EPAP of 4 centimeters. This is on when we are using NIV ventilators. On invasive ventilators, we see this IPAP means 8 centimeters is contains EPAP of 4. So pressure support is 4 centimeters. But when you do it, it will pressure support 4 and PEEP of 4 on invasive ventilation. So that is the difference. We should remember one thing. In simple non-invasive ventilators, IPAP includes EPAP. Whereas in invasive ventilator, they exclude, so you have to put 4 plus 4. That's the fundamental difference. So gradually you try to follow the same principle. You need increased time for expiration, less time for inspiration, and then you up titrate. It's like a mitral stenosis. You give more time to deflate, more time to lung to remove the gas from itself so that it can come back to its original FRC. So when you increase EPAP, you simultaneously must increase IPAP. Otherwise, your pressure support will reduce, alveolar ventilation will go down. Set maximum pressure which patients can tolerate without discomfort over a period of time. We titrated him. He did well with an IPAP of 12 and EPAP of 6, and FiO2 came down to 30%. He did well, tachypnea subsided. Now, what will be your suggestion regarding how you should monitor, how you oxygenate, humidification, bronchodilator therapy, and sedation? Because these things are important to ensure safe delivery and at the same time compliance of the patient. You are the best monitor. Doctor is the best monitor. Nurse is the best monitor. So the oxygen saturation we need to continuously monitor. And remember one thing: with acidosis, your saturation levels will be low. So you may have a paradoxically high PO2 levels. So be careful about that. You need to measure intermittent PCO2. You can have a side state ETCO2, but it will be less than PCO2 because of increased gap, what you call as the PCO2 minus ETCO2, and pH is required. But it is important, first your oxygenation will improve, then your pH will start improving and the CO2 will gradually come down. And we usually do it at 30 minutes and 1 hour. ECG monitoring to ensure there is no arrhythmias. Oxygenation, again, should be trained as close to patients as possible. Usually around the mask you will see. We don't put it at later on because it dilutes and may not give you adequate oxygenation. And we need to keep the target flow rates because FiO2 can vary depending upon the patient's respiratory drive and depth. Therefore, you try to titrate oxygen at a level which is usually in the masks so that adequate oxygen target of 88 to 90% are maintained. Avoid mask leaks, and delayed triggering may be caused by oxygen flow rates by more because it can interfere with it. Therefore, it is important for us to remember. A ventilator who has got an internal oxygen blender is recommended at 4 liters. Sometimes you can have paradoxically fall and you not maintain, and that can happen in the advanced NIV machines or in ICU ventilator. Humidification usually we don't need, but if it has to be used, heated humidification is the one which should be preferred, not the artificial nose. Sedation we are using now because initially these people are hypoxemic. They may not respond, they may not do it, they may not agree to you or may not listen, may be agitated. So we are using conscious sedation. UK define the BTS says we use morphine, but what we are using is fentanyl, obviously a type of narcotics, but along we need to sedative doses And another one that we are using is when you do not have any problem is a dexmedetomidine is the one which we use very commonly for conscious sedation. He improved, but after 30 hours or so, he again worsened. Drowsy became tachypneic. There was a worsening of respiratory acidosis, which was. So, how are we going to proceed, my dear friends? We first need to know what are the reasons of the NIV failure. Is it a ventilator cycling independent of patient effort? That means there is the inspiratory trigger sensitivity is too high. So you need to adjust trigger. But most important reason for this is reduced mask leaks are there. So we try to do it. Ventilator is there, but it is not triggering what patient is making. Again, leakage is the problem. You try to do it. So what we try to do on the ventilators is we pick up the inspiratory time, and that can be taken care of. Chest expansion, apparently not triggering because of this. Again, we try to increase IPAP, and in neuromuscular chest wall disease, consider longer TI. But in patients of CRPD, we always consider smaller inspiratory time because you need to give long time to expiration. So this is what is important. When you find excessive TI or IPAP, then you try adjust as necessary. So what is important for us is we ensure that when the expiratory muscles start working, a cycling takes place also on the ventilator. Otherwise, they can have a stacking of a breath. They may have a missed triggers, and ensure that to counter that, you have a good amount of PEEP or the EPAP which has been fixed up to take care of the trigger sensitivity. Indications of ICU admission besides NIV, you can give it an emergency or watch, can be a person persistent with breathlessness which does not respond, continues to be drowsy, or after improvement becomes drowsy, become markedly tachypneic at that point in time, or in simple words, a person who comes who is unconscious, who has got a significant cardiac abnormalities which are not working it out, he is having unconscious or is not responding to the command, that is the time you need to take them immediately on the intubation. And later on, if person has responded early and later on failed, it is better to take these patients on invasive ventilation. Late failures are associated with very high mortality. We try to use mechanical ventilation invasive when person is not able to NIV or NIV failure, as discussed, post-cardiac or respiratory arrest, psychomotor agitation or alteration of sensorium. Patients can be delirious or because of alcohol withdrawal or because of hypoxemia associated, or maybe because of withdrawal. Quite a lot of them are smokers. What we don't talk about, the tobacco withdrawal in particular can also cause, has a vomiting aspiration, unable to seek excrete of throughout the phlegm, and can have a significant hemodynamic instability, which itself could be because of photopeep. So when we intubate these patients, wait, see how they do it, not more than 4 to 5 per minute, and see how the air complement the BP goes up. And when these patients have a recurrent arrhythmias and having a left ventricle failure, when you take them positive pressure, it improves LV function and patient improves. Again, the same principle setting, you can use either mode, but what is very important to remember is give adequate time for expiration. So you need to have a relatively slow rate. We come with a 6 to 8 ml per kg. Respiratory rate should be 10 to 15, with an inspiratory expiratory ratio of 1:2. Oxygenation targets are the same, and gradually titrate up the pH. If you do very rapidly, the patient can develop sudden shift in the anions and cations, leading on to, from acidosis, they become alkalotic, and the net result is they can throw a seizure, and again, everything what you have started may go waste. So gradually step up the ventilation and bring the normocapnia for them is what was their basal. So if they had 60, so for you, the carbon dioxide 60 should be the target, and the pH corresponding will come up as the compensation starts taking place in next 24 to 48 hours. This is what we see it, what is wrong here, that's what we need to look at it. If you see it, it is not touching it here. That means this patient continues to have a significant amount of autophagy. Now, how are you going to correct now these things? But what is most important, which among the following measures needed for correcting autopsy? That's a question I'm putting it up. But how you correct autopsy? So first and foremost thing is that one question is a low tidal volume, low respiratory rate, prolonged respiratory time, and nebulizing with bronchodilators. Most important thing is that there is an obstruction. There is an obstruction, so you need to take care of the bronchospasm. So you need to nebulize with it. You need to reduce the tidal volumes, and you also need to reduce the respiratory. It gives much more time. And simultaneously try to give the PEEP so that internal pneumatic sprinting takes place. But if you see, so that it will lead to deflation of the lung. But quite often we tend to use 50 to 80% of intrinsic PEEP. But when we find that the auto PEEP is too high due to high minute ventilation, then probably PEEP will not be at that point of time. It is sedation which is required. So what is very important in patients on ventilation is adequate expiratory time. That you gain by low respiratory rates, low tidal volumes, and also equally important is by giving adequate management of the underlying bronchospasm and inflammation. If rate is too high, like in patients of predominant emphysematous, you may need to sedate and ventilate these cases. Then you need to assess readiness for discontinuation when these patients have been there. Please must assess cardiac function in these patients. When you take these patients on ventilator, please look at cardiovascular stabilization. BP may fall because of autopsy, may because of use of sedatives, or because of relative fluid deprivation. So give them fluid, see how it has stabilized, and then if autopsy is there, what we have talked about, aggressive nebulization has to be done, but nevertheless look at underlying left ventricular function by echocardiography clinical evaluation. Same way when patient is stabilized after 48 to 72 hours, then start assessing for discontinuation. So we should start spontaneous breathing. They should be off all sedation. We try to switch to spontaneous breathing for pressure support, and then we gradually try to reduce. The volume, the pressure support should be equivalent to the P-plat or the pressure control pressures which you have been using above P. And then you try to use spontaneous breathing trials. You can look at these patients, the ratio which you called as a Dobbins index or rapid shallow breathing index, that can be done, that can be seen. And one patient does well, then probably you can think in terms of extubation. You do extubation provided person can maintain a good cough and can spit out the phlegm. If there is a difficult breathing, then we look at which can happen in up to 40% of these cases. That can be because of the underlying respiratory dysfunction, again working back, or cardiovascular dysfunction. So we try to do in these cases two things. In these patients, when you're shifting from positive pressure to spontaneous breathing, there occurs a development of autopsy with increased work of breathing. That again lead to dynamic hyperinflation, the same mechanism which caused the failure starts working again. Then there occurs a rise in venous return to the right ventricle is much more, leading on to displacement of interventricular septum to the left side, and simultaneously increase afterload again puts a pressure on the left ventricle. The net result is a cardiac dysfunction, respiratory dysfunction, and obviously failure is obvious in these patients. So how you assess the cardiac failure? Either by echocardiography or sometime in these patients in CP and ischemia could be there. So we took ECG, we took tropi, but very important sensitive for the left ventricle failure is a biomarker in the form of BNP, provided there is no kidney failure and there is no obvious right heart failure. Then you do, if you have already baseline, then it will jump 2 to 3 folds. So that gives you an idea. So what we are trying to do is the determination of difficult breathing. You look at central drive for the sedation, respiratory muscle strengths you try to see in these patients, electrolyte imbalances, and quite often these patients on steroid therapy, so that is atrophy and increased respiratory load. Nutrition you look, neuromuscular you look at it, but for me most important is upper airway and cardiac load along with reduced respiratory muscle strength. So when you do it in these patients, we try to take NIV. So assess patient readiness to wean, we perform SBT for 20 minutes, for 2 hours or so, A person is conscious, can protect you, a good cough, well tolerated, you extubate, monitor, and that's there. But if you find post extubation failure, this is one place NIV is excellent. But one thing remember, person must be able to expectorate. That is very good, important. If it is not, you keep on trying this system. And if somewhere we find out that a patient has a cardiac dysfunction, we try to support heart by means of your uh, if cardiac dysfunction is happening, you can use I preferably we use levosimendan, or you can use theophylline also, but preferably it is levosimendan because it also improves diaphragmatic function, increases contractility, and the data is also showing the role of nitrates at this point of time to add, which can take care of cardiac dysfunction secondary to ischemia. And this is so you have to use multiple things, but most important armamentarium with you is non-invasive ventilation. So the take-home messages, my friends, are rule out differential diagnosis before a diagnosis of acute exacerbation of COPD, oxygen therapy with venturi mask with target SpO2 of 82 to 90%, no need 96, 97%. Must nebulize only with air-driven nebulizer or meter dose inhaler. Never ever use oxygen for nebulization. Optimal medical therapy in form of short-acting bronchodilators, including both muscarinic and beta agonists with steroids, is the mainstay of treatment. You use antibiotics if required, and NIV is the one which takes care of most of this. And if once you decide to take the patient on mechanical ventilation, try to see to it you avoid autopene, give early spontaneous trial, and if there is a difficult weaning, you use NIV in these cases. And also, if there is a further challenge, please always rule out cardiac dysfunction in these cases. Thank you very much.
Thank you, Dr. Govil. Unfortunately, Dr. Govil is not able to take up the questions.
Dr. Chaudhary,
there are Dr. Chaudhary. No, sorry. So there are a few questions for Dr. Dhruv Chaudhary. One is why oxygen therapy can cause secondary hypercarbia in COPD. So, and he's asking the physiology behind.
Yeah.
So, Doctor, and the other question is, can we ventilate with 21% oxygen, irrespective of whether the patient is COPD or not? So, the general fear of using oxygen in COPD is, regarding the suppression of the respiratory drive. Because of the chronic hypercarbia, the bioreceptors and chemoreceptors and the central respiratory drive is set at a higher level. If we discuss about the physiology, if you say that the deoxygenated blood is more capable to carry CO2. That means if you oxygenate the blood, the CO2 carrying capacity is reduced, and that's why there is CO2 buildup. So that's what happened if you give oxygen to these patients, and that's why there is a general consensus of not using higher oxygen flows in these patients. We also call it as the Halden effect. Uh, for folks who want to go into details about it. So can you ventilate with 21%? Yes, of course, you can ventilate with 21%. If your oxygen saturation, as Dr. Dhruv mentioned, is around 88 to 90%. Can we have, the next question is, can patient having higher intrinsic PEEP, is there a fixed way to adjust set PEEP? How does it impact the work of breathing? Well, we all are worried about having auto PEEP in such patients, and um, the uh, the auto PEEP does cause increased effort for us to trigger the breath normally, and it puts the muscles of breathing at a disadvantage. So if you say work of breathing, the patients would not be able to trigger the breath. He will find it harder to trigger the breath. Normally so if you're breathing spontaneously, you need to have a uh, lesser change in the negative pressure. From the negative to the positive, you need a very smaller change to trigger the breath. If you have a patient who develops auto peep, then you have to overcome that auto peep to make that change in the alveolar pressure, or sorry, the pleural pressure, to trigger the breath. So if you put that auto peep, then you make that difference between the alveolar pressure and the pleural pressure lesser, so that the patient can have lesser effect or lesser effort to trigger the breath. Okay, so
Sheil, may I add some point here?
yes, please, Amol.
So now this question was about the high in patient with uh, high PEEP. What is the fixed pay of? So basically, when you're adjusting the PEEP or the lower EPAP, so we have to actually look at the bedside and see whether all the patients' breaths are triggered. So if you clinically identify that all the patients' breaths are not triggered, that means the auto PEEP in the patient is more than your EPAP or PEEP. So that way you can increase the PEEP or your EPAP to get all the patient breaths which will be triggered by the patient. And so that's why. So and talking about the other question was, how does it impact workout breathing? So so when you talk about workout breathing, it's your pressure support or IPAP. And when you talk about triggering or auto PEEP, it is about your when the setting which is important is PEEP or we can EPAP. May I add one point about this hypercarbia in COPD?
Yeah, please, Amol, go ahead.
So now, like previously, people used to believe that when you give oxygen, because these patients have a hypoxic respiratory drive, so as you give oxygen and you normalize, the patient lose their respiratory drive. And definitely there is some decrease in minute ventilation when these COPD patients who are chronically hypoxic and you put them on oxygen. That's why when we get these patients in our with exacerbation, we avoid giving oxygen nebulization. Even a small amount of oxygen has a risk of causing hypoventilation, and it's a very true fear, and that's why all these patients should be kept in a monitored environment. Now, physiologically, as you had mentioned about the hydrogen effect, that is one of the important reason why you get the CO2 buildup, and the other reason is VQ mismatch. So as and the hypoxic pulmonary vasoconstriction. So in these patients, when you give oxygen, the hypoxic pulmonary vasoconstriction is relieved, and that's why the lung which was previously not getting perfusion, it start getting perfusion. That's why you increase in dead space, and that's the reason why you get an increase in CO.
Thank you, Amol. That was very well explained. We have another question. Role of HFNC in COVID. You want to take that, Amol?
We can take that question, but is it related topic?
No, I think let us skip that. Please stick to COPD.
Yes,
Injection methylprednisolone role in COPD. Role of aminophyllin exacerbation if not responding to steroids. You want to take it, Amol? Role of methylpred. So So Amol is muted. So methylpred has been used for exacerbation of COPD. If you are not able to relieve bronchospasm in with the beta 2 agonists. So yeah, so the answer would be yes. Is the role of diuretics at the diuretics in weaning to prevent right heart failure? Well, again, we all know that right heart failure has been one of the major contributors in COPD, core pulmonary patients who are difficult to wean, and we do use diuretics with conflicting evidence uh, uh, to get patients off the ventilator. I think that's about it. Right. So thank you so much, Dr.
Still
Dhruv
not
Chaudhary.
prophylactically. So
Not
don't use,
prophylactically.
yeah, not prophylactically.
Yes, not prophylactically, please. For the next talk, again, it is a very important talk, and I would like to invite Dr. Shiva Iyer, who's again very dear to us. He is the professor and head Department of Critical Care Medicine at Bharati Vidyapeeth Medical College, and he is again a very, very passionate teacher, and he is again talking on a very, very important talk, that is the end of life care and communication, again, which is somehow we lack. We are not being taught in the curriculum. We are not very good at it, and communication remains the bane of our clinical practice. So I would urge people to make good use of this, and you also have a communications and end of life session during your exams as well. So over to you, Dr. Shiva Iyer.
Hi, everybody.
Good afternoon, everybody. I thank the Tata team for having invited me for this BRITE 2021. I know I'm bringing up the last session for the day. And what I'm going to do is to cover end-of-life care and communication skills in ICU around EOLC. So today I will touch upon the current status of end-of-life in India, then look at the end-of-life principles gleaned from all over the world, and I will be using the ICCM IAPC elicit pathway to illustrate the points. I then have a case scenario, which we will discuss how we can plan end-of-life care. But before that, how to talk to people and what communication skills are required for managing end-of-life. Now, if you look at this, end-of-life care in India may be said to have started 1981 when Meenu Masani, a celebrated parliamentarian in Mumbai, established the Society for the Right to Die with Dignity. 1996, Dr. Kolabawala first prepared a living will draft. Then in 2005, under the guidance of Dr. R.K. Mani, who was the president at that time, our first guidelines on end-of-life care came up from the ICCM. Subsequently, there were 2 Law Commission reports, and there is an important Supreme Court judgment in 2018. ICCM, you can see from 2005 to 2020 has been involved actively in all stages of planning and providing end-of-life care to patients. The latest iteration of the ICCM guidelines is the Integrated Care Plan for Dying, which is a joint statement of the ICCM and IAPC in 2014. And then there is in 2019, there is a FICCI elicit guide for patients, administrators, and hospitals. The pathways which I will be discussing will be from this FICCI elicit guide. Subsequently, the National Accreditation Board for Hospitals, under the guidance or along with ICCM, established these standards for end-of-life care. It appeared as an annexure to the 5th edition of the NABH. The turning point really was the Supreme Court judgment, which was People versus Common Cause. And in that judgment, the Supreme Court gave permission for people to prepare advance directives. And they said that advance directives are legal in the sense of providing legal support for withholding care. And then, of course, the ICMR has come up with certain documents. Some of them have been published, some of them are yet to be published. So there's a DNAR, do not resuscitate document. And then regarding advance directives and withdrawing therapy, draft papers have been prepared, but they have yet to be published. So this is about the end-of-life care in India. And as you can see, we have come a long way from the guidelines in 2005, when people were worried about whether we have legal support or not. I think now, if we follow appropriate ethics, then we should not have any legal problems in implementing appropriate end-of-life care. So let's look at the case. This is a 45-year-old patient with severe COVID-19 who was not maintaining on non-invasive ventilation with 100% FiO2 and was intubated 3 days back. He has now developed shock, is requiring vasopressor therapy, requiring noradrenaline and vasopressin. He has developed decrease in the urine output and is on invasive ventilation with 100% FiO2. He's already received 2 cycles of prone ventilation. The family has been counseled, not the entire family, but a representative of the family has been counseled regarding the current status and options for further management. So now, what will you do? How will you counsel the family regarding the current status and options for further management, and how can we organize a family meeting? So when we consider counseling in situations like this, severely ill patients who are on the cusp of maybe they may recover, they may not recover, what you need to do then is to accurately identify the illness, the prognosis, and the appropriateness versus the inappropriateness of life-sustaining interventions. Once you've done that and the team is ready, then you need to establish consensus among all healthcare providers. Then, if the patient is competent for himself to decide, which is not often the case in ICU, then if the patient is competent, then you may discuss with the patient. If the patient is not competent to take decisions for himself, for example, he's sedated, paralyzed, as in this case, then you have to check whether there's an advanced medical directive available or it's not available. If an advanced medical directive is available, then you can work with the appointed healthcare proxy or next of kin and implement the advanced medical directive. If it is not available, then we have to identify the appropriate surrogate. Once that is done, then you have to do an honest disclosure of the terminal illness, the prognosis, and the inappropriateness of life-sustaining interventions. This disclosure then leads to a process of shared decision-making. We'll be discussing this as we go along. If through that shared decision-making, there is no conflict, then you can implement plan for withdrawing therapy, palliative care, after death care, bereavement care, as may be the case. And then later, once the thing is over, then you can review the care process. If there is conflict, however, you have to enter into a conflict resolution process. So this is the entire chart. Now, what I'm going to do is to go through it stepwise. And in that, necessarily, before we identify such an illness as terminal, we have to see what therapeutic options are available with us. So in identifying the nature of the illness accurately, you need to find out the degree of shock, the requirement for vasopressors. On vasopressors, how is the blood pressure maintained? Is he stable, or is he continuing to require escalating vasopressors? What is the stage of AKI? Is there a need for renal replacement therapy? What is the degree of respiratory support? Are there any correctable factors? For example, there's pneumonia, or in prone, the saturation is improving. You're able to increase the PEEP as well without allowing an increase in the plateau pressure. Since he's only 45 years old, does the family want to consider the possibility of an ECMO? In which case, then you'll need to discuss with an ECMO team and think of whether ECMO would be suitable for this patient or not. And of course, you need to think of whether there's any background life-limiting illness or not. So all this homework we need to do before we, try and establish consensus among the healthcare providers. The establishing consensus among the healthcare providers is an important step, because in multidisciplinary, multi-specialty care, there are multiple stakeholders, and all of them may be speaking to some or the other relatives of the patient. And so therefore, the intensivist, the infectious disease team, the family physician, nephrologist, nurses, respiratory therapists, all will need to have a consensus among themselves. And for this, it is necessary that there is a captain of the treating team. The captain of the treating team in ICU usually is the intensivist, be it a closed ICU or an open ICU. So the intensivist has the responsibility to talk to all the stakeholders among the healthcare providers and establish consensus. So if consensus is established about the treatment plan and what needs to be done further, then you can go ahead and plan talking to the family. Before that, let us look at what the treatment options are. So you can see there are 3 treatment options. One is to continue organ support and aggressive therapy and fight till the end, in the terms what patients describe it usually. The second option could be because patient has had a severe COVID-19 pneumonia, he is not responding to prone ventilation and has now developed a refractory shock, and an AKI, chance of survival are low, and so therefore consider withdrawing therapy. And if you're not able to make a decision, then you can offer what is called a time-limited trial of aggressive therapy, which we're going to discuss as we go along. Now, determining the competence of the patient is something which is very important, even in ICU. So if the patient is awake and oriented, then maybe you can discuss it with him. But in this case, obviously this patient is sedated and paralyzed and is hence not competent. We can check for whether an advanced medical directive has been prepared. It is less likely, because even though the Supreme Court in 2018 has given permission for people to prepare or execute advanced medical directives, the necessary legal process for that has not been well defined. If there is an AMD, then you can identify the healthcare proxy or next of kin. And if that is not available, then you need to identify who the appropriate surrogate is. So the appropriate surrogate, may be the wife, who would be the first legal surrogate. If she's not available, then the parents or the adult children or the siblings, brother, sister, or the cousins, and then finally friends. Now, there is no established order or hierarchy of surrogates in India, but this is generally what is used, especially for organ transplantation. And we can use the same process in patients in whom we are considering limitation of therapy. This judgment that I have put across is the Supreme Court judgment that I spoke to you about, 9 March 2018. Deepak Mishra and A.M. Khalnwilkar, the Chief Justice at that time, Deepak Mishra, they allowed the preparation of an AMD and said that it is within the rights of an individual under the Constitution of India to decide what treatment he or she will receive. We need to also keep in mind possible socioeconomic implications, especially before we counsel. So is there insurance? Is there a government insurance scheme which is applicable, Mahatma Jyotiba Phule or Ayushman Bharat? What is the family capacity for taking care of ongoing bills? Are they from a rural area? Will they be selling off land or fixed assets to pay for this illness? Are they going to go for crowdsourcing of funds? We've seen a lot of this during the COVID-19 epidemic. So all these are things that you need to consider regarding the economic implications as well. Okay, so let's say that the consensus has been established among healthcare providers. There is no competence for the patient. Patient is sedated, paralyzed, and there is no AMD available. Now, the appropriate surrogate in this case is the wife. She's available. And now you need to make an honest disclosure of the illness, the prognosis, and the appropriateness, inappropriateness of intervention. The shared decision-making process is called a shared process because on the one side, we have to respect autonomy of the patient. In this case, it is substituted autonomy, as the family will be deciding on behalf of the patient. And we have to look at the balance of beneficence and non-maleficence as judged by the healthcare providers. A third important part is the question of distributive justice, which has arisen multiple times during the COVID-19 epidemic, but it will not be part of what we are discussing today. Now, in making this honest disclosure, discussing prognosis, and exploring the treatment options with the family, communication skills are most important. So I've put here the Cardiff 6-point toolkit. The Cardiff 6-point toolkit comprises comfort, question style, language, listening/use of silence, reflection/acknowledgement, and summarizing. Looking at comfort, it is important to ensure a comfortable physical and psychological setting for the family. Many times, especially during the COVID-19 pandemic, our discussions have been over phone. So ensuring that the person has time and is available to discuss, making them comfortable psychologically before you begin to describe what is happening or exploring their understanding is most important. Knowing the emotional state will make a lot of difference. So ensuring this comfort is very important. Equally, if you're going to have a face-to-face meeting, then a comfortable setting where there is enough seating, there is water available, tissues available if required, and you're unlikely to be disturbed. So everybody's phone is off. There is no disturbance likely to happen. That's about a comfortable setting. The next is about the question style. So whenever we ask questions of patients or their families, there are 3 types of questions that we can ask. The first type of question is an open-ended question. So an open-ended question is where the scope is wide. For example, how are you feeling today? What is uppermost in your mind? That's a typical example of an open-ended question. Now, supposing the patient comes up and says that today I'm having cough and this cough is disturbing me a lot. So then I move on to what is called a focused question. Say, can you tell me more about your cough? So that's a focused question. And then subsequently, as I'm exploring the cough, if I want to find out about hemoptysis, I ask, have you had blood in the sputum? Have you passed blood in the cuff? That becomes a yes or no question, and that is described typically as closed-ended question. So open-ended, focused question, and close-ended question. So each has their place, and it is better to start the interview with an open-ended question. The use of language is of paramount importance. As doctors, we are prone to use medical jargon. We describe the condition of the patient in terms of disease process, in terms of organ support, which can become very difficult for laypersons to understand. Besides, then there is, of course, the question of languages. In India, people speak multiple languages. So in Maharashtra itself, so Marathi, Gujarati, Hindi, English. So multiple languages patients may be knowing, and you need to find out which language they're likely to be most comfortable with. Then there is, of course, the question of culture. Then there is a question of culture, where cultural situations also will play a part in communication. Listening, one has to be present completely when in an interview. In that interview, it is important to pick up not only verbal but also non-verbal cues. In addition, listening to the patient is important, and you need to be also looking at what your own reactions and feelings are. The use of silence is an important tool, and allowing people to speak most of the time is an important part of the medical interview. Studies have shown that doctors tend to speak 80% of the time, whereas patients or relatives get a chance to speak only 20% of the time. This should be exactly reversed if we have to have a successful interview. Then regarding reflection and acknowledgement, reflection is a technique which is used, and I will be describing an example as we go along, where you reflect what the patient tells you in order to explore it further. Then acknowledgement of emotion. Again, this I will be describing as we go along. Unless we acknowledge the emotion with which the patient or the family is speaking, they are unlikely to understand what factual information you're giving. So acknowledgement of emotion takes precedence over giving factual information. And then finally, it is important to summarize. Now, summarizing, not only is it done at the end with a further plan and with providing support to the family, but it is also done with each chunk of information you provide. So provide information in small chunks, preferably one idea at a time. And then once you've given that idea, then you check whether they've understood or not, and then summarize what they've understood. So this is the Cardiff 6-point toolkit, and these are all important points when we are communicating with the family. In intensive care, there is this very nice educational module from the UCLA Health website, and it describes these 5 techniques. The first technique is called Ask, Tell, Ask. The second technique is called Tell Me More. The third technique is about using reflections. The fourth is about responding to emotion. And the fifth is assessing the information coping decision-making style of the family. And this may be diametrically opposite in some families. So you have to adapt to that. So the Ask, Tell, Ask principle first is to ask the patient and family to describe their current understanding of the situation by asking open-ended questions. Then asking permission also helps to establish mutual trust. This helps us to negotiate the agenda for the meeting, and also gives us an idea about the informational and decision-making style of the family. Once you've asked them this, explore their understanding, then you tell the family in clear, simple language about the situation, a language that they understand, and be mindful about using medical jargon. Once you've told them, then you ask what they have understood and clarify further if necessary. So this is the Ask, Tell, Ask principle, and it is probably the most important principle. The second principle is called the Tell Me More principle. Now, conversations that occur with families occur at 3 levels. One is a superficial level where the family is trying to understand the information being provided. At a deeper level, emotions to that information are being elicited. So, for example, you've told them, I'm afraid the prognosis is not very good. Then feeling of fear, feeling of anxiety, sometimes grief. These are the emotional responses that may be triggered. And at the deepest level is, what does this information mean to me? So what's going to happen to me? Supposing something happens to my patient, then what does it mean for me? So these 3 levels are occurring, and therefore using the Tell Me More principle is extremely important. Here is an example. So restating or paraphrasing a patient family statement can be a powerful method for eliciting further information or exploring understanding. So here you can see an example of using reflection. So the mother is asking about her son. I can see what you mean, but how can I give up hope? So the doctor is using the technique of reflection. He's saying, give up hope? What do you mean? And the mother then says, what will I do if he gets sicker or does not make it? So you've reached the deepest level of the conversation by using the technique of reflection, and it helps you get an insight into what the emotional state of the mother is. Some more examples of using reflections. Now here, let us say in this case, the patient's brother-in-law is saying, I get what you're saying, doctor, but please don't tell my sister. That means the wife. She will be devastated and won't be able to handle it. So the doctor, using an empathic and kind manner and allowing for enough silence, says, I can see that you care deeply for your sister and want her to be prepared to accept the situation. And then he allows silence. So in that silence and the empathic and kind manner of the doctor, the patient's brother-in-law breaks into tears. And he says, she has 2 small children, doctor. I don't know how she will cope. She's not working as well. So the underlying emotion is brought out, and the importance of that is underlined by using reflections. The next is about responding to emotions. And in responding to emotions, we need to be present completely. So our heart and our mind should be present. We should not be distracted. We should be mindful of our own reactions and feelings to what is happening. We should closely watch for verbal cues and also for non-verbal cues. The acknowledging of emotions can be understood further by using a mnemonic. It's called the nurse mnemonic. So first principle is naming. So naming the emotion appropriately. Example, some people would be upset by what is happening. Rather than saying that, I can see that you are angry. People generally don't like to be told what they're feeling, especially if they're feeling anger, they don't like to be told that they're feeling angry. So upset would be a better terminology for that. Then understanding and appreciating what the patient is experiencing. So you can do that by saying, I cannot begin to imagine what it might be like to be in this situation. In understanding, it is important not to give false hope or premature reassurance. Showing respect can be a non-verbal response, but a verbal response can help validate the emotion. Depending on the strength of the exposed emotion, you might want to give an equally strong acknowledgement. Praising the way that the patient family is coping is a good way of showing respect. Support can be expressed in many ways. Willingness to help, being available, expressing concern, making statements about working together for resolution are all very useful. We have covered a lot of ground today. If you want to ask me anything else, I will be available in my office. And of course, we have a scheduled meeting for tomorrow. So support is extremely important. And then finally, exploring what people are feeling with open-ended questions or inviting them to share their story is a good way to help them express their emotions. For example, what has this been like for you? I've given you a lot of information. What is on your mind? What are you thinking? So acknowledgement of emotion and exploring of emotions is extremely important. Coming back to our case, after exploring with the brother, option 3, that is a time-limited trial of aggressive therapy, was chosen. Now let us understand further what we understand by a time-limited trial. So patients who have an uncertain prognosis or have unclear preferences. So here, both things were there. The prognosis was uncertain because a young person may still recover from shock and multisystem organ failure. And preferences were unclear because there were multiple stakeholders. Of course, being young, they did want to continue fully. At the same time, there were social economic implications which are making it difficult for them to decide well. And so therefore, a time-limited trial can work in such a situation. So this time-limited trial, of course, was given during ICU stay. So a time-limited trial is an agreement to initiate all necessary treatment for a certain period of time. Now, this period of time may be 48 or 72 hours. One must use clear and concise communication, get an insight into the specific values, goals, and preferences, set a time frame for reevaluation. So we'll speak daily, but at 48 to 72 hours, we decide regarding the aggressiveness of therapy. Define also what you're going to do at the end of the time-limited trial. You can set specific narrow goals. So for example, change in the SOFA score, whether the organ system are failing further, then is the vasoactive support going up? Is the respiratory support not coming down? So all these things are things which can be discussed and explained, especially to people who can understand. You need to also focus on what the patient and family perception of improvement. So for example, in India, perception of improvement is if the person opens eyes and obeys commands. But the organ system failure would be a better way. And bringing this to their notice is extremely important. Getting an insight into the expected quality of life and functional status following ICU survival using pre-admission quality of life is extremely important. So in our case, of course, pre-admission quality of life was very good. And so even expected quality of life after ICU stay is expected to be good. Then what are you going to evaluate at the end? If there is improvement, you're going to continue treatment. If it is unchanged or worsened, then depending on the discussion at the start of time-limited trial, one may consider prolonging of the time-limited trial or change the treatment to comfort care or withdraw organ support. So this is from an article in intensive care medicine, Eliazule, Wink, E, and it's an excellent article. So those who are interested can go through this. So the time-limited trial was offered. 3 days later, the vasopressor requirement had not come down. In fact, the blood pressure had dropped. There was no improvement in respiratory function. Still 100% FiO2 was required. Prone was not possible. And in this case, due to limitations, ECMO also was not possible, and the patient was anuric on renal replacement therapy. So clearly, there was a worsening of the prognosis, worsening of organ system failure, and the chance of survival had dropped further. So what does one do now? Family is still unclear about their preferences, and they still are not clear. This may be the time where you may want to organize a family meeting. And the spikes mnemonic, which has been used in end-of-life care in cancer, I have modified for organizing a family meeting in the setting of intensive care. So setting now, especially in COVID-19, we may do a face-to-face meeting, but it is mostly online. So there have been times when we have arranged a WhatsApp video call. Then before you organize the video call, you gather the background information, find out who the stakeholders in the family are, the wife, who is the head of the family, then who is the financial supporter, is there a family physician, is there any close friend who needs to be there, then who was being counseled daily, is there a sensible member in the family who understands the prognosis and is able to be rational about what is happening, not just emotionally affected, is there conflict in the family, do some people feel that we should continue, some people feel that we should not continue. So all this background information before you actually do the family meeting is extremely important. Then of course, once the WhatsApp group has been created and you've initiated a video call, then you can start by exploring the perception of the family, maybe through the person who was being counseled daily. Like I said, in this case, the elder brother of the patient and the wife. These are the people who are being spoken to daily. So since the brother is likely to be more rational, you can request the brother to describe what he sees is happening. So Tara, तुम्ही सांगू शकता का मला? Can you summarize for us what you've understood so far regarding the illness and what we've discussed so far? So then we can go ahead. So once this perception is explored, you will find that there will be gaps and he may not be able to completely describe what is happening. So using open-ended, sometimes closed-ended questions, you can complete the picture for the rest of the family. Once that picture is completed, then you can ask if anybody else in the family have any more questions about what is being discussed. So once the perception is completely explored, then you can start your description. Maybe you can start by saying that I'm afraid there is the news is not very good. We've not had a good response to the escalation of treatment and the aggressive therapy that we've been doing. And we are really at the end of our time-limited trial. And now we need to decide how to go ahead. And then, of course, you provide the knowledge regarding the time-limited trial and the things that have not gone well and what the current option is. Now, as you're describing this, make sure that you give your knowledge in small chunks. With each small chunk of knowledge, check if they've understood, clarify if required, if the understanding is inadequate. All the time, keep a mind on the emotions. Since it's a video call, you will be able to notice people's reactions. For yourself, in the WhatsApp video call, along with the head of the team, you may want another intensivist, especially the one who's been speaking to the family before and with whom the family has a rapport, to be present. So one person can then, help to identify if emotions are going high or if there is any anger or grief that needs to be explored further. So acknowledging emotions as we go along is extremely important. And then at the end of the meeting, one can summarize what is to be done and outline what the further plan is going to be if there is no conflict. Unfortunately, conflict is not uncommon. Many times, family is not willing to discontinue care. It is completely understandable given that the patient is not very old, young, and breadwinner of the family. At the same time, they are unwilling to pay or don't have the means to pay. So in such cases, then what we need to do is to explore how they can continue to be supported emotionally, and to make them understand that it's not a question of payment, that it is a question of not helping the patient or the family. The interventions are not appropriate at this stage. So continue this open and repeated discussions with continued emotional support, and sometimes multiple meetings will be required before patients will agree for withholding withdrawing care. If the conflict continues to persist, then there is a well-defined conflict resolution process. You can enlist expert consultation to continue the negotiation during dispute resolution process. You can give notice of this process to the surrogates that you're getting expert help. You can obtain a second medical opinion, preferably of the family's choice. Now, most hospitals have an ethics committee or an interdisciplinary hospital committee that will review the file, if necessary, speak to the family also. Then, if after this also there is still disagreement, then you can offer the surrogates the opportunity to transfer the patient to an alternate institution, if that is possible. Just the process of going to another hospital, finding out, exploring, talking to other people, and they see that clearly we have no hidden agenda. Then they come back and say, "Hey, doctor, we'll continue what you're doing, and we are now open to withholding, withdrawing." Very, 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 very rarely, judicial remedies may be required. And if such are required, then during the process of judicial remedy, you will have to continue treatment. I have not seen this happening in my practice so far. This is more from the literature. So once conflict is resolved, or if there is no conflict, one can implement a plan for withholding withdrawing therapy, for palliative care, for after-death care, and for appropriate bereavement support. And let me tell you, in COVID-19, you have to offer all these things. So after-death care and bereavement support can continue for a long time. Having a review of the care process within your hospital quality and safety committee is extremely important. The NABH standard, the fact sheet on the end-of-life care, is a good checklist to use for reviewing the care process. So having an end-of-life care policy, having a physical space where necessary privacy can be provided, having essential medications for pain and symptom control, trained healthcare providers in end-of-life care, access to religious clerics rituals and bereavement care support if required. Then documentation evidence to suggest that patient had knowledge of diagnosis and prognosis, consensus among the treatment team regarding medical futility, evidence of communication of the medical futility and available modalities of ULC, then goals of care, documentation of resuscitation status, allowing natural death and end-of-life care management plan being documented, then the end-of-life care symptoms being managed appropriately, and if the patient dies, then ensuring that after-death care and continuity of bereavement support is provided. We are at the end of this talk now. So it is important to follow the ISCCM IAPC illicit pathway that I have put forth in this lecture. In following this pathway, it is necessary to stick to the 5 E's of communication. First and foremost, establish rapport with patients and family, make them comfortable with the communication process. It is extremely important to explore the level of understanding first before you begin to give them knowledge. Whatever explanations you give, it should be in simple language that the patient understands. Once you have explained, you need to examine the comprehension of the situation by the family. And once this is done, you can end with a summary and a further plan. In case conflict occurs, then there are well-defined means. So open and repeated discussions, providing emotional support, getting a second medical opinion, asking an interdisciplinary hospital committee to review, offering them the choice of shifting to a place of their choice if required. And if things do not resolve by then very rarely a judicial remedy. So today we've discussed the end of life and communication skills in ICU. If there are any questions, I will be most willing to answer. Thank you.
Thank you, sir. That was an excellent overview of the end of life and key elements of communication in the ICU. We will wait for questions from the delegates if there are any.
Thank you, Shiv.
So till we have questions, like may I ask, when we give time limited trial,
Yes.
do we put endpoints for those 24? Suppose we put 24 hours, and then once you reach or don't reach those endpoints, how do you take the conversation from there?
So that's why it is important now, when during the family meeting, you're going to offer them a time limited trial. Tell them that if we find that the blood pressure does not respond, we don't get a reduction in the BP medicines, we don't get a reduction in the respiratory support, then so you set the parameters for them and explain it. The important thing now is whether they have understood that or not. Many times, patients may have understood it, but are unwilling to accept. And those are extremely difficult situations. And then, at times, we may have to resort to telling them, for example, that, look, he's receiving the renal replacement therapy, but because of the blood pressure now, he's not going to tolerate the renal replacement therapy. Because of the need for vasoactive support, we're not going to be able to prone him. So we're really out of options. So once they understand that they're out of options now, then usually they will accept that the time limited trial can now be ended.
Right.
But it is difficult.
Yes. And while so how do you address the caregivers issues, because they feel the sense of utility and when you are dealing with end of life.
Especially
nurses.
The wife, because the other people are all there, but finally, if the person passes away, the brunt has to be borne by her. And so, helping to handle that situation, getting the brother some support, then providing emotional support to the wife through a psychologist or a psychiatrist who is part of the hospital team, getting them a face-to-face meeting. Many times what happens is, she may also be positive, she may be admitted. The other members in the family also may have been affected. So this COVID-19 has really brought to fore all these things. And initially we were doing only the WhatsApp phone calls. Then we thought WhatsApp group video calls are working better. And then finally, we've now breached the barrier. During the second wave, we don't insist on only phone communication. Many times, we'll call them to the non-COVID side and have a proper face-to-face meeting, which is always better than just doing it on the phone.
Sir, I also mean about the nurses and all, because do you involve them in because they feel that
sorry. Yeah, I didn't get that. Sorry. So for the caregivers, what we do is we will generally try and involve the nurses in the discussion when we have about consensus among the healthcare team. But talking to the family, that is part of the training that we provide to them, because many times when relatives call up directly the ICU, or they call up the hospital board, and the ICU gets a call from one of the relatives. So being empathetic at that time, saying what the current condition is in simple language, offering them support, and then saying that I will convey your information to the doctor and they will call you back as soon as possible. So those things we do. And then to provide support for the caregivers, what we are doing currently is designed a mindfulness-based intervention that nurses will do at the beginning of the shift and at the end of the shift. And we are planning to study this in a, open-blinded study. We've submitted that to our ethics committee. And so to prevent stress and burnout in the caregivers, this is something which we're exploring at the moment.
Yes. I don't see any. There is a question: how do you resolve conflict?
Yes. So, I mean, this I've elaborated as we went along. So first of all, it is necessary to have open and repeated discussions with the family, and you need to really find out what the reason for conflict is. And if there is conflict within the family, you need to address that. So for example, the brother is rational, but he's providing the financial support. The wife wants to continue. So then how does one resolve this? Together, first speak to them separately. Then speak to them together. And the time-limited trial is way. So even though at the end of the time, resolution. If that does not work alone, then at that time, a second medical opinion is most important. And the second medical opinion, you can encourage the brother to take the wife along with him. Maybe go to another hospital where they're dealing with COVID patients or any other illness for that matter. And once they do that, then they realize the refractory organ failure and increasing SOFA scores and increasing supports, things are not going to really work. And then they come back and then they're ready. If the second medical opinion does not work, then we have within the hospital an interdisciplinary committee, which is not connected in any way to the ICU. So this hospital or this ethics committee, so those people can help you. If that does not work, manage this. So would you like to shift somewhere? Shall we ask another team to take over? Well, so these are the methods to deal with conflict.
Yes.
Dr. Pratik, is your question answered, or do you have anything specific you want to know about dealing with conflict?
Dr. Pratik, you can put it on the chat box.
Participants are allowed to ask direct questions?
No, sir, they'll have to put it on the chat box. No, they have to put it on the chat box, sir.
Yeah. Oh, they have to put it on the chat box. I don't think he's putting anything, so maybe he's satisfied with what we've told. So how can Spike's protocol be used in general? So that's what I've explained, So the Spike's protocol for cancer has to be adapted for use in the ICU where there is refractory shock principles using those SPIKES. So I don't know, Sheel, will the presentation be available or the recording be available to participants?
Yes, sir, it will be available for a few days.
So I would urge you to please go through those sections on how to use these protocols. Spikes in particular in intensive care with the help of the nurse mnemonic. Then how you can use the ask, tell me more principle. Knowing about, some people are described as monitors, especially those who have.
Sir, we are losing your audio in between.
He's asked a related question. Can you explain what all we can do in withdrawal and withholding option? So in withholding option, see, once the decision is made, it does not that it automatically happens. We can do a gradual reduction of the blood pressure drops, then we will not escalate these supports. While gradually withdrawing the respiratory support, you may, in that case, if you find that you've withdrawn those medications and the person is beginning, as we do with terminal breathlessness, you may have to give sedation in order to relieve that discomfort. So these are things that you may need to do. And all the time you have to reassure the family that while you are withdrawing organ support, withdrawing life-sustaining interventions, because they are not helping, at the same time, you will not be withdrawing comfort measures. Comfort measures will include measures for pain relief, measures to relieve distress. So all these things will continue on the side. So these are things that we should do in withdrawing process. And once things stop, you may even allow the family to be at the bedside. Now in COVID-19, it becomes difficult, but we have allowed families wearing PPE to come in and be with the family. And then of course, once the withdrawing happens, you have to, help with the after death care. What kind of processing do you want to do? Do you want to do COVID-19 processing or non-COVID-19 processing? How much time is it going to take? How can you help them with the bill? And then after death occurs, you can tell them that, look, I know that this has been a difficult period. If you feel that you need to still talk to us, we will be available. And for after bereavement care, you can contact the hospital, you can contact our team. We'll put you in touch with the appropriate psychologist or psychotherapist.
Right. Okay. Sir, I can't see any more questions.
Yes. No more questions, I think.
Okay. So thank you so much, sir. It has been an excellent, enlightening lecture about the end of life issues and how to approach them. We will move on. If there are any questions, we can get it through email. I will put it across through the email, sir. Thank you so much again to Dr. Shiva Iyer. So moving on, we will have the next talk by Dr. Suresh Ramasubban, and we've heard him in the morning. We are again pretty excited to hear him again. He is the senior consultant at the Apollo Clinicals in Calcutta, and he will be speaking on pulmonary embolism management in the intensive care unit. Over to you, Dr. Suresh.
Good afternoon, everybody. Welcome to the last, probably I think this is the last lecture of the 3-day conference, the BRITE. So I think you guys must be tired, and but just to finish another important acute emergency and acute issues in the ICU, I will like to run through this over the next 30 minutes, and that's acute pulmonary embolism. Obviously, we've been going through a case-based discussion, and I'll start the case, but I'll just give you a little brief introduction about the importance of the pulmonary embolism. It's the world's third leading cause of cardiovascular death, and its incidence continues to rise. It's a major cause of hospitalization, morbidity, mortality, with approximately 100,000 deaths per year in the United States. So it has got a significant burden, despite the fact that we always believe Asians don't have DVTE. It is not the right thing to say. We do see, even in with the COVID, we are seeing a large number of pulmonary embolism, and there is no doubt that it is a prevalent disease in this part of the world also. All right, so what do you mean by pulmonary embolism? Pulmonary embolism means any obstruction to the pulmonary artery or one of its branches. So the obstruction is generally assumed to be a thrombus, but it can be a tumor, it can be air or fat. Obviously, so it depends on the case scenario in which you're dealing with. So if you give a case scenario of a hysteroscopy patient who subsequently collapses, air embolism, if there is a pregnancy, amniotic fluid embolism, and so on and so forth. So, but for matter of discussion today, we obviously will focus ourselves only on the thrombus today, as this is the most common embolus for our discussion and management plan. Again, in the thrombus, you can have acute, subacute, or chronic thrombus in the pulmonary circulation. And again, for the sake of discussion, we will leave it to the acute thromboembolism, which can present with being asymptomatic in a lot of patients to having sudden death. So it can have a huge spectrum of illness. But the disease, by acute, we mean that from the time the thrombus is formed in the pulmonary circulation to the presentation is what we call it. It has to be a few days only before we can say it's an acute. Subacute goes to days to weeks, and chronic goes months to years. And chronic thromboembolic pulmonary hypertension manifests itself in the form of breathlessness, progressive on exertion, and the PA. It's a workup of pulmonary artery hypertension that leads to that diagnosis. Obviously, that's a separate entity by itself. So we're going to stick ourselves to the treatment of acute pulmonary embolism as the main focus of this thing. And the pathogenesis of acute pulmonary embolism is the virtuous triad, is the fact that you have a, one second, why is the screen got stuck here? It's moving. Let's move too fast now. 1 second, sorry about the glitch. All right, let me just pause. Just right. Sorry about that technical glitch. I had to stop for a second because the screen froze on me. Right. So the idea is that obviously the pathogenesis of acute pulmonary embolism is in the virtuous triad as it is for DVT. So that's why the combined entity is called as venous thromboembolism. And stasis plays the number one part in an ICU patient who's lying in bed and who's not mobile and who's got significant hypercoagulability because of sepsis, because of other medical problems. COVID is also one of the hypercoagulable diseases. And you have vessel wall injury from surgery and from trauma and things like that. So all this put together makes it a milieu for creation of pulmonary thromboembolism in the ICU. So there is obviously risk factors. It's not that everybody gets it, but in ICU, I'd say it's an acquired non-provoking risk factor that is provoking risk factor that is immobilization that you get in bed. Otherwise, you can have factor V Leiden and prothrombin gene mutation. But the most common non-provoking things which makes a patient present to the hospital is obviously obesity, heavy cigarette smoking. And the provoking histories are recent surgery, trauma, immobilization, initiation of hormone therapy, active cancer, etc., which makes a patient present with acute pulmonary embolism. When the acute pulmonary embolism arises, it has to arise from somewhere in the venous system. Most emboli are thought to arise from lower extremity proximal vein, that is iliac, femoral, and popliteal, and more than 50% of patients with the proximal DVT will have a concurrent PE. So you don't need to really work up that, okay, if you have a proximal DVT, should I really image for the PE? But you know that there is going to be PE and you treat it in a similar fashion. Fortunately, calf vein DVTs are different. Calf vein DVT rarely embolizes to the lungs, and 2/3 of calf vein thromboemboli resolve spontaneously after detection. So again, however, if you leave it untreated, 1/3 of calf vein DVT extend into the proximal veins where they have the greater potential to embolize. So when you don't treat the calf vein DVT, you need to monitor them carefully to make sure that they're not spreading and they're not spreading proximally. All right. So PE can also arise from non-lower extremity, that's the upper extremity veins, renal veins. Although again, embolization is less, but upper extremity, especially in cancer patient with lines, is very well reported and very well known. Right. So when we talk about the pathophysiology of the disease, how does pulmonary embolism affect the individual? Generally it's multiple small emboli that happens with the lower lobes being involved in the majority of the cases. And once the thrombus lodges in the lung, a series of pathophysiological changes happen. And these are the three changes that we need to be aware of, and the symptoms then kind of develop from there. So you can have an infarction, you can have abnormal gas exchange, and you can have hemodynamic instability. So depending on the presentation, some people can just have chest pain and hemoptysis, and some people can have frank shunting and require a lot of amount of oxygen, and some people can be hemodynamically unstable with blood pressure with lactates high and in shock state of affairs. So when you talk about abnormal gas exchange, we talk about altered VQ ratio, which is the most common mechanism of abnormal gas exchange because there is a mechanical and functional obstruction of the vascular bed. However, especially in amniotic fluids and in fat, you get a lot of endothelial injury and you need a lot of alveolar injury because of inflammation from surfactant dysfunction, and that leads to atelectasis and a significant amount of shunting. And this is where we get into trouble. Is normally when we say abnormal VQ ratio, you give them oxygen, their saturation picks up. But in a shunting, even with oxygen, the oxygen saturation doesn't pick up that well. And generally when we have shunting, we are looking at atelectasis, pulmonary edema, ARDS as the cause. But remember, this is much more common with the other thromboembolism rather than with the thrombus, with the thromboembolic thrombus in the circulation. So when you see shunting, always keep in mind that there might be something else happening. But yes, if in a large amount of pulmonary thromboembolism can result in surfactant dysfunction and atelectasis, but the main gas exchange abnormality is an altered VQ ratio, and therefore, and the way you distinguish clinically is by giving oxygen. If it improves its VQ ratio mismatch, if it doesn't improve, it's shunting with oxygen. The circulatory failure that happens is because of the right ventricular pressure overload. The right ventricle is capable of handling volume overload, but not capable of handling pressure. That's how the right ventricle has been built. So there is a mechanical obstruction where the RV outflow tract can be obstructed. There can be a pre-existing cardiopulmonary status where the right ventricle can fail because of the previous problems. There are other pulmonary vasoconstrictive factors that happen, like neural reflexes and then release of humoral factors from platelets, plasma, and tissue, and hypoxia itself, which will cause pulmonary arterial vasoconstriction, and this will result in significant pulmonary arterial hypertension, pulmonary vasoconstriction, and will lead to pulmonary arterial pressure being up, and that leads to a right ventricular pressure overload. So as a result of the anatomical obstruction and the neurohumoral effects, you have increase in PA pressure, and that leads to RV dysfunction. The increase in PA pressure leads to increased wall tension because the transmural pressure changes, and that leads to right ventricular ischemia, which can lead to RV dysfunction, and the RV dysfunction will lead to decreased RV output, and because the RV is in series with the left ventricle, you will have a decreased LV preload and decreased LV output. This leads to decreased coronary perfusion, decreased RV ischemia again, and this is a vicious cycle that can set in. But most commonly is the RV dysfunction followed by RV dilatation, followed by decreased RV distensibility due to the ventricular interaction, and you see the classical D sign when the RV is hugely distended to get a hemodynamic instability. All right, so now let's start with the case, and then we will talk about the various findings and the questions that arise when we're discussing a case of pulmonary embolism. All right, so this is a 76-year-old female without any significant past medical history who presents to the hospital with acute onset of shortness of breath for last 3 days. It has progressively worsened, and the patient was breathless at rest and therefore came to the emergency department. No history of fever, cough, myalgia. COVID has been screened and negative. No history of chest pain, palpitation, diaphoresis, and the workup for cardiac also has been negative so far. All right, again, next. So the initial respiratory rate is 22 per minute, heart rate 128, blood pressure 92/52, and room air oxygen saturation 88%. This improved to 18 breaths per minute, 120 breaths per minute of heart rate, 102/66, and 98% after 500 ml IV-NS, and 6 liter per minute oxygen by nasal cannula. So you now have brought some stability by just giving the emergency treatment. And physical examination was otherwise unremarkable, with no JVD, no S3, no DVD examination on examination, and just positive for obesity as the only risk factor that we can think of. All right, so the hemoglobin came back as 14, platelets normal, creatinine normal. The BNP was slightly elevated to 349, troponin slightly elevated at 0.64, lactate slightly elevated to 2.4. ECGs did not show any acute STT changes, chest X-ray was normal, and COVID screen was negative. All right, so the step one that we ask you is, what are you going to do with this patient, is the question that we ask in the WISE, how do you want to proceed? And the answer to that is lies in the fact that you need to make a diagnosis of PE, and the presentation of that's the first step. You have a patient who's hypoxic and has got some element of hypotension also. You need to establish a diagnosis. You can't manage this patient unless you get a diagnosis done. So step one, or the first thing that you need to do, is you've gotten the ABC taken care of. You gave the oxygen, you gave the little bit of fluids to get the pressure up and if required, and you got the patients, now you got to make the diagnosis. So this presentation is obviously heterogeneous. As I said, you can have infarct symptoms, you can have hypoxia, and you can have circulatory symptoms. So you can have any of these. Our patient here has got both pulmonary and circulatory symptoms. So again, so the only way you can make this diagnosis if your clinical suspicion is high, because the signs and symptoms are non-specific. It could be sepsis, it could be MI, it could be COVID, it could be anything, isn't it? So the key in making a diagnosis is to be having a suspicious. So how do you get suspicious? You just can't say, oh, I think it is PD. So the best way to be about suspicious is to have the fact that, obviously, as I showed you, the symptoms and signs of acute pulmonary embolism are very non-specific, and the frequency can vary. The signs are also non-specific. So circulatory collapse is like 8% of patients, but yeah, again, they really have to have a very high index of suspicion. So what you do is a modified Wells criteria for assessment of pulmonary embolism, where if you had clinical symptoms of DVT, which our patient didn't have, you look for other diagnoses less likely. So that means the patient didn't have heart failure, obvious, didn't have MI, didn't have pneumonia in the chest X-ray. So you are more suspicious that this is a So the modified Wells criteria is the way we see if the risk factors are there for this patient. And as I mentioned, in this patient, the factors that there's chances that this alternate diagnosis is less likely gives it 3 points, and that's important because in a quick examination we couldn't find any significant abnormality in the chest X-ray to suggest pulmonary edema, pneumonia, atelectasis, and we also didn't find any ECG changes and things like that suggesting of an ACS. So that leaves us with no other explanation for no easy explanation, and this should then come on top, and that automatically gives us the heart rate more than 100 gives it 1.5. So this makes it more than 4.5. And traditionally we would say high, moderate, low, but the simplified clinical probability assessment is the P is more likely if it's more than 4, P is unlikely if it's less than 4, and so on. The simplified clinical probability, so if you have a modified score, I think I lost the PowerPoint. So we're talking about the modified Wells score. Let me put it in PowerPoint again. So yeah, so the modified Wells criteria would make it in this patient like P more score of more than 4. So we go ahead and do a CT or an EQ scan. But if it was less than 4, what are we going to do? And that's the question. Do we still believe that there might be a PE? So you can use the PERC criteria. The PERC criteria for low risk patients, that means your pre-test probability based on Wells is low. And on top of it, if a patient has got all these 8 criteria met, then the chances is very, very low that the patient has a pulmonary embolism. So if your age is less than 50, pulse less than 100, saturation 95, no hemoptysis, no estrogen use, no prior VT, no unilateral leg swelling, no surgery or trauma. So this would make a low pre-test probability with a low PERC criteria would make it absolutely less assured that you have to search for an alternative diagnosis for this patient. And PE is not going to be the major thing. The other thing we can do, which we commonly do actually, is to use a D-dimer in a low-risk patient. We don't use the D-dimer in a high-risk patient because in a high-risk patient, we are going to be subjecting them to a VQ scan or a CT pulmonary angiography. So it's only the low-risk patient that we're going to say, okay, your Wells score is low, and I still want to make sure that there's no PE. So I get a D-dimer, and the D-dimer has a very good negative predictive value. So again, so instead of using a low Wells score plus a low PERC score, we can use a low Wells score plus a low D-dimer to go ahead and say what that the chances of him being worked up for pulmonary embolism is less, and you don't need to you don't need to bark up the wrong tree, and you can find an alternate diagnosis. However, if your Wells score is high, that means you're more than 4.5. So then you go ahead and say, okay, let me just say you already have a high test probability, so go ahead and do a CT angiography as the method of choice to identify pulmonary embolism, especially in an acute situation when the patient presents to the emergency, like in this scenario. You can definitely use perfusion scan in a renal failure situation. You can use leg ultrasonography and echo. But again, these are echo will be helpful only when you have a when you have right ventricular dysfunction or when you have circulatory issues. But if you don't have, if you have purely breathing issues, which is getting sorted out by 4 to 6 liters of oxygen, and you have no cardiac issue, the chances that the echo would be able to make a diagnosis is less. But if you have circulatory collapse, then echo becomes a very important thing of doing it. So all right, so in our patient, because this Wells score was more than 4.5, was 4.5, a CT angiography was done, which revealed extensive bilateral acute PE involving main pulmonary artery, lobar and segmental branches. And like DVT was done, again, you can debate as to say why should it be done. I think this is a matter of argument's sake and completion, that people just want to see the source of the PE, and eventually the source of the PE is in this prediction was the deep vein, the popliteal vein, and the distal femoral vein was involved. And more importantly, as I said, we do an echo to assess, even though the patient's blood pressure is stable, came in with hypotension, received fluid, and the blood pressure went up. So maybe and the lactate is still 2.4. So I think he bought himself an echocardiography to see if there is any abnormality, and that showed severe RV dilatation and dysfunction. So now that we have these constellation of findings, we know in echocardiography what we are looking for is basically not dilatation, which is going to be a manifestation of failure to meet the pressure overload. We're looking at right ventricular wall hypokinesis. We can see a McConnell sign. We can see, and you look at RV dilatation, which we can have many methods of doing it, but we commonly just do an eyeballing technique. We can looking at pulmonary artery hypertension pressure. We're actually measuring the pulmonary artery pressure. and then you look at the IVC and find that the IVC is dilated with lack of respiratory collapse. So again, the echocardiographic assessment of the right ventricle was a topic by itself. You must have heard it through the previous lectures. So I'm not going to stress too much on it, but the fact that you're looking for RV dilatation and pulmonary artery hypertension in addition to wall hypokinesis, so RV dysfunction and RV dilatation are the two things that we are looking at. So again, this is with a 4-chamber view that we want to look at the shape of the RV, and this is a normal RV, and then once you start getting dilated, you start getting bigger. This is moderate RV dilatation, and eventually you will find that RV and LV now have become almost the same size here, and so this tells you again there's a moderate RV dilatation happening, and then finally when the extreme RV dilatation where the the severe LV is just being pushed, and you know that now there's a left ventricular output is going to go down. So this is what we serially see. And when we do in a parallel short axis view, when you have severe dilatation, you can see the classical D sign of the left ventricle being compressed by the dilated right ventricle. So these are the echocardiographic thing which I put this slide in, though this is not just to give an idea as to the ability that most of us intensivists should have to look at the RV and look at the RV size to eyeball before we get somebody. We can do various assessment of the right ventricular systolic strain by using left ventricular eccentricity index. I'm not going to be talking in detail about this because this is something which we don't expect any one of us to be aware of and to do it. But what we do is we expect that we should have an idea of what TAPC, which is the tricuspid annular plane systolic excursion, which is normally about 2.4 to 2.7 centimeter, and value below 1.8 centimeter has been shown to have an 87% accuracy at predicting a low stroke volume. So it's important to recognize TAPC and the fact that as the stroke, as the TAPC numbers decrease, you have a chances that this patient is going to be has got a high chance of right ventricular dysfunction and the low cardiac output subsequent to it. So this is the tricuspid, the way you put the probe and look at the Doppler and then go ahead and do the TAPC. But again, as I said, we don't expect this thing as this is a little advanced skill that we really need to possess. So most of the time for us, it's looking at the picture and taking a look at the RV dilatation. Of course, with interest and with ability, all these things needs to be picked up. And then, all right. So the first step was make the diagnosis, which you did with the CT angiography in this case, and you supplanted that with the echocardiography and the venous Doppler, and they told us that not only this patient had significant has pulmonary embolism, acute pulmonary embolism, but also has RV dysfunction, which has been noted on the echocardiography. But though patient is hemodynamically stable, so what is the next step that you would want to do in this situation? So obviously the next step is to stratify the risk, because if so there's going to be 3 main categories. So in your image, when you said the patient hemodynamically unstable, is the patient as a high risk or massive category that we call as massive pulmonary embolism, or the patient has an intermediate risk or a submassive, or is a low risk pulmonary embolism. And once we stratify risk, then the treatment can be planned accordingly. So high risk or massive pulmonary embolism is defined as persistent hypotension, that is blood pressure less than 90, or a decrease in SBP of more than 40 millimeter from baseline for greater than 15 minutes, or the presence of end organ hypoperfusion like altered mental status, cold clammy skin, oliguria, anuria, lactic acidosis, and even cardiac arrest. So these are all high risk. That means the patient is going to be dying out of this pulmonary embolism, and these only account for 5 to 10% of acute PE. But unfortunately, once you get these patients, they have a 50% chance of dying on you. So they have a high mortality, though the incidence of this is very less. That means circulatory collapse with acute PE is not the main presentation. As we said, 8% or 5 to 10% of acute PEs will present with circulatory manifestation. Right. So in the absence of hypotension and shock, obviously you need to do further assessment to say whether he's going to be at a higher risk of early death, and that's the intermediate group. So if you don't have pure shock, you're going to say, okay, is the still guy going to be having a problem? So this again this cannot be done just by using the echo. This has to involve clinical imaging, laboratory indicators, and there are certain scores like the PESI score, which also can be able to tell you whether there's any problem. This is the pulmonary embolism severity score. It used to be cumbersome with original PESI, which required plus 10, 10, 10, 20 points. but now they have modified it and just made it into 1 score. So anything more than 2 is going to be in the simplified set. PESI score is going to be significantly high risk for a 30-day mortality, and this works very well. So in the original one, if it is less than 65, 30-day mortality is only 0.6%. But if your score is more than 125, your 30-day mortality is almost 25%. So this PESI score is very important. So using this, and this involves what is the age of the patient, a history of the existing heart failure, chronic lung disease, what is his pulse, blood pressure, respiratory rate, mental status, and oxygen saturation. So all these things put together, you get a PESI score. But what we generally do is risk assessment is using echo, using elevated troponins and elevated BNP and NT-proBNP. So in this patient, as we saw, there was RV dysfunction and RV dilatation. Troponins were elevated, BNP were elevated. So this puts the patient at an intermediate, because the patient had an intermediate risk of death. And in the intermediate risk, if you had all of these, both echocardiographic and biochemical, you become what is called as a high risk intermediate group. That means you have both RV dysfunction and biomarker elevation, and you have high risk of decompensation. You might be in the 25% who's going to die. So you really need to take action. While an intermediate low risk is whether either one RV dysfunction or biomarker elevation, and your risk is slightly less for death as far as compared to a high risk intermediate group of patient. And so in this case, as I said, because the patient had all the features of RV dysfunction, RV dilatation, troponin elevation, and BNP elevation, it was diagnosed to have high risk, intermediate high risk. In the intermediate category, she was high risk. And also the extensive clot burden was causing severe reason for the RV dysfunction is obviously the clot burden. And the SPECI score was 2 based on heart rate and oxygen saturation. So very a high risk patient for us. So what is the next step in this category of patients? As I said, once you have a low risk, and so you need to have a PERT team or specializes. What in the Western world they're doing is that means have like a stroke alert team. You can have a PERT team who can assess this kind of patient and make difficult decisions, talk with the family, give a multidisciplinary approach with interventional radiography, pulmonary critical care medicine, cardiac surgery, vascular surgery. Everybody comes together and makes a decision rather than one single team. So the PERT, pulmonary embolism response teams are the things in vogue in the Western world. We unfortunately still are not evolved in that very setup of creating a teamwork, but we do that. So anyway, so the specific management measures again depends on whether you're low risk, medium risk, intermediate risk, or high risk. So, but therapeutic anticoagulation across all groups has to be done. So it remains the treatment of choice for acute PE. And patients achieving therapeutic anticoagulation within 24 hours have a reduced 30-day mortality. So when you start heparin in most of the hospitals, you will find you rarely achieve a good APTT in 24 hours. So we tend to therefore have shifted out from unfractionated heparin to low molecular weight heparin, because in low molecular weight heparin, you are at least assured that with 2 good doses of appropriate therapy, in 24 hours, you will achieve therapeutic level, and that therapeutic level will decrease your mortality much more than any other intervention that you're going to do. So LMWH becomes the initial anticoagulant of choice. So why do we use, when do we prefer to use unfractionated heparin is the question that will always be asked. And where do we really need it in our armamentarium? And the answer is yes. If you have overt hemodynamic instability, that means your blood pressure is low and your lactates are high, and you have imminent need for reperfusion, that you're going to be thrombolizing them or you're going to be taking to the cath lab, then it's probably easier to do anticoagulation with unfractionated, because you can titrate it up and down and according to the needs of the patient. In low risk, you also have a choice of not using low molecular weight heparin. You can even directly start direct acting oral anticoagulants as the first line treatment in low risk PE nowadays. So you can probably don't need to other than you probably can manage them as outpatient. If you need to hospitalize the low risk patient also, you can get away with a DOAC and as a treatment of choice. It's the intermediate PE where systemic anticoagulation is obviously still recommended over systemic thrombolysis or catheter-directed thrombolysis by all guidelines. But as I said, once we divide them into high-risk intermediate and low-risk intermediate, then we might have a little difference. So when you have high-risk intermediate group, that means both RV dysfunction and biomarker elevation, we need to consider additional interventions such as systemic thrombolysis, catheter-directed lysis, or catheter embolectomy. These are the 3 things that we can offer them when we do this. And obviously the consideration are, what do you have in your hospital? Can you transfer them to another facility? What is the available resources and what are the risks of bleeding? So what is the role of systemic thrombolysis in intermediate risk PE? So obviously it's absolutely the expected treatment of choice in high risk PE. or massive pulmonary embolism, but in intermediate or submassive pulmonary embolism, we really don't know what to do. So in this case situation, pulmonary embolism thrombolysis trial was done. It's a large double-blind placebo-controlled trial. The trial did show a decrease in hemodynamic deterioration without a difference in mortality. So again, there's ability for you to decrease the hemodynamic support, but there is no mortality benefit, and there is an increased bleeding risk and intracranial hemorrhage also in the thrombolysis group. So we need to be careful about treating submassive pulmonary embolism with thrombolysis, and especially this bleeding is higher in people above 65 and much higher in above 75. So, and there's no long-term difference in the creation of CTPH or mortality. So probably staying away from systemic thrombolysis in submassive pulmonary embolism is the rule as of now. So what is the alternative do we have? So one is we can do half dose systemic thrombolysis, because that's the only thing where most of us will have resources or facility to. Otherwise, you have to do catheter directed thrombolysis or catheter embolectomy as the two main treatment choice for intermediate high risk submassive pulmonary embolism or high risk intermediate pulmonary embolism. All right, so what is catheter-directed lysis or catheter-directed thrombolysis? So in this, you position the catheters directly into the clot in one or both pulmonary arteries and infuse low dose of thrombolytics. But this has to be done with a special ECOS catheter, which is going to be an ultrasonic catheter, which is going to be, which has got multiple poles and is going to be infusing the drug over 8 to 12 hours. So there's evidence for this is the Ultima trial. It's a prospective randomized controlled trial, unfractionated heparin alone or ultrasound-assisted CDL plus UFH. Again, it improves the RV to LV diameter ratio, and there's a low risk of bleeding. Seattle 2 study is also there, which shows a single arm prospective trial, an early reduction in PA pressure and obstruction index, and there's a 10% bleeding rate and no ICH. So catheter directed lysis may be the way to go in a high risk submassive pulmonary embolism. Again, the advantages is that you get only 4 to 12 milligram of TPA with infusion duration of 4 to 12 hours, and there's a lower risk of bleeding, and there's a very, very minimal risk of ICH when you do this through a catheter-directed lysis. Disadvantage is obviously you're going to infuse it over 6 to 24 hours. So if somebody deteriorates, you probably don't want to do a CDL, and your restoration of hemodynamics may be a little time consuming, and that may be a problem in patients who are hemodynamically unstable. The other issue is catheter embolectomy, which can be done. Catheter embolectomy is done in isolation or along with the catheter-directed lysis. So use this again requires a specialized catheter called float reaver in a 22 French cannula to suck out with manual suction. Or you have the penumbral indigo, which consists of an 8 French catheter that aspirates thrombus via a suction pump. Again, these are useful when you have a patient with high bleeding risk or contraindication to systemic anticoagulant. So if in our patient we couldn't anticoagulate them also and cannot obviously antithrombolyze them, then this becomes in a submassive pulmonary embolism, catheter embolectomy becomes an important armamentarium in our disease thing. For high risk, it's very straightforward. Systemic thrombolysis using TPA 100 milligram over 2 hours remains the mainstay of therapy, and patients with relative contraindications can be considered for CDL, and patients with absolute contraindication to systemic thrombolysis should be considered either for a catheter-directed embolectomy or a surgical embolectomy. And surgical embolectomy is obviously the treatment of choice when there is an absolute contraindication to systemic thrombolysis or for whom thrombolysis has failed. And that is the instance when you do it. Obviously, we do have the option of getting into VA ECMO for immediate stabilization of high-risk PE, for treatment of refractory cardiogenic shock, cardiac arrest, and bridge to reperfusion therapy. You buy time when you start before you start the review. The other important aspect which intensive care unit physicians are called into play is the hemodynamic management of high-risk patients. And that means in this situation, we have two choices. How much do you do fluids? Fluids, we don't do too much. Fluids, we don't do too much because aggressive volume loading can worsen the RV function by causing mechanical overstretch and inducing reflex mechanism that will depress the contractility. However, you can do a modest fluid challenge. That there have been small clinical studies that show after infusion of 500 ml of dextran, the cardiac index improves. But since we don't use dextran anymore, a modest fluid challenge also has to be taken with very, very carefully when doing this without an unmonitored situation. So IV fluids has a number of detrimental effects, and as we said again, this RV decompensation, volume loading them is going to cause more problem with decreased RV output, and this vicious cycle which I showed you earlier is going to get worse if you volume load them. But again, a small volumes of 500 to 500 ml is acceptable when patients do come with hemodynamic instability. As far as vasopressor is concerned, noradrenaline is the preferred agent for hemodynamic support in pulmonary embolism. This has been well studied and is probably the best. It achieves better wall function because of increased systemic pressure, which results in improved coronary perfusion and improved right ventricular function. So NORAD is the drug of choice in pulmonary embolism. Again, it's obviously the use of vasopressors is in parallel while you're doing the thrombolysis, while you're doing the catheter-directed thrombolysis. Again, as I said, norepinephrine has a direct benefit on the RV, has an RV inotropic effect, while so it might be biased more time. As far as inotropes are concerned, dobutamine has been studied, and again, not very good outcomes with that. Again, with dobutamine, there has been an increase in cardiac index, but again, only with the low cardiac, one can document that the cardiac index is low and the blood pressure is normal, but the lactates are high or shock features are there. You want to use dobutamine in addition to noradrenaline while we are doing the important therapy of lysis in some way or the other. So is it the combined vasopressor and inotrope is only in that subset of patient when we do these things. All right, so in our patient, we got a low molecular weight heparin, was admitted to the ICU for monitoring for 3 hours after patient admission. Persistent dyspnea was noted with minimal movement, heart rate remained high, saturated blood pressure remained between 98 to 108. In view of the appearance, SPECI score, heart rate, oxygen requirement, biomarkers, echo parameters, clot burden, we knew there was a high mortality, so there's going to be a chance that we need to give some definitive therapy. So obviously not a candidate for systemic thrombolysis. As I said, submassive embolism is now, and so surgical embolectomy and systemic thrombolysis is ruled out. So then CDL was considered, but again, we don't have ECOS catheter, only local installation was done, which is a modification, but I don't know how much it works. And low molecular weight was continued. Fortunately, improvement occurred after another 4 hours and weaned off oxygen in 24 hours. And then subsequently transition to a DOAC and discharge to home. So it is a wonderful story of an example of where close monitoring in the intensive care unit and making decisions helps us in doing this thing. Right. So let me just finish by saying that in acute pulmonary embolism, we really need to stepwise identify, be suspicious of pulmonary embolism, and so I make the diagnosis with high risk with CT angiography, and low risk with using a combination of score and D dimer. And then once you stratify them, then based on the strategy, what the stratification they are, we will manage them according to whether they're high risk, low risk, or intermediate risk. That is massive pulmonary embolism, submassive pulmonary embolism, and low risk for pulmonary embolism death. So once we do that, it's easier to manage. And so thank you very much for your kind attention. I know it's the end of the day. Most of you would be tired and would be happy that I finish fast and quickly. Thank you very much.
Thank you, Dr. Suresh. No, it is not the end of the day. We still have two,
I just saw the
more
schedule.
talks pending. So yeah, we will see if we've got any questions. Yeah, we have one question. How do we differentiate patient with hemodynamically unstable pulmonary embolism from patient with severe ARDS and sepsis?
Acute cor pulmonale, you can't do anything. You have to show the clot. So TE would be a best option if you can demonstrate the clot in the pulmonary artery. So if you have an acute cor pulmonale because of mechanical ventilation or RV or ARDS, as rightly pointed out, and it's impossible to distinguish unless you demonstrate the clot somewhere. So you can demonstrate the clot in the veins, you can demonstrate the clot in the main pulmonary artery by echo or transesophageal echo. Otherwise, in the West, in this kind of a situation, you would get a multidisciplinary team meeting and think about it and say in an urgent setting in the critical care, the team, the PERC team that as I mentioned would come in and say, okay, there is a possibility, so let's shoot some dye and see. So again, it's impossible if you don't put together, and there's no one test or anything that we can do to distinguish. So even in this COVID epidemic, we've had patients with RV dysfunction whose D dimers are going up, delta D dimers are high, and we don't know what the RV dysfunction is because of bad ventilation or is it because of a new PE. Sometimes we have this thing of looking at an echocardiography, looking at the TE, and looking at the MPA, especially, and seeing what is happening. But eventually, the answer to your question is no. There's no way to distinguish. It's a clinical distinction.
And there's another question by Dr. Arnab. He says unfractionated heparin in thromboembolism in the setting of CKD or AKI when the GFR is less than 30, and can low molecular weight be still used in such patients with dose modification?
Yeah. So when we have an acute pulmonary embolism and you have a patient with a creatinine clearance which is low, it is probably better. And as I said, the key in decreasing mortality is to achieve therapeutic anticoagulation levels in the first 24 hours. So which is the best way to do it? The best way to do it in a patient with CKD is to make sure that you give heparin, which need not be adjusted for renal failure. So I don't think there's any doubt in an acute pulmonary embolism, especially if you have circulatory dysfunction, that the choice is IV heparin. If you have mild PE, low risk PE, and you don't want them, if you have intermediate risk or high risk, you would probably want them to be anticoagulated quickly with heparin. There's no doubt about it. And then you can do an adjusted low molecular weight heparin or a DOAC and then take it from there.
There's another question which says, how do you thrombolize patient with COVID-related thromboembolism?
So I said, if you have COVID and you have no other reason for an acute cor pulmonale, then the thrombolysis would remain the same thing. So if the patient can be taken down for a CT angiography, you need to demonstrate the clot before you give it. If you have, as I said, the mechanism, if you have circulatory failure and you want to thrombolize them, which is what is a hemodynamically unstable or a massive pulmonary embolism, you have to demonstrate the clot before you can say, yes, I'm going to go ahead and give the thrombolysis. So the main message would be go ahead and image it. If the patient cannot be taken down for an image, then it is a joint decision. It's a clinical decision making with a combined multidisciplinary team that needs to be done. And thrombolysis would be the same as you would do a thrombolysis in any other patient, 100 milligram of TPA over 2 hours.
Okay, I think there are no more questions. How long would you give anticoagulation for unprovoked PV?
Unprovoked DVT would be about 3 months minimum. 3 months should be good enough. For a unprovoked would be 6 months minimum. And the guidelines for this do change depending on what is the whether male or female. And so some in men, 6 months is good enough for an unprovoked DVT. For females, 1 year, and in screening them for occult malignancy. So that becomes more of an issue as an outpatient and to decide how to stop it. But that's for unprovoked first episode of unprovoked PE in a man, 6 months is good enough. For a female, 1 year, and an unprovoked second episode in a female would probably get you a lifelong therapy. Obviously, you need to be investigated in between as to the cause of thrombophilia, why you're having an unprovoked. Especially in ladies, vasculitis, Aplas syndrome needs to be worked up. We also need to work up for genetic mutation factor V Leiden and protein C deficiencies. In elderly male, we definitely need to work up for occult malignancies when somebody has unprovoked DVTs.
So when is the time window when you do that workup? Because most of them will be on anticoagulation for at least 3 months.
So the first unprovoked and the basic screening is not showing anything. You have to do it after when you finish that first episode, 6 months. So when you get that window after that, and once you stop the treatment, 7 days without heparin, you can go ahead and do a thrombophilia check.
Okay. We have another question that is role of inhaled pulmonary vasodilators.
For acute cor pulmonale, that would be a treatment of choice. Nitric oxide would be the best way to go about it. That will at least decrease the pulmonary vascular resistance. Hasn't changed outcomes so far in COVID or non-COVID.
Okay, and there's another question. How do you do catheter-directed embolectomy?
So it's done by the interventional radiologist. As I said, we don't have the ECOS catheter. So what our interventional radiologist does is a thrombectomy device. They have a thrombectomy device, a thrombectomy suction device, the Penumbra device, which cost about $1.5 lakh to use. And basically they use a syringe to suction it out. And when they come out, they instill 6 milligram in each of the pulmonary arteries and come out. And this is, as I said, is a modification by Indian interventional radiologists to do this. I don't think there is the ideal one, the way in which I showed you, was using an ECOS catheter or a similar kind of catheter. ECOS is a brand name, so not to use that in a specific, but in a catheter which has multiple holes, which can infuse very slowly over 8 to 24 hours into both the pulmonary arteries. About 6 to 12 milligrams is the way to go. Is the method of choice for a catheter, and that is the one that's been studied in these two trials that I showed you.
And final, your take on filters and whether retrievable, non-retrievable.
Correct. Filters doesn't prevent DVT. Filters can prevent a massive pulmonary embolism, can prevent significant pulmonary embolism. So if you have a contraindication or a failure of thrombolysis, failure of anticoagulation, then only it is a question of where we go to. So the management of acute PE, we really have this discussion should not even come in, because acute PE you're going to anticoagulate. If somebody cannot be anticoagulated and they're low risk and they don't have pulmonary reserves, then yes. So say if you have a patient who is a contraindication to thrombolysis, contraindication to anticoagulation for whatever bleeding problems, and has got a low risk PE right now, but you are afraid that he doesn't have too much reserve and you might want to do it, that is more of a prophylaxis, and that's not managed treatment of an acute PE. So in that situation, yes, you can do it, but in a treatment of otherwise, it's the only two indication would be failure of anticoagulation or a contraindication to anticoagulation, where you would think of IVC in an acute setting.
Yeah, so that message has to be clear. Can streptokinase be used in poor resource settings?
Yeah, I think so. Streptokinase, everything can be used, but again, this problem with streptokinase is then the systemic anticoagulation has to be taken care of, and we really don't know the dose. But people have tried it, and it used to be the treatment of choice. So it is not that it's not been tried. The risk of bleeding increases, and the risk of ICH increases with a non-specific thrombolytic agent. And that's why even in the cardiology setup, the cheapest centers, government centers, also have now moved from streptokinase to the Indian brands of thrombolysis, TPA, because of the availability, and the cost has come down. So I don't think we really need to, because in the cardiology setting, they have completely moved away from streptokinase because of the Indian variants available. So in majority of our patients can afford that much. It's still probably as expensive as a 7-day course of meropenem.
Should vasopressin be the vasopressor of choice, considering its favorable effect on pulmonary vascular resistance?
No, again, not because vasopressin, as an intended use, when you titrate it, has got significant peripheral effects, significant splanchnic circulation effects. So it might be neutral on the pulmonary vasculature, but it's got significant effects. So you cannot titrate vasopressin without losing a limb in the process, or you have to be careful about doing it. Yes, if you're on a very low dose of vasopressin, as I said, you really, because when we use it in septic shock, we use it as a fixed dose, as a kind of a more as a hormone replacement rather than as a titratable medicine. So if you have a person who's hemodynamically unstable, you want to use a drug which is titratable, and vasopressin is not considered a titratable drug because of its side effects. So that's why we don't.
Okay, I think if that's about it. So thank you, Dr. Suresh. I mean, it has always been an exciting discussion as always, and I'm sure uh, uh, the students would have greatly been benefited with this. Thank you so much. So moving on for the next talk, I would like to invite Professor Sheila Maitra. She is the professor critical care medicine at Tata Memorial Center. She is also the president-elect for Indian Society of Critical Care Medicine, and she is also the president of AIDA, and has been the vice chancellor for ISCCM in the last year. So she will be speaking on ventilator-associated pneumonia, and I invite Professor Sheila Maitra to speak.
Thank you so much, Sheel, for that very kind introduction. First of all, I want to apologize. This talk on ventilator-associated pneumonia was to be held yesterday, so sincere apologies for changing the sequence because of some technical problem. I was unable to take this talk. And at the outset, I'd like to thank our department, Dr. Divatya, Dr. Atul Kulkarni, whose brainchild this program is, and my colleagues, Dr. Sheel and Dr. Amol, who have been working tirelessly over the last few days to make this, get this program across to you. So I'm going to be speaking on ventilator-associated pneumonia. And it's interesting that this talk is here now today, because we've just had some changes with the CDC recommendations for ventilator associated infections. To be honest with you, the various definitions have made it all very confusing for the clinicians, and a lot of this is not really based on the infection itself, but practical logistic changes, related to billing the patient, diagnosis of a pneumonia, especially in North America. They don't want to say that there are more pneumonias because there are billing issues, insurance issues. But I'm going to give you more practical tips as to how we can diagnose patients with pneumonia, how we should manage them, and how we should treat the more resistant pneumonias. So before we go on to this, what I was mentioning is that the CDC in January 2021 has just come up with a new definition for ventilator-associated events, what they call VEAE. And they say that we should look for, rather than call it VAP, they call it VAE. So we look for ventilator-associated events. Now, what do you mean by this? This is a combination of objective criteria, and this should include deterioration in the respiratory status after a period of instability. So there's a period of instability of a patient on a ventilator, and then there's a period of deterioration. Then there's evidence of infection or inflammation and lab evidence of respiratory infection. So this is what the current definition by the CDC from the National Healthcare Safety Network, that is the NHSN, which has just been given in Jan 2021. Before that, what is a HAP and a VAP? So when you have a HAP, when you have a new pneumonia, that's a lower respiratory tract infection, verified by the presence of a new pulmonary infiltrate on imaging, and this develops 48 hours after hospitalization. Now, this is in a non-intubated patient. That's what we call a HAP. And VAP is the most common and fatal nosocomial infection that you're all aware about in the intensive care unit. And this is nothing but a new pneumonia that develops after 48 hours in a patient who is intubated. So importantly, by the time VAP onset, sometimes a patient may already have been extubated as well. So keep this in mind. So you should know what a HAP is, and what a hospital-acquired pneumonia is, and what a VAP is. HAP is in a non-intubated patient. And we also had HCAP, that is healthcare, healthcare-acquired pneumonia. But this, after 2016, has become very unpopular, and they've taken it out of the definition. So essentially, you have HAP in non-intubated patients, and you have VAP in intubated patients. Now, this is something you should focus on. I'll touch on this a bit. You should know about this because this is the current kind of algorithmic approach that the CDC has given in Jan 2021 for your ventilator-associated events. So I know it's a little small print, and I've divided the table over 2 slides, but just the algorithmic approach about how you should go about the surveillance. So if you have a patient on ventilator, and this should be more than 2 calendar days, so he should be stable on the ventilator more than 2 calendar days, and there is an increment in the FiO2 or the PEEP from the baseline in the preceding 2 calendar days, then you go on to the next step. And this, as I mentioned, when you're talking about FiO2, it should be more than 0.2 or 20 points, and an increase in PEEP of more than 3 centimeters of water. And then you will call it a ventilator-associated condition, that is VAP. And then on or after 3 days of mechanical ventilation, within 2 calendar days before the onset of this worsening oxygenation, if the patient should meet both the following criteria, that is either temperature, so you should have fever or elevated white cell count or a count less than 4,000, and a new antimicrobial agent that is started, and they have an appendix for a whole lot of agents. And if this is the case, then it is what we call an IVAC, or an infection-related ventilator-associated complications. And then moving on to how you would proceed further is if it's actually an infection related to the ventilator-associated condition. So just to go back, you first look at whether it's a ventilator-associated condition, that's VAC, and then IVAC if there's fever and a new antibiotic has been started, And then if it is infection related to the ventilator associated complication, you proceed forward to move on to diagnose whether it's a possible ventilator associated pneumonia or a VAP. And for this, you need one of the following criteria that is below. And this is a little detailed, but just to tell you, the criteria one is that it's a positive culture with one of the following specimens meeting the quantitative or the semi-quantitative threshold as I'd outlined. So the threshold that they give is for endotracheal aspirate, it's more than 10 to the power of 3. This is colony forming units per ml. For a BAL, it's 10 to the power of 4. Lung tissue, 10 to the power of 4. And protective specimen brush, it is 10 to the power of 3, or of course with this corresponding semi-quantitative results. Then the second criteria is if you have purulent respiratory secretions, okay? And plus an organism identified from one of the following specimens. And it could be any one of this: sputum, endotracheal aspirate, broncho, BAL, or lung tissue, or even a protective specimen brush. And the third criteria is one of the following positive tests. So an organism identified from the pleural fluid or lung histopathology, or diagnostic test for Legionella species, or diagnostic test for respiratory secretions. And if you have one of these criteria, 1, 2, or 3, then it is a possible ventilator-associated pneumonia. So essentially, it's become a little complicated. The reason I want to tell you is this is the latest definition that has come from CDC after their 2011 definition of VAP. And this is, just to go back, a stepwise surveillance algorithm that you should follow. But just to simplify this, if you talk about ventilator-associated events, I'll just summarize it by telling you that when you say a VAC, it is a ventilator-associated, you have worsening oxygenation and increase in PEEP and increase in FiO2 by 20%. And if this is also has fever and an antibiotic has been started for this patient, it is an IVAC. And if there's an IVAC plus a positive microbiology result, then it becomes a VAP. Just in summary, to understand what IVAC, and VAP is, because it's all very complicated, I understand. And it's to be assessed for any ventilator-associated event, the patient should be ventilated for a minimum of 4 calendar days. So in short, at least there should be 2 days of stability, and in the 2 preceding days, these events should have occurred. Now, remember, a ventilator-associated event is defined for a period of 14 days. So if a patient can have only one VAP, ventilator-associated event per fortnight. So it's always in a fortnight criteria that is given. So 1 VAE in 1 fortnight. So in simple terms, the definition of a ventilator-associated pneumonia is an infection of the pulmonary parenchyma in a patient who's exposed to invasive mechanical ventilation for at least 48 hours. And of course, it's part of the ICU-acquired pneumonia. And we all know why is it important, because it imposes significant economic burden on us, and it's associated with a prolonged duration of mechanical ventilation, ICU stay, and even increased mortality. So the incidence is high. It can be anywhere between 5 to 40% of the patients receiving invasive mechanical ventilation for more than 2 days, again, depending upon which part of the world that you live in. And the daily risk of VAC peaks between 5 to 9 days of the mechanical ventilation. And then the incidence depends, as I mentioned, upon the country, the type of surveillance methods, where you live, and what is your infection pattern. So obviously in North America, it is much lower, 1 to 2.5 cases. And this is very dynamic. It evolves over time. And low middle income countries could be as high as 18.5. So how is this calculated? It is a number, the VAP, the incidence, divided by the number of ventilator days. Now, this is very important that you have a denominator, and then it is always in terms, a VAP is always described in terms of per 1,000 ventilator days. So it's very important that if you want to calculate the incidence of VAP in your unit, you should know the number of days the patient was ventilated, not only for that patient, but all the patients in your unit. So unless you have your denominator correctly recorded on a daily basis, you can't really give an accurate assessment of the ventilator-associated pneumonia in your unit. So what are the risk factors? Male, gender. Age does not appear to be particularly associated with the risk of VAP. Underlying medical conditions, including various comorbidities that patient may have. And there has been noted a higher incidence in patients with malignancies, trauma, and COPD patients. What about the microorganisms responsible for ventilator-associated infections? So these the organisms associated with VAP, they depend on what is the length of stay and the ICU stay before the VAP developed, how long were you ventilated, the timing and the cumulative exposure of the antimicrobial, also very much on the local ecology, and any epidemic factors could also be responsible for the kind of microorganism. The usual microorganisms that are involved in ventilator-associated pneumonia, they're the gram-negatives, Pseudomonas, E. coli, Klebsiella, Acinetobacter, and gram-positives could be Staph aureus. As we know, we have more of gram-negative pneumonias as compared to the Western countries. Now, early onset VAP. Now, when you talk about early onset VAP, now this is within 4 days of hospitalization, and this is in a previously healthy patient who's not receiving antibiotic, and this usually involves the normal oropharyngeal flora. Whereas late onset VAP, this is one that occurs 5 days after hospitalization. And this is one with in patients with risk factors. And this is usually associated more with multi-drug resistant kind of pathogens. And the MDR pathogens may be associated in early onset VAP in the presence of certain risk factors. So even in early onset, you may get MDR bugs. And the risk factors for this are if they have antimicrobial exposure in the last 90 days, or there's been prior colonization of infection with MDR pathogens, or there has been an ARDS preceding the VAP, or they've received renal replacement therapy, or the presence of a septic shock at the time of VAC. So these are the situations where you could think that there could be MDR bugs in an early onset VAP. Just some things to keep in mind. What about fungi? Now, colonization of the lower respiratory tract by Candida species, this affects 27% of mechanically ventilated patients, and it could be associated with an increased risk for bacterial VAP. So a lot of time you get Candida species when you have your tracheal aspirates, but this is not Candida pneumonia. And available data does not support a direct role of Candida species as a causative organism, direct organism of VAP. Aspergillus species may be involved in some very late onset VAPs, and this is particularly in patients with a recent history of influenza. But by and large, this is not seen. Regarding viruses, the respiratory viruses include influenza, respiratory and syncytial virus, and others. And the herpes simplex virus and cytomegalovirus can be cause viral reactivation pneumonia. And this is seen more in the immunocompromised and also sometimes in non-immunocompromised patient. And now, of course, we have COVID, but I'll talk about COVID a little later. So coming to the diagnosis of VAP. So how do we go about diagnosing VAP? Of course, first it's on a clinical suspicion. You see a new or progressive persistent radiographic infiltrate. And this has to be substantiated with a positive microbiological culture from a lower respiratory tract specimen. We also used to follow the CPIS scoring in the past, and this is, 3 different rates of scoring. It's important to know it from an exam point of view, where we look at tracheal secretions, infiltrate, and also the P2F ratio, and there's a scoring 0, 1, 2, and 3. However, this has been seen to have very low specificity, particularly compared to obtaining the lower tract, respiratory tract specimens for culture, which is not often done in most cases today. So there are some limitations with using this CPI scoring system. So just coming to a clinical case, you have a 50-year-old male. He has no comorbidities, and he's had a road traffic accident, traumatic brain injury, for which he was operated. And his GCS post-surgery is 8. He's been now 3 days on a mechanical ventilator. And on the 3rd day, he develops fever. He's got temperature of 101. He's hemodynamically stable, but the white cell count is 17,000. The X-ray is normal, but there's worsening of P to F ratio, and now this becomes 250. So could he have developed ventilator-associated pneumonia? So if you look at clinical signs of infection, you need 2 of the following criteria. And if you look at he's got new onset of fever, purulent endotracheal secretions, leukocytosis or leukopenia is there, increase in mechanical ventilation, decline in oxygen, and if there's a need for a new vasopressure. So these are the clinical signs of infection that you should look at, and he should have 2 of the following criteria. He has fever, he has leukocytosis, he has a decline in the oxygenation. And then coming to the imaging criteria, this is again very important to clinch the diagnosis and also to increase your suspicion of a ventilator-associated pneumonia, not only the X-ray findings, but the CT findings, and you could also look at the ultrasound findings. Now, if you're looking at lung ultrasound, you could also look at air bronchograms, which could be suggestive of a pneumonia. But remember that there are many conditions that mimic a VAP when you're doing imaging. Could be pulmonary edema, there could be pulmonary contusions, pulmonary hemorrhage. Sometimes it could just be mucus plugging or atelectasis or even thromboembolic diseases. So you should keep this in mind because these are conditions that can mimic VAP on imaging. So coming to chest, just to tell you about chest imaging and how reliable these are. Now, this is the chest images, the X-ray chest of a patient in the intensive care unit who had clinical suspicion of a VAP, and it looks, reasonably all right. But the same patient on the same day, the CT scan that is done for this patient, and you can see in the lower inferior lobe, you can see this infiltrate that is not picked up on the X-ray chest. And the X-ray that is done on the next day did show progression in the infiltrate. And that is why X-ray chest may not be, especially when there's a very high clinical suspicion and you find a normal X-ray chest, it's very important to go ahead doing a CT scan. And this is even more important in an immunocompromised patient because X-ray really does not have much value in these patients and you might have a normal X-ray chest. So it's very important to do CT scans in these patients. I'm not saying that you should do CT scans in all, but definitely in immunocompromised patients in whom you're suspecting a ventilator-associated pneumonia. So new or progressive and persistent infiltrate. So X-rays are neither sensitive or specific, as I mentioned. CT scan is more sensitive, but then of course there's issues of feasibility and transport. Lung ultrasound has recently been proposed as a diagnostic aid for VAP. However, data on the sensitivity and specificity are lacking, but definitely this is something that's evolving and probably will have more applicability as we progress. We just need more studies because it can be done at the bedside and therefore it can be quite a useful tool in our armamentarium. We just need more studies to validate this. Coming to the biomarkers. So there are a lot of biomarkers, the C-reactive protein, procalcitonin. What about procalcitonin? So a lot of people, we use procalcitonin, but it should not be used to decide whether to start an antibiotic or not, but rather it should be used in conjunction with your clinical judgment to decide the course of the course duration and also when you could consider stopping the antibiotic. So based on procalcitonin, you shouldn't just be starting your antibiotic. Then there's also the soluble trigger receptor expressed on the myeloid cells. So all this has been tried this, but it lacks accuracy, and that's for VAP diagnosis. This is not yet recommended, any of these biomarkers. Now coming to microbiological diagnosis. So you have the quantitative cultures, and these are obtained using the proximal samples such as endotracheal aspirates. And the issues with this is that it may overestimate the presence of bacteria. Then you have various techniques like your bronchoalveolar lavage, protected specimen brush, or lung biopsy sampling methods. Now, a meta-analysis of 5 randomized controlled trial comparing these two has really shown no difference in patient outcomes. Earlier, people used to say that you have to do, go ahead and do a BAL, but it's not necessarily a tracheal aspirate may be as good enough. In terms of outcome, there hasn't been any difference. What about polymerase chain reaction, the PCR to detect bacterial DNA? And this can definitely shorten your time of the organism identification and susceptibility, but it is restricted again to specific pathogens and resistance mechanisms, right? So it really has to be a combination of all of these, depending upon your clinical setting and what is the urgency of the diagnosis and the condition of the patient as well. Now, there is the Disease Society of America and the ATS guidelines for which one to do. And there's also the European Respiratory Society, ESICM, and these guidelines. So coming back to this, the question raised is, should a patient with susceptible VAP be treated based on the results of invasive sampling, that is BAL, protective specimen brush, or a mini BAL, with quantitative culture results, or non-invasively with endotracheal aspirate with quantitative culture results, or non-invasively with semi-quantitative culture results. So if you look at the ATS recommendation, and these are the 2016 recommendations from the American Thoracic Society, what they have recommended is non-invasive sampling with semi-quantitative cultures to diagnose VAP rather than invasive sampling with quantitative cultures, and rather than non-invasive sampling with quantitative cultures. Now, the recommendation for this is weak. And they say if invasive quantitative cultures are performed, then they should be performed in patients with suspected VAP for whom the culture results are below the diagnostic threshold for the VAP. For example, the protective specimen brush is less than 10 to the power of 3, or a BAL is less than 10 to the power of 4 colony forming units, and and whether we should have the antibiotics withheld or continued. So more when there is a diagnostic dilemma, or in conditions where the patient is very sick and you still have your BAL or this thing less than the threshold. And the other recommendation is about non-invasive sampling with semi-quantitative cultures is preferred methodology to diagnose VAP. However, the panel will recognize that invasive quantitative cultures will occasionally be performed in some citizens. So this recommendation again is weak. So this is by the American Thoracic Society. And coming to the European Society and the ESICM recommendation, now this is in intubated patients who are susceptible to have VAP. Should distal quantitative samples be obtained instead of proximal quantitative samples? This is a 2017 recommendation, and what they've recommended is we suggest obtaining distal quantitative cultures prior to any antibiotic treatment in order to reduce the antibiotic exposure in stable patients with suspected VAP and to improve the accuracy of the results. But this is a weak recommendation, and they have recommended obtaining lower respiratory tract sample, that's a distal quantitative and proximal quantitative cultures, to focus on narrow the initial empirical antibiotic therapy. Now that is a strong recommendation. So essentially, taking the two together, you can say that definitely doing the sort of quantitative cultures or non-quantitative cultures using non-invasive sampling is as good, and it's only in specific cases where you might need to do invasive quantitative cultures in these patients. So both you can really say are acceptable, and there has been no demonstrated improvement in the as far as outcome goes. Now, often you are left with the dilemma of negative microbiology and whether to start antibiotics or not. So now if there's compelling evidence of a pulmonary infection, okay, and if the patient received antimicrobial therapy prior to the sampling, and this is very important because sometimes the patient has been on antimicrobial therapy, and this may be the reason why there's a negative microbiology. Now, if the patient has associated septic shock, or in an immunocompromised patient, or in conditions where there's no improvement despite managing the patient as a non-invasive disease and there's clinical deterioration. So these are the compelling reasons to start antibiotics even when there is negative microbiology. So it's more practical looking at the patient, looking at the clinical course of the disease, that you may consider starting antimicrobial agents. Now, what about the duration of your antimicrobial therapy? So both the European and the US guidelines recommend that the duration of antimicrobial treatment for VAP should not exceed more than 7 days in most patients. Longer course of duration may be appropriate for immunocompromised patients and necessary for patients with, say, you have empyema or lung abscess or necrotizing pneumonia or some specific conditions like that may need a longer course. But by and large, 7 days in most patients. And shortening the duration of antimicrobial is currently not recommended. And they have demonstrated, so you have a patient with the proven VAP. At day 5, you have a negative culture, is not a reason to stop. You should give 7 days of antimicrobial therapy. And authors have demonstrated that treatment duration can be customized based on your procalcitonin kinetics, and have been able to treat some patients for less than 7 days. But this is again still in experimental phase. Like I said, procalcitonin cannot be used to decide whether to start antibiotics, but definitely to decide on the course of how long your antibiotics can be and whether to stop. So when to stop the antibiotics? Now you've already started it before sampling, you revalidate the patient, and if the clinical course is favorable and the likelihood of infection is low, then you can stop the antibiotic. And you can do this in conjunction with the procalcitonin. So at 48 to 72 hours, if the level is less than 0.5, or there has been a decrease more than 80% as compared to the peak value, then you can consider using this, not in isolation, but of course in conjunction with the clinical course of the patient. You can use the procalcitonin, and that is a reasonable way to consider stopping the antibiotic. So just coming to just a kind of algorithmic way of when there's a suspicion of VAP, you can either do an endotracheal aspirate or you can do a bronchoalveolar lavage. The advantages of this are endotracheal aspirate, it's cheap, patient tolerates it better, it's easier to perform, and it's more sensitive. And the downside is the specificity is low, antibiotic usage may be higher, and only microbiological exams can be done. But if you do a BAL, it's more specific. You can give lesser antibiotics to these patients. Larger sample is required. And the negative side is that the sensitivity, the cost, the tolerance, and also it requires specific skill. Not everyone may be able to do a bronchoalveolar purge. Of course, you have to start empirical antibiotic therapy, and you consider stopping if the cultures come negative. And if you're giving definitive antibiotic therapy, by and large, it shouldn't exceed 7 days of therapy. So then coming to a more kind of current workup process, and this is a potential for the future. So when you do microbiological sampling, less than 1 hour, the microbiological examination should be done, and you should start your empirical treatment. Your cultures, your other tests can go, and you can start if within 24 to 36 hours, you should get your culture reports back, and then you can titrate it based on this. And if there's antimicrobial susceptibility tests are done, you can use definitive targeted therapy is this done. More futuristic, and what we're looking for in the future is multiplex, PCR tests, and this can give you definitive targeted therapy in less than 6 hours. But these are more things that we are looking forward to in the future and not yet developed. So by and large, within 36 to 48 hours, you should be able to get your results, even if you've done a regular culture. So the treatment of VAP, supportive treatment, of course, 2 steps of antimicrobial treatment. One is the empirical treatment. So the choice, again, immediacy of the treatment. And this is driven by what is the disease severity, mortality risk, and the factors of the MMDR. So these are the 2 criteria that you use. Is the patient stable or not? Is he in septic shock? And what is the risk factors? Like I told you, even in the early onset, you can have MDR bugs. So what is the likelihood of this patient having, does he have risk factors for MDR bugs? And then, of course, based on your local kind of flora and epidemiological pattern of your in your hospital. And definitive treatment, of course, should be done once the results of your culture reports or the PCR are available. And this is to avoid overuse of antibiotics and to stop, having stop antimicrobial resistance, etc. So empirical, and then you have to have the definitive treatment. And what's really, really bad is continuing the same broad spectrum antibiotic that you use for the empirical treatment for long duration of time, or discharging the patient of ICU and the patient still continues to be on meropenem. So this is the de-escalation is very, very essential, and titrating the therapy and narrowing your spectrum to a more definitive treatment is very important. Now, concerns about antimicrobial therapy, of course, the resistance to the 3rd and 4th generation cephalosporins in the Enterobacter series stage, and this is due to expression of acquired extended spectrum, the ESBLs. Your ABC lactamases is a major worry. The spread of carbapenemase producing strains, MDR isolates of Pseudomonas aeruginosa, Acinetobacter baumannii strains, carbapenem resistant ones, and colistin resistance has also increased following rise in the rates of colistin consumption and treatment extended drugs, so extended drug resistance organisms. This is really a concern for antimicrobial therapy, especially in the developing world, and you are all aware of this problem that we are currently facing. So just to go through a little about the initial empirical antimicrobial therapy, I don't want to tell you too much about this, but early VAPs, less than 5 days, without MDR bacteria, okay? These are non-Pseudomonas, then you can just give something like an amoxiclav or 3rd generation cephalosporin. But in late VAPs, when you talk about more than 5 days, and these have risk of MDR bugs, then a beta-lactam against Pseudomonas and non-beta-lactam anti-Pseudomonal agent. So you could give a cephalosporin, piptazo, meropenem, amikacin, as we are doing. And if there's known MRSA colonization or a high more than 20% prevalence of MRSA in your unit, then you have to have an agent that's active against MRSA, that's vancomycin or linezolid may be started. And if you have known colonization with carbapenem resistant Enterobacter or Pseudomonas, then you can give the newer beta-lactam agents. So these can be considered for this patient. So coming to strategies that you can use to prevent VAP. And this is very important. We're talking about diagnosis and treatment of VAP, but what's most important is try to prevent VAP. So avoid intubation. Of course, that may not be possible. Whenever it is possible, try to avoid intubation. Consider non-invasive ventilation. You have an IV, you have high flow nasal cannula oxygen. Of course, that may not work very well in acute hypoxemic respiratory failure, but when possible, try to use this Prefer oral intubations to nasal intubations unless it is for some reason contraindicated. Head elevation 30 to 45 in a semi-recumbent position, and this is to avoid aspiration of tracheal secretions, which are known to increase the incidence of pneumonias. Daily interruption of sedation, consider early extubation, early mobilization, and avoiding reintubation whenever possible. Routine change of ventilator circuits is not required. You can use one circuit for the entire course of the patient. So some people change in 48 hours, 72 hours. This is really not required, not recommended. Monitor the cuff pressure and keep it at more than 20 centimeters. And this is to avoid the air leaks around the cuff and to avoid the microaspiration that may occur. And try to prefer endotracheal tube with subglottic suction. And this is again to prevent the microaspiration. So there's whatever collection of secretions occurs in the subglottic area is continuously sucked out. And HME may be better than the heated humidifier. So heated humidifier is better in terms of humidification, but high chance of colonization. So your HME filters are better to use. We were able to reduce our incidence of VAPs in our hospital by almost 50% when we stopped using the wet circuits and we moved to the HME filters. Closed endotracheal systems may be better than. Now, this is a very, very important intervention to reduce. By these two interventions, the last two that I mentioned, we were able to reduce the incidence of VAP. So especially when there is multiple people handling and you have open suctioning, this is really, really bad, and wet circuits. So, and do suctioning only when it's required. There's no requirement, need to do frequent suctioning, and periodically drain and discard the condensate. Now, this doesn't really happen when you use the HME filters, but drain the condensate. So these are the strategies to prevent VAP, the common interventions that you could use. But you have a VAP bundle that has been proposed for by the IHI. And this is often asked in the exams, the VAP bundle. So if you look at it, it's head elevation, again, to prevent the microaspiration, daily interruption of sedation, and this is the reason you do that is not to assess the CNS status, but to, for the metabolism of the drugs, because they have prolonged duration of action in critically ill patients. So you can wean off these patients faster, and that's how it can help in reducing VAP. Stress ulcer prophylaxis, this has been is a little controversial, and I'll talk about that. Deep vein thrombosis, DVT prophylaxis, and stress ulcer prophylaxis, both of these are just part of the care in a patient who is immobilized and on a mechanical ventilator. Daily use of chlorhexidine for oral hygiene. Now, this had been proposed in the previous guidelines, and it was a new addition to the VAP bundle. However, this has become controversial and has been currently challenged. So this also falls a little weak. These two are just part of the general care of a ventilator, ventilated patient. It's not a direct intervention to reduce the incidence of VAP. But if you're asked about the IHI VAP bundle, then it is, these are the 5 elements of the VAP bundle. And there's several modifications by different societies that have been proposed. Now, what you must know about VAP prevention is what is the current evidence about VAP prevention. Now, this is, important for you to know. Head elevation. So there are less studies, but it's more logical. If you keep the patient's head elevated, microaspiration is less likely. So it's understudied, but a few contradictory randomized controlled trial, but it's just logical, makes sense. Tapered endotracheal tube cuffs with ultra-thin polyurethane, so no impact. So a lot of coated tubes, etc. Automated endotracheal tube cuff with pressure monitoring. Again, merit, this needs to be further evaluated. Subglottic secretion drainage. So this has been extended studied, but despite the lower VAPS rates, no impact on the duration of mechanical ventilation, ICU length of stay, or even the VAE rates. So it's really unclear. So we do a lot of this subglottic secretion. Again, it seems logical, but no demonstrated benefit in recent trials. Now, this is very important, oral care with chlorhexidine. So following the previous studies, people started using oral care with chlorhexidine, but this is still unclear. And now extensively studied, most individual studies were negative, and there was a recent meta-analysis, open label study suggested that VAP rates, these were double blinded studies that occurred later, found no impact, and they actually found it may increase the mortality rate. So oral care with sterile water is now preferred rather than oral care with chlorhexidine. So this is like a big change. There's no data to support its use following the initial big study, after which it was included in the bundle. Selected oral digestive decontamination, it likely lowers VAPs, but extensively studied, No impact on mortality or any benefit seen. Probiotics, again, unclear, many studies, but mixed results. No signal when it was restricted to double-blind studies. Now, stress ulcer prophylaxis. Now, stress ulcer prophylaxis can actually increase your VAP rates. So, observational studies and some meta-analysis suggest that higher VAP rates, but more recent trials have found no impact. Now, you need to give stress ulcer prophylaxis for other reasons. Mechanical ventilation is itself a high risk for developing stress ulcers, but prolonged use should not be considered because it can alter the pH, increase the colonization. And VAP prevention bundles. Now, you talk a lot about the VAP bundles, likely lowers rates. Now, this again has been extensively studied almost exclusively in before and after times, but may be associated with lower mortality and more likely benefiting from following these bundles is not directly reducing, but definitely reducing the duration of sedation and encouraging early extubation, so indirectly preventing VAP. So though we don't have any direct evidence, this seems like something that is good to be done as part of a general care process. So if you're talking about prevention of VAP today, oral care with chlorhexidine and stress ulcer prophylaxis may actually be harmful. You can do it with just distilled water. And stress ulcer prophylaxis, again, if you need it, use it, but you must know that this may actually be harmful in terms of VAP. The most consistently what has been associated with improving objective outcomes in these patients is try to avoid intubation, though of course it's not always possible. Minimize the exposure to invasive ventilation by using alternatives like high flow NIV. Care bundles now addressing aspiration specific factors. Okay, so maybe head elevation, subglottic suction, different things can be used to avoid this kind of aspiration. Lighter, but what's shown to have a benefit is lighter levels of sedation, so earlier weaning, spontaneous breathing, more early mobilization. So all this to help early extubation. As you know, the more days on mechanical ventilator, the more higher chance that you are at a risk of getting um, a ventilator associated pneumonia. Now, coming to COVID, so ventilator-associated pneumonia. Now, in the era of the COVID-19 pandemic, how common and what is the impact? So they have seen, studies have not shown an increased incidence, but there is VAP in association with COVID-19. And this is a very nice study that was published very recently in Critical Care. And this is from Professor Vicky Niederman and Jean-François Timsy, and very, very nice cartoon that they've given along with this. And I found this very interesting because it really summarizes everything. And here they've looked at the pathophysiology, diagnosis, and the treatment of ventilator-associated pneumonia. And what you see in blue is what is associated with ARDS. So your pathophysiology, the nasopharyngeal colonization, enhanced bacterial adherence, direct mucosal epithelial damage, and your immune alterations that, is a pathophysiology for your ARDS. And what they found with SARS, whatever is in red is additional for the pathophysiology diagnosis and treatment. So in terms of SARS, definitely overcrowding. So there's disorganized healthcare system, suboptimal prevention strategies, right? We've seen that especially in the beginning of the pandemic. Atelectasis, so mucus plugs, prolonged ventilation and sedation was being used for these patients, and this definitely is contributory. Then micro and macro thrombi, pulmonary embolism that we're seeing with COVID, and lymphopenia, immunoparalysis, paralysis, and this is with corticosteroid use and the various immunomodulators that we're using for the treatment of COVID. So this can alter the pathophysiology of in COVID-19 for VAP. Coming to the diagnosis, in ARDS, you look at whether it's tracheobronchitis or pneumonia, proximal or distal, bronchoscopic or blind strategies. Whereas the diagnosis here, the problems are the limited samples. So because the healthcare worker tries to avoid the direct exposure, there could be limited sampling and limited gram stain examination, limited specimen manipulations. So increased use of PCR is there. So this is what's different in COVID. And frequent MDR and PDR pathogens. And here in COVID, you'll see, abnormal microbiological pharmacokinetics. So what happens is frequently you see augmented renal clearance and also lung hypoperfusion. And this may result in increased risk of treatment failure, especially the use of use of therapeutic drug monitoring. So these are some of the challenges that we are facing in, differences that we're seeing with pathophysiology diagnosis and treatment in the era of COVID-19. and along with ventilator associated pneumonia. So I'd like to just conclude by saying that VAP remains one of the most frequent ICU-acquired infection with increased mortality in these patients, and the diagnosis should be made on clinical, radiological, and microbiological evidence. Microbiological confirmation is strongly recommended for the diagnosis, and antimicrobials should be limited to 7 days in most of the cases. Emerging microbiological tools are likely to modify our routine approach to the diagnosis and also treatment. We'll have earlier, more definitive treatment if we get our results earlier, like if you have the test available to you in less than 6 hours. But we do need more randomized controlled trial to confirm that these bundles that combine the multiple prevention strategies may actually improve outcomes. So bundles until then remain something that's part of a good quality process, but whether they actually reduce infections need to be further, and outcomes, improve outcomes need to be further studied. I'll leave you with this very nice review that I found not very old, it was in March 2020, about a 1 year old, but this was a very, very nice review on VAP in adults, and I think that will be really good for further reading. So thank you very much for your attention.
Thank you so much, Dr. Mahatra, for an excellent overview of the VAP and prevention of VAP. We have got a couple of questions.
Yeah.
We will. So, how would you differentiate tracheobronchitis with colonizer versus VAP, and your approach towards when to start antibiotics? And the third, the same is, do you need to reculture before you stop antibiotics?
Right. So, very important questions, definitely from the clinical point of view. So, again, depending upon the kind of symptoms that the patient has with tracheobronchitis, and when you're doing your culturing, that's very important. Where you're taking your, samples from, imaging can play a very important role in this. You see the cultures are positive, but you see the imaging, and there are no infiltrates. So these are things that you can use to distinguish. In any case, if it's an infection, you need to treat it. So you have to have microbiological confirmation for this. And coming to your, what was the second question? Sorry.
When do you repeat the? Do you need to repeat cultures before you stop the antibiotics?
Right. So usually the period of antibiotic administration, as I've mentioned, the current recommendations are for 7 days. So if the patient is getting better, imaging is getting better, I wouldn't bother to reculture the patient. But if you're 7 days on antibiotics and the patient is actually getting worse, then you might consider, reculturing. It's not mandatory. It again, it depends on the course of the patient and whether the patient is improving or not. But it's not mandatory, but it can be done. I would complement this with procalcitonin. So if I see that my procalcitonin values persistently remain high or are not going down, and this patient is still sick, then I might consider culturing. But if I have a patient who's clinically getting much better, imaging is resolving, the procal values are going down, I would stop the antibiotic without reculturing.
Right. The next question is by Dr. Rajat. He wants to know how sedation holiday helps in VAP prevention.
Yeah. So it's not a direct, it's not that you reduce sedation and VAP goes down. So sedation holiday, now most people in the unit, when I ask them, why do you stop sedation? Why do you do daily interruption of sedation? It is not to assess the neurological status. That's the first answer. One of the benefits of it is yes, you can wake up the patient and assess the CNS. The reason is to help in the metabolism of the drugs. So what happens is whatever drugs you give, midazolam, fentanyl, morphine, whatever infusions you give in a patient, say in the operating room, the way they metabolize is not the same as in a patient who has renal dysfunction, liver dysfunction, or whatever other critically ill patients, right? So you have prolonged duration of these drugs. So the reason we give, daily interruption of sedation in the morning, and morning, of course, because there's more staff around, so you don't want accidental extubations and tubes pulled out, is so that you can give a few hours and allow these drugs to metabolize so you can facilitate a faster weaning. So you do what we call a daily awakening, followed by a daily spontaneous breathing trial. And if the patient is actually well enough, you can actually consider extubating. So unless you do this every day, you land up just deeply sedating the patient, and you'll give more and more days of mechanical ventilation and increase your likelihood of developing VAP. So this is a very, very important intervention to reduce. Either you keep lighter levels of sedation, in which case you don't need interruption, or if you're a unit where you don't have very good nursing and you're not able to maintain the perfect RAS cause, you must do daily interruption, and this will help reduce the days on mechanical ventilation. So that daily assessment of, can I wean this patient? Is he ready for extubation? Is he ready for weaning? Can I reduce the duration of mechanical ventilation is extremely important. So it's indirect, it's not direct. It's not that you stop sedation and VAP will reduce. It's not like that. But it's one of the interventions that can indirectly help you in the process.
Right. Then the next question is by Dr. Pradeep in terms of could you explain the VAP trial? And he also asked that if the patient is on NIV and he deteriorates in terms of either increase in the FiO2 or new onset, new patches on the X-ray or counts, is it ventilator associated complication if he deteriorates on NIV?
Yeah. So VAP trial, I mean, which trial are you referring to? Sorry, I'm not aware of it. What trial you're talking about? But just coming to the NIV,
Yeah.
I'd like to say that, see, the definitions are for intubated patients, right? So that would constitute a HAP, definitely, like a hospital-acquired pneumonia, not a VAP by the, absolute, definition. But when he's worsening like that, I mean, even keeping him on, see, non-invasive ventilation is something, and high flow are something that you could consider, but they don't work well in acute hypoxemic respiratory failure. So if you're seeing, so even using them could actually be quite dangerous in terms of patient outcomes. What's key is to monitor them and to intubate them early. So it's not about early or late intubation as we've seen in COVID. It's about the timely intubation. So you have to monitor them early, and you have to make sure that they are, intubated at the right time. Because if you see this kind of worsening, earlier trials actually showed worse outcomes in patients who got NIV because intubations were delayed. And the same thing with hypronasal cannula oxygen. So when you're seeing this kind of worsening in a condition, even if a patient is maintaining the saturation, there might be some patients who you need to intubate early. But in terms of a VAP, you cannot call this a VAP, you can call this a HAP.
Okay, and then Dr. Arnab wants to know what is the role of nebulized antibiotics, especially the polymyxin group for VAP? How do you manage XDR organisms or either pan-resistant or intermediate resistant organisms?
Yes, so nebulized colistin, nebulized drugs do work in combination with intravenous dose of the antibiotic. There have been studies, but not very, very hard data to suggest that you should definitely use them. So a lot of people, we use it in our unit. You can use it in combination. You can use both intravenous as well as nebulized colistin can be used. And these drugs can be used. But all this, we really need more data. We need more data, even for the XDR bugs, promising antibiotics. But I think we need more studies. So we are with our back against the wall. There's nothing left. Your patient is doing badly, resistant to meropenem, resistant to colistin, so you have this kind of situation. We don't have much choice left. So you do try this, but I would really say you need more data to say whether they can actually, improve outcomes. And we don't really have that at the moment. We have promising data, but we don't have data to suggest they improve outcomes.
Third part of his question is if the patient is deteriorating hemodynamically on broad spectrum antibiotic, when do you decide about empirical antifungals?
Right. So definitely, again, it depends on the clinical setting of the patient, right? So I work in a cancer hospital. So if this kind of patient is already on broad spectrum antibiotic and has a fever or any kind of deterioration, I would immediately start this patient on antifungals. So if your patient isn't getting better and there is a suspicion, the patient has to have some risk factors for getting a fungal infection, right? So if he's got lines in for a very long time, central line in or other catheters or things like that. So then there would be a higher or other risk factors, or has been on broad spectrum antibiotics before, or has been on TPN, or has been on prolonged steroid therapy. So there has to be some risk factors. And then he's worsening, right? So then you can consider giving fungal antifungals. But just because he's hemodynamically stable, you need to evaluate why he's hemodynamically stable. It could be anything else. It may not necessarily be because of sepsis. He may just have, pulmonary embolism or something, some other condition why he may just have cardiac failure or something else that is causing the hemodynamic instability. So I think I would evaluate it. But if his VAP is not getting better, and you're already on these broad spectrum antibiotics, and there is a suspicion, a risk factors for developing a fungal infection, again, depending upon your setting, then definitely I would consider starting an antifungal on this patient.
Right. So I think that's about it. Well, thank you, Dr. Mahatra, and uh, we will move on. The few announcements, we have the certificates can be downloaded from the website after you fill up the feedback form, and to um, to go on to the last topic for the day, I would like to invite um, Dr. Deepak Govil. Again, he is the director of Medanta, and he is the president of Indian Society of Critical Care Medicine. We've heard him in the afternoon about the liver failure, and now he's going to talk about another important topic, that is management of polytrauma patients in the ICU. Over to you, Dr. Deepak.
Good afternoon, dear friends. In next 25 minutes or so, I'll be talking about the polytrauma. Polytrauma is a syndrome of multiple injuries exceeding a defined severity score, that is, injury severity score more than 17, with consecutive systemic reactions which may lead to dysfunction or failure of remote, primarily uninjured organs or vital system. This is the trimodal distribution of the death. First peak when it happens, seconds to minutes. That can happen in seconds to minutes due to major vessel or cardiac injuries, due to severe traumatic brain injury or high spinal cord injury. Second peak, minutes to hours. This time is called as a golden hour of the trauma care. If we succeed in providing golden hour, good trauma care, this peak can be avoided many times. We have to do a rapid assessment and resuscitation of the patients during this phase. Third peak is days to weeks. It is mainly because of the sepsis and multi-organ dysfunction syndrome. Coming to the ACLS concepts, they are basic concepts. Treat the greatest threat to the life first. Never allow the lack of definitive diagnosis to impede the implication of indicated treatment. Detailed history is not essential to begin the evaluation of a patient with acute injuries. So, as per ATLS, treat the greatest threat to the life first, because the first aim is to save life. Definitive diagnosis is not immediately important. Time is the essence to save the life, and do not do further harm to the patient. We have to go for initial assessment and management, airway and ventilator management, and shock management. To have a good initial assessment and management, we have to do a certain preparation. We have to think of triaging the patient. Primary survey like ABCDE. I'm sure everybody knows what it stands for. ABCDE: airway, breathing, circulation, disability, and exposure or environment, with immediate resuscitation of patient with life-threatening injuries to be done. Adjuncts to the primary survey and resuscitation to be considered, that we'll discuss in the successive slides. Consideration of need for patient transfer to be thought of. Secondary survey is again a head-to-toe evaluation along with the patient history. Here some adjuncts are there for secondary survey that we'll discuss later on. Continued post-resuscitation monitoring and reevaluation should be done, and one can think of that definitive care. In trauma patients, the primary and secondary survey are repeated time to time. And ATLS steps are just guide to you. Not everyone will all steps. So one has to think accordingly the patient's injury, but primary and secondary survey has to be repeated every time to time. Who requires pre-hospital triaging, where the GCS is less than 13, systolic blood pressure is less than 90, the respiratory rate is less than 10 or more than 29 might need ventilatory support. Patients who are having penetrating trauma to head, neck, torso, extremities proximal to elbow or knee. Patients who present with flail chest, pelvic fractures, 2 or more proximal long bone fractures, proximal amputation, wrist of ankle, crushed, degloved, mangled, pulseless extremity, depressed skull fracture, and patient who present with paralysis. When there is a small doubt, please refer the patient to trauma center. Primary survey is a rapid examination to identify and treat life-threatening conditions. Many times we feel that primary survey is a simple survey just to identify the life-threatening condition, but primary survey also includes the treatment of the life-threatening conditions. A stands for airway maintenance with cervical spine protection. B is for breathing and ventilation. C is circulation with hemorrhage control. D is disability and neurological status. E is exposure and environmental control. Primary survey is a rapid examination to identify and treat life-threatening conditions. It should be completed in 10 seconds. Ask the patient to identify himself, name what happened quickly. Talking patients, you can assure patient momentary reassurance can be done, and it is reassurance to doctor as well that patient's airway might be patent. There is no issue if he is talking about. Refuse to lie down. Again, there could be a breathing or airway issue. That is why a patient is not comfortable in lie down and trying to sit up on the bed. All severely injured patients should be administered oxygen. Simple maneuver can help, like suction to clear any obstruction, chin lift, jaw thrust, making C-spine precautions. Mind you, here we don't do the head tilt. Only chin lift and jaw thrust while somebody is doing cervical spine stabilization should be done. So no head tilt is done. Anticipate vomiting and aspiration in these patients. As you can see here in airway, there is a chin lift. You can see one person is stabilizing the neck and another person is doing the chin lift. Do not hyperextend the neck at this point. Jaw thrust, again, one person is doing jaw thrust and another person is stabilizing the neck. One has to avoid the neck extension because at this point, we don't know whether patient is having cervical spine injury or not. Cervical spine has not yet cleared. So if we extend the neck, patient can have further damage to the cervical cord. In airway, we have to look for laryngeal trauma. We can identify laryngeal trauma if patient is having hoarseness of the voice, if there is a subcutaneous emphysema over the larynx, or we can feel the fracture over the larynx. In airway, we have to always look, listen, and feel. Expose the neck and chest, then look for the rate and depth of respiration. C for engorged neck veins. C for any tracheal deviation if it is there. Look bilaterally or unilaterally chest movements and look for the use of accessory muscles. Listen chest bilaterally very carefully. Listen for any hoarseness of the sound. Listen for any dysphonia in the vocation. Feel chest for dullness. If it is there, pneumothorax, hyperresonance in presence of pneumothorax, crepitus could be surgical emphysema or fracture rib or any other deformity. Be prepared with equipments like suction, oxygen, oro or nasopharyngeal airway, bag mask, laryngoscope, bougie, extraglottic devices, cricothyroidotomy kit, PT tubes of various size, pulse oximeter, capnography, and drugs. Restrict cervical spine motion, reoxygenate the patient with help of oxygen, bag mask ventilation, oral bag mask, and oral or nasal airway. Assess airway anatomy, difficult intubation. You can assess with the mnemonics of lemon. L is for looking, E for is evaluation, M is for malampatti, O is for obstruction, and neck, N is for the neck movements. If you feel it is easy, go for intubation. Depending on the patient's GCS or patient's cuff reflex, it could be drug-assisted intubation or it could be just intubation. One has to apply cricoid pressure. If you feel that airway anatomy is difficult or difficult intubation is going to happen, call for assistance. Don't wait for attempt. If your airway, maintaining airway or intubation attempt is unsuccessful, consider adjuvants, consider awake intubation, or definitive or surgical airway can be considered. Drug-assisted intubation, have a plan in the event of failure that includes possibility of performing surgical airway.
Know where your rescue airway equipment is located. Ensure that suction and ability to deliver positive pressure ventilation are ready. Pre-oxygenate the patient with 100% oxygen. Apply pressure of cricoid cartilage. Administer an induction drug like etomidate or sedative according to local protocol. Administer 1 to 2 milligram per kg of succinylcholine intravenously. After the patient is relaxed, intubate the patient orotracheally, inflate the cuff and confirm tube placement by auscultating the patient's chest and determining the presence of CO2 in exhaled air. Release cricoid pressure, ventilate your patient. Definitive airway, inability to maintain a patient airway by other means with impending or potential airway compromise, like following inhalational injury, facial fractures, or retropharyngeal hematoma. Inability to maintain adequate oxygenation by face mask oxygen supplementation or the presence of apnea. Obtundation or combative resulting from the cerebral hypoperfusion. Obtundation indicating the presence of head injury and requiring assisted ventilation. So in such conditions, we have to maintain a definitive airway. Indication of surgical airway in the presence of edema of glottis, fracture of the larynx, severe oropharyngeal hemorrhage that obstructs the airway, inability to place an endotracheal tube through the vocal cords. Percutaneous tracheostomy is generally not recommended in acute trauma. One has to go for surgical cricothyroidotomy or percutaneous cricothyroidotomy because it is very fast in urgent situations, whereas percutaneous tracheostomy can take some time. Look for, in breathing, look for tension pneumothorax. Usually it happens because of there is a formation of one-way valve inside the chest is there. It is a clinical diagnosis. Do not wait for radiological confirmation. If ultrasound machine is there, you can do quick e-fast. Over the needle catheter or finger thoracostomy should be performed to release the air. Fifth intercostal space anterior to mid-axillary line can be chosen to do the needle thoracostomy or finger thoracostomy. Check peripheral pulses, heart rate, blood pressure, pulse pressure, capillary refill, and cyanosis. Be careful in children and elderly. All hypotensive trauma patients are assumed to be in hemorrhagic shock after pneumothorax is ruled out. 2 large bore peripheral IV cannula, at least 18 gauge should be put in and control external bleeding if there is any. Look for blood, especially these 4 places other than the floor. First look at the floor or surrounding, you will come to know how much bleeding is there. Then you can look for the thorax, thoracic cavity, for a hemothorax, pericardial area, for a pericardial tamponade. Look for the fracture pelvis or floor of the pelvis for the collection of blood, and look for any long bone fractures. This is the sign and symptom of hemorrhagic shock by classes. So there are class 1, class 2 is mild, class 3 is moderate, class 4 is severe. Approximate blood loss in class 1 is less than 15%, in class 2 it is 15 to 30%, in class 3 it is 31 to 40%, and class 4 it is more than 40%. Heart rate, blood pressure, pulse pressure, respiratory rate, urine output, GCS can remain stable in class 1. Base deficit, usually 0 to minus 2 milliequivalent per liter is found in the class 1. Need for blood products is not there. One has to just monitor the patient. In class 2, again, the blood loss is 15 to 30% of the total body volume. Heart rate sometimes may remain stable or it can increase. Blood pressure sometimes remain stable. Pulse pressure goes down. Respiratory rate may be stable. Urine output is there. Glasgow Coma scale is there. Base is stable. Base deficit is minus 2 to minus 6 milliequivalent per liter. And need for blood product could be there. It is possibility. In moderate or class 3 hemorrhagic shock, approximate blood loss is 31 to 40%. Heart rate goes up. Blood pressure goes down. Pulse pressure goes down, respiratory rate goes up, urine output goes down, and GCS can go down. Base deficit is increased, minus 6 to minus 10 milliequivalent per liter, and need for blood product is definitively there. Class 4, more than 40% of the blood loss, the heart rate goes up quite fast, blood pressure is down, pulse pressure is down, respiratory rate is high, urine output is very less, Glasgow Coma scale can go down, and base deficit is usually more than 10 milliequivalent. Massive transfusion protocol should be initiated in class 4 or severe hemorrhagic shock situation.
There are certain pitfalls to assessment of the hemorrhagic shock. Patient age is very important. Extreme of ages, the shock can manifest very fast. Or in the healthy adult, you may not find that clear-cut sign of the hemorrhagic shock where patient has already lost much blood. But because of the compensatory mechanism, the signs are not that severe. Severity of injury, particular the type and anatomic location of the injury, has to be considered. Time lapse between injury and initiation of treatment. If a type 1 shock is there or type 2 shock is there and nobody has done the management, then gradually it can convert into type 3 or type 4. Pre-hospital fluid therapy has to be considered, and medication used for chronic conditions like anticoagulation, like antiplatelet drugs, like beta blockers has to be considered here, because if a patient is on beta blocker, his heart rate is not going to rise. After in the initial resistance, how will you assess whether your fluid resuscitation is adequate or not? So in this table, I have tried to show you how you can assess the initial fluid resuscitation. So there could be three possibilities. Rapid response is there, transit response to your fluid resuscitation is there, or minimal or no response to your fluid resuscitation is there. Look at the vital signs. If fluid resuscitation is adequate, then rapid response is there. The vital signs will become return to normal. Here the estimated blood loss is less than 15% of the total blood. Need of blood is very low or not. Blood preparation, one has to send for typing and cross matching. Operative intervention can be there. Early presence of surgeon should be there. So early presence of surgeon should be there in all type of trauma. If your fluid response is very transient, vital signs are transiently improvement, then recurrence of the decreased blood pressure and increased heart rate is there, then you can assess that the moderate or ongoing blood loss is there. Need for blood is moderate to high. Patient needs a type specific. At this juncture, we don't have got time for cross matching. We have to ask just the type specific, the B positive or O positive, whatever the patient's blood group is there, just ask that blood. Then operative intervention is likely, surgeon should be there. Minimal of no response to your early fluid resuscitation. Patient's vital sign remain abnormal. It means patient has had severe blood loss, more than 40%. Need of blood is immediate. Here you have to activate the massive transfusion protocols. Emergency blood release has to be done. Need for operative intervention is highly likely, and presence of surgeon should be there. Now coming to the other aspect, after resuscitation, what is happening? Once we have started resuscitation of the patient, then what is there after resuscitation? There could be edema, there could be compartment syndrome, there could be hemodilution, there could be hypothermia, coagulopathy, and disruption of the clot. In hemorrhagic shock, one has to use the early use of blood product. In class 3, class 4, early use of blood product should be done. RBC, FFP, and platelet ratio should be 1:1:1, or at least 2:1:1. One has to consider the medications here. If patient is on antiplatelet or anticoagulant, reversal agents should be given. Initial goal of resuscitation is hemostatic resuscitation, systolic blood pressure 80 to 90 until major bleeding is stopped. The only caveat here is if a patient is having traumatic brain injury, then we have to keep the mean arterial pressure 80 millimeter of mercury. Otherwise, try to do a little hypotensive resuscitation till the major bleeding is stopped. Initial crystalloid 20 ml per kg can be used judiciously, but later on it should be restricted. No colloids at this point. Blood and blood product transfusion should be considered early. Early use of tranexamic acid, 1 gram bolus and 1 gram over 8 hours. And try to prevent coagulopathy of trauma. When to go for massive transfusion? So there is a TAS score, trauma-associated severe hemorrhage. It considers the gender, hemoglobin, systolic blood pressure, heart rate, positive fast finding, or in presence of intra-abdominal fluid, complex long bone fracture, pelvic fractures, and base deficit more than 10. Another score is ABC score, where heart rate is more than 120, systolic blood pressure is less than 90, positive fast is there, and there is a presence of penetrating trauma. Predetermined massive transfusion protocols are associated with the reduction in organ failure and post-injury complications. So in a presence of hemorrhagic shock, one has to consider the early surgery. If
one can consider, if surgery is not possible, one can consider the angioembolization or pelvic stabilization. Aggressive and continued volume resuscitation is not a substitute for definite control of hemorrhage. Damage control resuscitation is hemostatic resuscitation. Damage control surgery is the aim is to control bleeding, not to do the reconstruction, but just come and go, quick control of the bleeding, prevention of contamination, allow the correction of hypothermia, coagulopathy, and acidosis. Then once patient is stabilized, then definitive surgery can be undertaken afterwards. This is a traumatic circulatory arrest algorithm. If patient is having traumatic circulatory arrest, penetrating of a blunt without any pulse, patient is in operating room, or you can take the patient to operating room with surgeon presence is mandatory. If it is less than 2 minutes, trauma team alerted by medical dispatch, close CPR in progress, airway, external cardiac massage, orotracheal intubation, 100% oxygen, IV or IO line, fluids, and epinephrine is to be given. If return of spontaneous circulation is there, usual management. If there is no return of spontaneous circulation, bilateral chest decompression should be done. Return of circulation is there, put the chest tube, and usual management. If there is no ROSC or more than 3 minutes of the pulseless activity is there, then anterolateral or clamshell thoracotomy can be done. Vertical pericardectomy and release of tamponade, if presence is there, can be done. In a traumatic circulatory arrest, there could be two possibilities. One is cardiac injury, another is severe hypovolemia. If cardiac injury is there, control of cardiac lesion, cardiotomy performed at the previous green box, as we have discussed earlier, repair of the heart wounds can be done. The return of circulation is there, then usual management. If patient is having severe hypovolemia, thorax, pulmonary pedicle, mediastinal vesicle, hemostasis, clamp, loop can be applied. If in abdomen, clamp the descending aorta, continue resuscitation via large bore lines. The patient had cardiac arrest, again, internal cardiac massage or internal cardiac shock can be given. If after 30 minutes of resuscitation and the temperature is more than 33, his heart is not returning back, then one can pronounce the death. Primary survey, disability part, level of consciousness has to be assessed, pupillary size and reaction, lateralizing sign and spinal cord injury level has to be checked, Glasgow Coma scale has to be monitored, and careful for head injury patients. Exposure, completely undress the patient and inspect the entire patient from head to toe, both from front and back. Maintain spinal precautions while doing log rolling. Inspect both axilla and perineum and use warm blanket so that your patient is not become hypothermic while exposing him or her. Adjuncts to the primary survey and resuscitation, ECG monitoring is very vital. Urinary and gastric catheters, put pulse oximetry, measure blood pressure, do ABG, do X-ray examination, do fast and diagnostic peritoneal lavage can be done. Focused assessment of with sonography in trauma, that is fast. We are having 4 windows: perihepatic, perisplenic, pelvis, and pericardium. Nowadays, we have moved from fast to e-fast. In e-fast, what we do in hepatic and perisplenic, we just move the probe to upper area and look for the other things as well in the lungs. I'll tell you what, in perihepatic, we look for the blood between any presence of the fluid between the liver and the kidney. And if we go up the diaphragm, then we look for any fluid in the peritoneal cavity, and we move little bit upwards to look for any pneumothorax. Same in the perisplenic, we look for the presence of any fluid between the spleen and the kidney, and we move up to the diaphragm, up of the diaphragm in the chest to look for any presence of pneumothorax or pneumothorax. In pelvis, again, we look for any presence of the fluid, and in pericardium, we also look for any pericardial tamponade. Secondary survey does not begin until the primary survey is completed, resuscitative efforts are well established, and the patient is demonstrating normalization of the vital sign. So till the patient recovery is there, primary survey is continued. Once the recovery is there, we stop the bleeding and vitals are returning back to the normal. Then secondary survey starts with the complete history and physical examination. And then reassessment of all the vital signs are to be done. History is taken as ample surgery, allergies, medication, what medications on the patient, past medical history,
is last menstrual period, history of any transfusions, last meal, and event leading up to the trauma. Secondary survey is physical examination. It is a stepwise organized, every patient same way every time. So it should be a reflex, superior to inferior. Look for the superior surfaces to inferior surfaces and proximal to distal from top to head to toe. Listen, look, listen, feel is the dictum. So physical examination, neurologic examination, head examination, maxillofacial examination, cervical spine and neck, chest, abdomen, perineum, rectum, vagina, or musculoskeletal examination to be done. Adjuncts to the secondary survey are X-ray examination of spine and extremities, CT scan of head, chest, abdomen, and spine. One can go for contrast angiography, bronchoscopy, and esophagoscopy. Endpoints of the resuscitation after control of the hemorrhage. Normal or hyperdynamic vital signs. Hematocrit is more than 21. Transfusion threshold many times determined by the patient age. As we all know, the extreme of ages, we have to be little liberal in the transfusion. Normal coagulation function, platelet count should be more than 50,000. Normal serum electrolyte, restoration of adequate tissue perfusion as indicated by normal serum lactate or normal base deficit, normal SCVO2 or SVO2, normal or high cardiac output, and normal urine output. Reevaluation and definitive care, constant reevaluation should be done. Ensure new findings are not overlooked and new deterioration is not missed. Definitive care, transfer to theater, ICU, ward, or other hospital or to trauma center. To summarize, treat life-threatening injuries first. Primary survey repeated multiple times. Early control of bleeding and resuscitation, aiming to prevent coagulopathy of trauma. Early administration of blood and blood products should be considered. Take care of spine at all the times. Thank you very much.
Thank you, Dr. Govil. That was an excellent overview of the management of polytrauma patient. If you have any questions, please put it on the chat box. The final announcement is to refresh your screens so that you can generate your certificates. Please fill up the feedback form so that you can get the certificates. The feedback form is a mandatory requirement for the MMC because they have granted points to this meeting. Please put your questions on the chat box. If there are no more questions, I think I will hand it over to Atul sir for the final comments.
Okay, thank you, Sheel and Amol, for taking care of the panelists and the delegates for 3 days. It was tiring, and I must thank you and the faculty who spent a lot of time with our delegates trying to answer their questions. My apologies to delegates. Some of your questions couldn't be answered, but I'm sure you will get them answered on your rounds in whichever units you are working. All of us wish you the best of luck, and we hope you don't have to attend the next year's BRITE program. Don't worry about the book delivery. I'm sure you will get the books. You can follow up with the email address that was given to you for joining the BRITE course. And all the best once again for your exams. If you have any comments, you can put them in your chat box. I also want to thank the meetings and more guys. Without good support, this webinar would not have been possible. So Girish, Jia, both Rohits and all the team which remains unnamed, thank you very much on behalf of the team, the organizing team from the Tata Memorial Hospital and ISSM Mumbai branch.
Thank you, sir. Thank you, sir. Thank you.
So if there are any concerns, maybe give them 5 minutes, Sheel, to put them to us in the chat box, and then we can say goodbye.
Sure, sir.
Any last minute questions or anything?
So Dr. Hina is asking that will the videos be available to us? So the link will be open for a few days. If you guys have missed a couple of lectures, you can revisit those. Uh,
All right, then. Thank you very much. And hopefully, we'll not see any of you next year. Bye bye. From our team.
Thank you so much. Thank you all, and all the best for your exams.
Bye.
Bye. Thank you.